Good morning. I'd like to welcome you all to the fifth meeting of the National Clinical Care Commission. I'll turn it over to Clydette Powell to do the formal welcome.
Good morning, ladies and gentlemen. It's lovely to have you here gathered for the fifth meeting of the National Clinical Care Commission. We are gathered here on November 22nd, 2019 here in Bethesda, Maryland. And we'll go ahead and get started with our designated federal officer, Linda Harris.
Good morning, everyone. We'll begin with a roll call. I will state your name, and if you would please just recognize yourself and tell us where you're from. Ann Albright.
Here, CDC.
Howard Tracer.
Howard Tracer, Agency for Healthcare Research and Quality.
Thank you. Barry Marks.
Here, Centers for Medicare and Medicaid Services.
Naomi Fukagawa, who is being replaced with Pamela Stark-Reed. Pamela here.
I'm Pam Stark-Reed. I'm with the Department of Agriculture.
Donald Schell.
Good morning, Department of Defense here. Donald Schell.
William Chong.
William Chong, Food and Drug Administration.
Aaron Lapata. Ann Bullock.
Hi, Ann Bullock, Indian Health Service.
Barbara Linder.
She is excused.
Captain David Wong.
Here, HHS Office of Minority Health.
Paul Conlon.
Good morning, Department of Veterans Affairs.
Ayatunde Dokan, who is calling in, I believe. Are you on the line? Carol Greenlee.
Carol Greenlee, Western Slope Endocrinology, representing ACP.
David Strogatz.
I'm here, Bassett Healthcare Network, Cooperstown, New York.
Dean Schillinger.
Here from the University of California, San Francisco and San Francisco General Hospital.
Ellen Lee.
I'm here representing the patient voice.
Jasmine Gonzalez.
Here, Purdue University and Eskenazi Health.
John Boltry.
Here from Northeast Ohio Medical University.
Meredith Hawkins, who is on sabbatical. Shannon Itzik.
Hi, Shannon Isaac, nurse practitioner here representing the University of Maryland School of Nursing.
And Sherry Boland.
I'm here representing Metro Health Medical Center and Case Western Reserve University.
Welcome, everyone.
Is Bill Cook here?
Sorry. And Bill Cook.
Yes, I am, Bill.
Okay, sorry.
Hi, I'm with Ascension Healthcare in Baltimore, primary care physician.
Did I leave out anyone else?
And I'm Bill Herman from the University of Michigan. Good. So again, I'm Bill Herman. I want to welcome you all to the meeting. We have a very busy agenda today. We're going to be focusing primarily on social determinants of health. We'll have a didactic presentation from two of the National Commission members, and then we will receive input from a number of federal agencies that are working in this area with programs in this area. I'd like to get started by talking a little bit about a model that we have developed for diabetes prevention and care. Early in its work, the National Clinical Care Commission recognized that in order to develop recommendations to improve coordination, reduce duplication, and address gaps in policies, programs, and research related to diabetes prevention, treatment, and complications within and across federal agencies, it would be important to have an overarching model to guide our deliberations. It quickly became apparent that there was no single model that we could identify to meet our needs. but the elements of a potential model were available through the socio-ecological model and the chronic care model. And this shows a working model that we have developed that has features of both the socio-ecological model and the chronic care model. At the top of the model, under where it says sectors of influence, you can see what is more commonly known as social determinants of health. These involve things like the environment, education, housing, labor, transportation, food, parks, and green spaces. And it's been recognized that these factors are very important both to disease prevention as well as to the treatment of disease and the prevention of disease, related as well to disease risk. These things influence behavioral settings, including the community, the home, the school, and the work site. And together, these with individual factors really have a major impact on the delivery of care and the prevention of disease. Within the level of individual factors, we're concerned about issues related to age, sex, and socioeconomic status, diet and physical activity, psychosocial factors, including stress and trauma, and even genetics. And when thinking about disease treatment and prevention, one is concerned about individuals with the disease, individuals at risk for the disease, community resources, and centrally, the healthcare system. With respect to the healthcare system, we've recognized that coverage and benefits are important. Delivery system design, information systems, and decision support systems to support care are all critically important. If one then thinks about the interaction between the healthcare system and individuals with diabetes, critical issues include access to care, self-management support, health literacy, and disparities. And on the other side, if one considers individuals at risk in targeted prevention of disease, there are major issues related to screening and diagnosis of individuals at risk, prevention including lifestyle interventions, potentially pharmacologic interventions, and even surgical interventions, and self-support management. At the bottom of the figure are elements that we've derived from the chronic care model. And this model basically indicates that the critical features to clinical care are having informed, activated patients within a supportive environment, having a prepared, proactive practice team with supportive community partners. And it's the interaction among those three forces, the patient, the delivery system, and community partners, that leads to proactive interactions and relationships, and hopefully population health outcomes and functional and clinical outcomes. So this is our working model for the Commission. This is still a work in progress, and I anticipate that there will be further revisions to this, and we will actually be seeking input from the Commission members on this. But today we want to start by focusing on social determinants of health. We anticipate that at our next virtual meeting in February, we'll focus more on issues related to the healthcare delivery system. But this is the framework that we hope to use in terms of making our recommendations to improve coordination, reduce duplication, and address gaps in policies, programs, and research within and across federal agencies. So that's my brief introduction. What I would like to turn to now, I guess, is to, do you want to say a few words, Claudette? Were you going to do an introduction? Okay, so Claudette Powell to introduce the meeting theme.
Good morning again, and thank you, Bill. As Bill mentioned, the theme of today's meeting is on social determinants of health. And why did we pick this? Now, Bill has talked with you about the model, and today we're going to be looking at those sectors of influence in that outer ring. And we will be hearing from other federal partners who play, in a sense, a larger role in terms of population health and well-being. So as you listen to presentations from the Department of Transportation, from Housing and Urban Development, from USDA, a perspective about education from CDC, I want you to consider a number of questions. Be listening with these thoughts in mind. First of all, what elements from the model are we hearing in the presentation? And perhaps what elements from the model are missing in the presentation? So look at it from that standpoint. Also, I want you to consider what have we learned about the state of interagency collaboration and coordination in those presentations. In some instances, it may be subtle, and other instances, it may be more apparent. These are the areas where your questions and their answers will elucidate that. Also, how do these federal programs apply to diabetes prevention, care, and treatment? Let's take these broader social determinants of health and see how they are playing a role within the lives of persons with diabetes, families, and the communities that care and support for them. I also want you to think about best practices that we might have heard, or promising practices, innovations, or perhaps things that might spark ideas in that direction as the Commission thinks about its own recommendations. And then what else do we need to learn about social determinants of health and diabetes? So this is a unique opportunity for the Commission to think broadly. We are not sending out formal data call requests to these agencies. So this is a unique opportunity for us to look at the larger context in which people live, move, and have their being. And as Bill had mentioned, we have the day pretty much dedicated to these presentations. The format will be 45 minutes total, and the presenters, either in person or as callers in, will do their presentation, and they can choose to entertain points of clarification throughout, or go through their full presentation and then leave about 10 or 15 minutes at the end for the back and forth that I know the Commission is eager to do with these people. So we will start off by laying the foundation, thanks to two of our Commission members, Dr. Ann Bullock from the Indian Health Service and Dr. Dean Schillinger from University of California in San Francisco and San Francisco General Hospital, sort of lay the groundwork about, what are these social determinants of health, risk factors, things that may impact positively and negatively in our population. So let's go ahead and transition to Dean and to Ann.
Thank you, Clydette, and thank you. Yeah, thank you, Bill. First of all, I want to thank you, Linda, and Clydette for the effort you made to not only invite, but to convince a number of the agencies to present on this theme. It's never easy to do that, and I think we all greatly appreciate the opportunity that you have provided the Commission by allowing us to hear directly from these agencies. I've been asked to speak about the social and environmental drivers of type 2 diabetes. As both Bill and Clydette mentioned, this is relevant to both the prevention and the care of diabetes. And I was asked to pick a few examples of social and environmental drivers, review some of the evidence related to them, and then provide some local flavor by reviewing some initiatives that have taken place where I live in California that may shed light on the kinds of recommendations and the kinds of activities that other sectors may have that relate to the call of our commission. When we're thinking about both the social determinants of health described in the model as sectors of influence, as well as some of the behavioral settings, it's helpful to think about these as systems that operate semi-autonomously, but have strong relationships to government affairs. The educational system obviously can have its impact on diabetes in a number of ways in terms of the literacy gaps that exist, the important role of early childhood education opportunities, how physical activity plays out in the school setting, and the dietary quality. Food systems are absolutely critical. The exposure to sugary beverages, processed fast foods, the marketing milieu, and the pricing and incentive systems that we have in our country, the problem of food insecurity, the access to fresh food, variation across our country, and the absence of meaningful labeling and warnings that can speak to those who are at greatest risk of misunderstanding, all play a role. The transportation system, similarly, is quite important in explaining the diabetes epidemic that we face and can be harnessed to reduce the burden of illness, specifically the lack of active transport that is ubiquitous in our country, the over-reliance on automobiles, the way that suburbia was constructed, the lack of availability of, I think that's walkable spaces, walkability, and then the long commutes that the average worker in America takes all have a role and take a toll. The housing system, specifically the high need that we have, unmet need that we have for public housing, the poor quality of some housing, and the lack of safety related to that housing that makes lives very stressful and very difficult to access healthy resources. The labor system, we all are very familiar with the degree to which our workplaces are primarily sedentary, the unhealthy dietary choices that exist in our workplaces, and then an important set of issues related particularly to lower and middle income families and workers, the lack of quote-unquote living wages in some sectors, inadequate parental leave, which has implications on maternal and paternal child health in a very vulnerable period of time, and the absence of consistent childcare, all have implications in the early years for the developing child, as well as the health and well-being of the parents. The environment and the park and rec systems with issues such as unequal access to fresh water in the United States and unequal access to safe spaces to exercise all also contribute to inactivity and a reliance on purchased beverages, and inconsistent regulatory systems, specifically lack of policies and practices that prioritize and promote public health, so that when decisions are made around policy and practice, public health goals are only inconsistently considered as those changes are made. Something that have been known as health impact assessments are generally lacking when new initiatives are made or when proposed reductions in programs are made. So with that framing, I will move now to some specific examples of two sectors of influence. But before I do that, I want to just stress the importance of the environment as a place which offers individuals and populations either healthy or unhealthy exposures and access to healthy resources. And that construct of exposures is an epidemiologic construct related to risk. And when one thinks about vulnerable populations and tries to define that term, the notion of risk is particularly central. So I just want to provide a definition that we have used in our group and was published in the American Journal of Public Health. Vulnerable populations are subgroups of the larger population that, because of social, economic, political, geographic, structural, and historical forces, are exposed to a greater risk of risks. So they are at greater risk of being in a risky environment with a food desert or unsafe parks to recreate in, and are thereby at a disadvantage with respect to their health and health care. As such, vulnerability is a function primarily of the maldistribution of exposures and resources that populations are subject to. And in that way, altering the distribution of exposures and resources can alter vulnerability. I want to give you a flavor of how environmental concerns, specifically issues related to place, play out in the city in which I live. Just as an example, this is the city and county of San Francisco, and these are the different neighborhoods and zip codes in San Francisco. And this map displays the per capita income. Obviously, socioeconomic status plays out at the individual level, but it's also determined in large part by the choices people have in greater society. And as you can see, San Francisco is a city with unequal distribution geographically of poverty. Poverty here is in the lower, the lighter colors of yellow, and the wealthier incomes are in the darker green. And you will notice that there is a general pattern, the inverted T pattern in our city, that bears the concentration of individuals with low incomes. These are incomes between $10,000 and $27,000 a year in a city which you all know is quite expensive to live in. I want you to remember this pattern of the inverted T. The next map is the soda expenditures per capita in the same city. And as you can see here in dark blue, darker colors represent regions that have very high concentrations of sugar-sweetened beverage consumption. The darkest blue is at the 100th percentile for the United States. The light blue are parks, so they should not be considered here. And as you can see, again, the concentration of sugar-sweetened beverage consumption occurs in the low-income neighborhoods, a consequence of a number of issues related to stress and the immediate gratification one gets, the concentration of marketing activities, both targeted marketing activities nationally as well as very hyper-local marketing activities and access to sugar-sweetened beverages. And then lastly, if we look at the diabetes hospitalization rate, this is for acute hospitalizations for dialysis, for coma, etc., in this city, which, by the way, has universal health care, San Francisco does, you can see that, again, in the darker colors are concentrated in the inverted T, and the disparities in the incidence of diabetes-related hospitalizations among adults here are tenfold between one neighborhood and the next. The neighborhood in which I live in is in a light yellow color, and the neighborhood in which I work, that the hospital is placed in, is in the dark brown, and there's a tenfold difference in hospitalization rates, which is a function of differences both in prevalent disease as well as quality of care, given the healthcare resources that we have to serve a very large population with diabetes and its complications. So the issue of does place matter, and does the concentration of these social vulnerabilities play out with respect to diabetes care specifically? A fascinating study was done by health economist Dr. Sanjay Basu, who asked the question, can area-level social and environmental factors, so measures obtained at the census tract or zip code level, can they predict very poor diabetes control, in this case hemoglobin A1C greater than 9%? And what he found was when combining this with simple demographic characteristics from an electronic health record like age, sex, and race, the area level social and environmental predictors, and I'll just read some of them out to you: the percent who graduated college, the percent in poverty, income inequality, healthy food access. All of these things have been measured in this particular region. This is actually a national study across the nation, and he used a very large healthcare database to obtain the individual demographic information. And what he found was by combining these simple individual level characteristics from medical claims data with area level measures of the social determinants of health, investigators were able to predict whether a patient would have an A1C greater than 9% with greater than 90% accuracy. The area level social variables themselves contributed to over 40% of the explained variation in A1C greater than 9%. This is combined with what we know about from prior research around the study of genetics, which generally explain less than 1% of variation. So, relatively speaking, these social factors are incredibly important, particularly in aggregate, in explaining, in this case, poor diabetes control, which obviously has tremendous implications to complications, which brings us back to the map I just showed you, where we are disproportionately hospitalizing those who live in the southeast corner of our city. So what to do about it, obviously, is why we're all here today. Many of you are familiar with Dr. Tom Frieden's framework for levels of intervention to improve health, his famous pyramid. I don't know why he calls it a pyramid. It's a triangle, but he calls it a pyramid. I want to just mention that the social factors that Dr. Herman mentioned on the outer ring are primarily in the bottom rung of the pyramid, and then my glasses don't go that far. Changing the context for making individual choices, the healthy choices, is the second rung. And Dr. Bullock and I will be focusing on these bottom two. Dr. Frieden's the purpose of his pyramid was to say that those interventions that focus on these lower rungs are the most likely to yield the greatest public health benefit to the greatest number of people. It is not necessarily about efficacy, but maybe more about the effectiveness and the reach of interventions focused there. So what we will be presenting by no means represents interventions at the exclusion of interventions in the higher levels of the pyramid, but we are focusing on the bottom two. The first one, which relates to the bottom level, is educational attainment. And this has been very well studied with respect to diabetes incidence and diabetes control. One of the major mechanisms whereby low educational attainment is associated with poor diabetes prevention and control is through the acquisition of poor literacy skills. We know that limited literacy skills are associated with the doubling of the odds of acquiring type 2 diabetes, that limited literacy is the strongest independent risk factor for sugar-sweetened beverage consumption. I just want to give you a sense of the scale of this problem. A study evaluated the relative impact of low literacy compared to other sociodemographic and behavioral factors on sugar-sweetened beverage consumption. And in comparing the individuals with lowest levels of literacy to those with highest in multivariate models, the difference in daily consumption of sugar-sweetened beverages was 240 kilocalories a day, which is 1 16-ounce bottle per day, which is 12 teaspoons of sugar per day, which in and of itself, that difference, which obviously doesn't represent a person's daily caloric intake, it's just one drink, exceeds the total max daily amount of added sugar based on the U.S. dietary guidelines, which is 9 teaspoons per day for a male and 6 per day for an adult woman. So the mechanisms whereby limited education play out with respect to diabetes are multiple, but this may be an important one. We have shown that limited literacy skills are both strongly associated with worse diabetes control. Here, the A1C is 9.5%. Again, this is an independent risk factor, independent of other confounders. And not surprisingly, with that A1C difference, we observed a near consistent doubling in the in the prevalence of diabetes complications, including micro and surprisingly macrovascular complications. So educational attainment in and of itself, when it is accompanied by adequate literacy levels, appears to be a buffer protecting people from acquiring diabetes as well as its complications. Food systems is the other example I will give, which represents the second to bottom rung in Dr. Frieden's pyramid about changing the environments to enable people to have the healthy choice be the easy choice. And I'm going to talk about food and beverage pricing, food insecurity, added sugar consumption, and retail food environments. A fascinating graph, again published by Dr. Frieden, related to the price of foods in the United States over time. And I want you to first, this starts, I think, in the late 1970s, I can't quite see, and ends in 2009. And I want you to first see the monotonic line in black, which is the consumer price index. That essentially is the cost of inflation, if you will. That's how much things cost over time just because of inflation. And as you can see, when you compare that line to the lines related to healthy foods, such as fresh fruits and vegetables, or unhealthy foods, processed foods, particularly those with added sugars and carbonated drinks, the relative difference in cost over time has amplified exponentially, such that living on a low income in the late 1970s, in terms of its implications for dietary choice, compared to living in a fixed income in 2009, will generate extremely different patterns of dietary quality just from economics alone. And there's been a lot of discussion about the causes of these disparate curves. And as you know, one of the more important hypotheses is the initiation of subsidies for particular products that lead to calorically dense foods, relative to the absence of subsidies for those that lead to healthier products such as fresh fruits and vegetables, contributing to the lower cost of unhealthy foods and the higher cost of healthy foods. Not surprisingly, in light of that graph, we have seen an explosion in food insecurity in the United States, and an increase over the last 5 years in our understanding of the relationship of food insecurity to diabetes incidence and complications, control and complications. In the general population, which is what our subcommittee is concerned with, food insecurity is associated with a between 1.5 and 2.5 greater odds of acquiring type 2 diabetes. This is particularly true for those who have severe food insecurity. Now, among the population with diabetes, being food insecure is also associated with about a doubling of the odds of having poor diabetes control. This is an A1C greater than 8%, again, independent of confounders. Interestingly, among food insecure patients with type 2 diabetes, receipt of SNAP benefits, formerly known as food stamps, appears to be protective with respect to the relationship between food insecurity and glycemic control. Among those with type 2 diabetes, food insecurity is also the most robust predictor of hypoglycemia among people treated with any form of hypoglycemic medication. And this is a significant patient safety concern that I'm sure the patient diabetes care subcommittee will be also addressing. But this hypoglycemia has also become a public health issue because of the impact it has on acute care hospitalizations as well as motor vehicle accidents. Why does food insecurity lead to difficulties in diabetes management? the cyclical nature of food insecurity, where people may get their check in the beginning of the month, be that an entitlement check or a check from one or two jobs that they are working, leads folks to consume disproportionately cheap and calorically dense foods, sort of binging in the context of having recently been under food scarcity. We know from studies from war settings and famine that when you have been exposed to food shortages and food becomes available, one overeats and overeats certain kinds of foods. And then in the final 2 weeks, as food becomes short, people begin to cope by skipping meals, reducing caloric intake, and experiencing hypoglycemia. Now, if the patient happens to come to see the doctor, the endocrinologist, in week 1.5, and their blood glucose is 413, fasting blood glucose, we tend to increase their insulin dose, and because we don't want to be subject to clinical inertia, and it can lead to a vicious cycle of hyper and hypoglycemia. The next area in the food system I want to talk about is the retail environment, the access to healthy foods in neighborhoods. This has been best studied by a metric known as the Retail Food Environment Index. That sounds fancy, but is quite simple. It's a simple ratio of the number of unhealthy vendor outlets like fast food restaurants and convenience stores in the numerator, and the number of healthy grocery stores and fresh produce vendors in the denominator. So obviously, if you live in a neighborhood with a low RFEI score, that is a healthier environment than if you live in one with a high RFEI score. So high score, theoretically bad. A study in California showed that high-income communities have an RFEI score of about 4, so there's 4 unhealthy outlets for every one healthy, and in low-income communities, it's nearly 5. The relationship between the RFEI score and diabetes prevalence is monotonic. Those who are fortunate to live in an RFEI score below 3 have the lowest prevalence of type 2 of diabetes, and those in the highest scores of 5 or higher have the highest prevalence. Reminder that the low income have an RFEI of 4.9 on average. Now, this is true even within low income communities. So if you are a low income individual living in a low RFEI setting, your hemoglobin A1C on average is going to be significantly lower than if you're a low income person living in a high RFEI setting. So at least with respect to this study, the retail food environment appears to be associated with poor glycemic control. Part of this retail food environment has to do with the amount of added sugars that we are exposed to. This is another phenomenal study done by Sanjay Basu, the health economist, that studied every nation in the world with respect to the change in added sugar consumption that their populations were exposed to over a 10-year period of time. And what he found was a linear relationship between the relative change in added sugar consumption over time and the increase in diabetes prevalence in that nation over time. In fact, the only factor, even after adjusting for a wide range of economic measures of development and success like GDP and other economic indicators, and even after measuring changes in other nutrient intake, the only independent factor, fraction of calories from added sugar, was the only food fraction correlated with diabetes prevalence. He found with a 1% rise over time in the fraction of total food calories as sugar corresponded to a 0.2 rise in diabetes prevalence. We often forget what it was like to live in the United States in 1950. This again relates to the exposure we have to added sugars. This here is just the example of sugar-sweetened beverages, and specifically soda consumption. Back in the great days of the 1950s, the Eisenhower era, the average American drank about 12 gallons of soda per year. That has steadily increased till the year about 2000, where the average American is drinking 53 gallons of soda per year. This does not include powdered drinks, the ones I grew up on. What are they called? What is it? Kool-Aid, thank you. Things like that are not included. As you can see, a downward trend as the science and public health messaging became more clear. The U.S. population has begun to reduce its consumption back to kind of the 1990 levels. This is just a display of the gallons that we've been drinking annually. And interestingly, if one graphs diabetes prevalence relative to this increase, obviously this is not causation, this is a simple two graphs put side by side, you can see a steady increase in the prevalence of diabetes, right shifted relative to the prevalence of high consumption of added sugars. Now, this is prevalence. Dr. Albright's group has recently published very, very exciting news. For the first time in a very long time, we have seen a significant drop in incident cases of diabetes, quite significant. And one could hypothesize that at least one factor explaining that drop, in addition to the national DPP and other kinds of programs that have been initiated, has been the significant drop of added sugar exposure in the United States that we have experienced recently. Okay, I want to, again, keeping in mind Dr. Frieden's pyramid, I want to give, as I was asked, 4 examples from California of concrete, tangible policy and practice initiatives happening at the local level that impact that second tier, which is changing the environment, not changing the root causes of socioeconomic factors and poverty and stress, but changing the environment's one level above in the pyramid to make the healthy choice the easier choice. And I'm going to review recent work, including a workplace-based disincentive to consume sugary sweetened beverages, a municipal excise tax that has been levied on a number of cities in the San Francisco Bay Area, the reinvestment of those funds, those revenues from taxes, into fresh fruits and vegetable vouchers, and lastly, a regulatory policy related to warning notices on sugar-sweetened beverage advertisements. Just by way of example, a large employer in San Francisco that employs nearly 25,000 individuals 4 years ago instituted a sugar-sweetened beverage ban on its campuses. And some investigators followed this cohort over time and found that on average, the daily consumption went from about a liter of sugar-sweetened beverages a day to a half a liter of sugar-sweetened beverages a day. That is 32 ounces to 16 ounces. That's that same 240 calories that I talked about when I talked about limited literacy. These individuals also investigated the changes in metabolic health in this cohort. This is only a 6 and 12-month study, and while they found no changes in body mass index, they found significant reductions in waist circumference and sagittal diameter. The aforementioned Dr. Basu has also done a health economics analysis and found that not only is this intervention cost effective, but it actually is cost saving for the employer in terms of deferred dental and medical costs over a 10-year time period. This includes the loss of revenue that they may experience by loss of sales of sugar-sweetened beverages. That was taken into account. Now, excise taxes on sugar-sweetened beverages are spreading throughout the world. The United States is somewhat of an outlier in not having them, although there are municipalities and the Navajo Nation reservation that are examples of excise taxes on sugar-sweetened beverages. And I want to share with you the results of the evaluation we just completed in Berkeley, California, which has a penny per ounce tax on sugar-sweetened beverages. Estimates with respect to price elasticity of sugar-sweetened beverages generally suggest that about a 20% reduction in consumption is what one could anticipate in the absence of any reinvestment of those funds into other health promotion activities. Berkeley has been very active in reinvesting funds in health promotion at the local level, and they, over 3 years, have experienced a 52% reduction in sugar-sweetened beverages from a penny per ounce tax, including reinvestment into community programs. As you can see, this was a fairly consistent drop across sugar-sweetened beverage subtypes, and it was associated with a higher consumption of, in this case, purchased bottled water. And I can tell you that there were no changes in the prices of foods and beverages that were not meant to be taxed, which is an important finding. Colleagues of mine in California modeled, even prior to this tax being implemented, how many cases of diabetes would be prevented over 10 years if the state of California introduced a penny per ounce tax under a number of assumptions. The first assumption is the 10% reduction, the second assumption is the 20% reduction, and the last is the 50% reduction under various assumptions of caloric compensation. I will just tell you that the numbers range between 20,000 and almost 100,000 new cases of diabetes would be prevented in these modeling exercises. And these are very conservative measures based on caloric compensation. The benefits in terms of reduction are they found disproportionately borne by those populations who disproportionately have type 2 diabetes: African Americans, Mexican Americans, and low-income individuals in California. Finally, I want to share with you an unsuccessful initiative, although the city is revisiting this. This relates to the marketing environment, particularly in low-income communities. On the right, you see a billboard, Unidos por sed de fútbol, which is basically we are united for our thirst of football. This is a widely disseminated sugar-sweetened beverage advertisement related to the World Cup. And the city of San Francisco in 2015 passed an ordinance requiring a warning label on advertisements for sugar-sweetened beverages, saying that consuming these beverages can contribute to cavities, obesity, and diabetes. This is a message from the city and county of San Francisco. This would have been the first public warning in the world, and the American Beverage Association successfully, they sued the city and county of San Francisco in a federal court because it was a freedom of speech case. The city won that case on the grounds that there is significant science to support causal relationships, but then on appeal, the American Beverage Association won the appeal based on a decision that the warning notice is too large, that it represents 20% of the ad, and warning labels such as the U.S. Surgeon General label for tobacco is on the order of 10 to 15%. So I believe the city is going to go back, despite the legal expenses, and try to make the warning notice smaller. But the main issue I want to raise is that the general public, still many of them are unaware of the unhealthy nature of sugar-sweetened beverages, and that warning notices can be effective. Finally, with respect to reinvestment of excise tax revenue or a revenue from other means, San Francisco and now Los Angeles have introduced a very significant vouchers for veggies program. This is simply giving $5 of money specifically and only to be redeemed for fresh fruits and vegetables to low-income individuals for long periods of time. And the vendors who participate in the program, for every $5 redeemed, they receive $5.50, incentivizing local corner stores to stock fresh fruits and vegetables. This is a triple win, supports healthy eating, increases food security, and drives the supply of fruits and vegetables into underserved neighborhoods that often, as you know, don't have a healthy retail food environment. So far, after 2 years, voucher redemption rate has been over 75%. Nearly half of participants have increased their food security status, and most importantly, there has been exactly a 1 serving increase in fruits and vegetables consumed per day by these individuals. This is not quite the 5 servings per day that the U.S. dietary guidelines report, but is higher than the average intake of the average American citizen. To date, they have served over 11,000 individuals and 6,000 households. There are 70 community distribution sites. These are vendors who are participating. The vendor network includes 30 convenience and corner stores, and $1.5 million has been infused into these communities as a result of these vouchers. And now, with that, I will pass it on to my colleague, Ann Bullock, who will speak more about the lower rung on the pyramid.
Hi, everyone. Dean had so many good slides. I'll have to try to rush a little, but we'll do what we can here. So, as Dean said, he has talked about the second to bottom rung of that pyramid, primarily on how can we make healthier choices available and affordable and all those kinds of things for folks who are low income and have many challenges. So I want to talk a little bit then about the bottom, the fundamental, the base, if you will, as I'm going to make the argument, the causes of the causes, which are social determinants. According to the World Health Organization, the social determinants, and Dean talked about this some, are the conditions in which people are born, grow, live, work, and age. And these are primarily what is responsible for health inequities, both within and between countries. It matters hugely, the environment in which we find ourselves. So I'm standing up here because I know it's hard to look at a speaker sitting there and look at slides at the same time. And the print on those printouts are small, and my slides aren't in there because I finished them at 7:20 this morning. So anyway, there's an overlapping issue in addition to social determinants, the usual things Dean talked about, transportation and poverty and all of those other kinds of things. But there's this whole other area that overlaps with it, but has its own life as well, and that relates to chronic stress, some of which relates to, of course, social determinants, but trauma and the related topic of adverse childhood experiences, which social determinants absolutely make all of these worse and increase the likelihood that they'll be transmitted between generations. So when we talk about those, I'll be talking about the traditional 10 ACE categories, which I'll show you in a few minutes if you're not familiar, but also way beyond, to include racism and discrimination, exposure to community violence, neighborhood quality, income, and wealth. Of course, income is one measure of what people have for resources, but wealth is a better measure because it looks at the resources you have beyond a paycheck. Many people in this country may make it on what they earn, but they're one paycheck away from disaster, basically, because they don't have wealth, savings in order to back up those times. So it's important to realize that for both social determinants and also this stress trauma continuum, that the effects are mediated through health behaviors. And unfortunately, sometimes we turn that around to blame the victim and say, well, poor people should just, be smart and not smoke and not drink and do those things. But in fact, these are adaptive coping strategies, as we'll talk about, including overeating. When you only have foods of poor nutritional value, we have a lot of high calorie, low nutrition obesity in this country. So that when you eat foods of poor nutritional quality, it's another stimulus to overeat. And so when you may not go to bed hungry, but what did you fill your belly with? Foods of low nutritional quality, the body knows you have to eat more of them to get what little good stuff is in there. In addition to the fact that they taste good and they lower your stress hormones and all these other things, and they're more affordable, on the shelf stable, and all those kinds of things. It's a perfect storm. So even health behaviors are hugely related to social determinants and stress and trauma, but they're also directly biologically embedded. I'll try to make the case here. It's also important to remember that we in healthcare think about individuals a lot, the patient sitting in front of us. And these things affect individuals, of course. But when we're going to try to look at these bigger, broader, deeper things that affect health, we need to look at the population level. Because not only is that where a lot of these things are mediated, but also because when we do interventions, we're going to see effects across populations if we're successful that will have huge impacts. So while it's important to connect individuals to services, if someone doesn't have gas money or time off from work in order to get to a medical appointment, it's awfully important to connect those people to those resources. But isn't it even more important that we work on family leave and parental leave, to work on living wages and all the other things that would no longer make it necessary for you to have to connect that person with a particular service and the stress that they have as a result of them. So that looking at the benefit that would come from improving the context in which populations live. And the stressors that affect people and populations are important no matter when they happen throughout life, but they're especially impactful in the life course when they occur in the in utero and early life phases of development because they become more deeply biologically embedded and have lifelong impact. And that's an important thing to remember as we think about where to put emphasis and where to put resources. And of course, now there's lots of evidence for intergenerational transfer of risk through a number of mechanisms. Yes, epigenetics is one of them, and that's an area of huge research and interest. But there are many other mechanisms as well that both behaviorally and biologically transfer risk through generations. So for diabetes, we've been thinking that it's been caused just by genetics and lifestyle choices. That's been the model we've had for many, many years. It's what I learned in medical school, and probably many of you did too. And focusing completely on the individual, your genetic risk, and your lifestyle choices. But of course, we know now that model needs to be expanded, especially on the genes. And Dean did mention this, that genes are actually a very small proportion, and we're talking about type 2 diabetes here. The proportion of predisposition explained is very small, relatively speaking, for genes. And it absolutely does not explain disparities in populations. So while it may, genetic risk may be a little bit larger in one person or family if they happen to have inherited more of the risk genes for diabetes, but when you try to explain disparities in diabetes across populations, genes are absolutely not the answer. So we also know, as I mentioned, that lifestyle choices are hugely impacted by social determinants and stress and trauma, and diabetes risk, as mentioned before, is directly biologically embedded, especially in early life. So this is a paper that I think we sent around a few months ago to the commission, and this is looking at a large study, looked at 18,000 adults, and it was a dose-response association between the number of the risk factors I'm about to show and onset of diabetes over the next 3.5 years. So this was prospective and looked at what would predict who would get diabetes, and they're not the usual list of things that we're all used to thinking about in terms of diabetes risk. It was having less than a high school education, having financial problems, being alone, single or separated basically, high stress of whatever type, dealing with intermittent partner violence, concentrated neighborhood poverty, so that idea of place that Dean talked about, depressive symptoms, and smoking. So in terms of our usual array of health behaviors, smoking would be the only one on that list. And of course, smoking is associated with lots of stress reduction, coping kinds of things as well. So when we think about what predicts diabetes, when we get down to some of the causes of the causes, we're looking at these kinds of lists, very much all about social determinants. I'm going to blitz through this because Dean covered all of this, except to say that if you take two people with a 2,000 calorie diet each, and one gets their calories from healthy foods, fresh fruits and vegetables, and all that array of healthier foods, and the other gets it from what's available in the corner store that's shelf stable, cheap, and tastes good, and helps reduce their HPA axis stress hormones and all those kinds of things, the weight gain will be a difference in the weight status for those people, even with the same number of calories. Diet quality does matter. The person who gets it from the higher simple carbohydrate, higher fat is going to, partly because of insulin response, gain weight where the other person may not. So when we think of just calories in, calories out, and it's all the same, it's actually not. Diet quality as well as diet quantity matters hugely. And why do people overeat when they're stressed? Well, carbohydrates actually affect brain serotonin levels. So when you're dealing with a lot of stress, having that kind of food is actually a little mini Prozac shot for you, helping you to feel better. And high-fat, high-calorie foods actually decrease the HPA axis stress hormone response. So in the short term, these foods not only taste good, they're cheap and available and affordable, but they actually truly do make you feel better. And when you're dealing with a lot of stress, you're going to get more, comfort from those kinds of foods than from broccoli. So, and then, as I made the case before, what happens early in life is absolutely critical. As the American Academy of Pediatrics said, many adult diseases, including diabetes and heart disease, should be viewed as developmental disorders. I really want to say that one again. Diabetes is a developmental disorder. That means it happens because of what happens while we are developing. And that means what happens in utero and in the womb. That is not what I learned in medical school about type 2 diabetes. And probably you guys didn't either. And they go on to say that persistent health disparities associated with poverty, discrimination, or maltreatment could be reduced by the alleviation of toxic stress in childhood. So, I mean, there's a lot packed into that statement. So, just want to quickly go through that because they're saying this is fundamental to what's happening with chronic disease in this country, is what happens early in our life. So, the concept of trauma itself, stress is something we have to respond to. If it just kind of comes and goes, a little cortisol to help us get a little blood sugar up in order to be able to have the energy to deal with that stress, that's a good thing. A little increase in adrenaline to give us a little extra oxygen pumping throughout our system, that's a good thing. And as long as it kind of comes and goes, the body is absolutely able to adapt to that. I mean, it works. But when those pathways are turned on constantly, there's a price to pay for having cortisol always suppressing insulin secretion from the pancreas, always increasing insulin resistance, the level of the fat cell, and having the liver continue to churn out glucose. There's a price to pay for that. There's a price to pay for having adrenaline or epinephrine constantly surging through your system, increasing your blood pressure and your heart rate, even in times when that's not going to help you run or fight or whatever with the fight or flight response. So having those pathways continually turned on pays a price that has sometimes been called allostatic load, and over time creates chronic disease. Diabetes is really, type 2 diabetes is really in many ways the natural outcome to lives led from chronic stress. So when you add on to the idea of stress, the idea of trauma, which is in my own simple definition, anything that overwhelms that ability to respond, especially if what is overwhelming us is something that we perceive to threaten our life or things that support us physically or emotionally. So we sometimes talk about being overwhelmed by too much work. For the most part, it's probably not traumatizing, although for some of us type A folks, it might be a little bit. But for having things that, in our lives that if we're 2 years old or 3 years old and our parents are screaming at each other, that can be very traumatizing because we're dependent upon those people in order, for our very existence. It may not be the same when we're, 20 or 25, but when we're young, our ability to take care of ourselves and perceive things is very different. And this can cause lasting changes in the brain and body because of that constantly turned on stress response. And then any later experiences which remind the brain of that traumatic event. Things, it might be people screaming at each other, but it could also be a tone of voice or a facial expression, all kinds of things that if you've had a lot of trauma, you go through life and you're being triggered because the amygdala is picking up on sensory input in the current environment, whether it's associated with something dangerous or not, that reminds it of that previous traumatic event. So it's turning on that stress response over and over and over again, even when you're not otherwise in a stressful situation, if it's perceiving that something in the current environment is reminiscent of the past one. I hope I'm saying that clearly because this is a really, really important point. So if you've had a lot of trauma, especially early in life, that is so programmed into your amygdala that you're going to see, your brain sees threat or things that are scary or whatever all over the place, even if the situation you're in isn't necessarily threatening at the time. And so that, of course, not only does that have effect on your mental health, because that's awful to have those emotions and that sense of stress come up constantly, but it's also takes its toll biologically. And when these things happen during the development of brain and body, that's why toxic stress is something we talk about, especially in children, but it's also being talked about for adults. When stress is chronic and unremitting, and you have no or little control in order to make it better, then this response just keeps running out of control. Cortisol, adrenaline, over and over and over again, affecting glucose metabolism, affecting cardiovascular health throughout life. And then this particular form of trauma that has been called adverse childhood experiences increases risk at any level. It's a graded dose-response relationship, as we'll see. Many people are familiar with this. The original papers, ACE papers, came out in the late 90s. 20 years later, we're still trying to figure out what to do with this because it's so deep and it's so profound and affects, really gets at who we are as human beings, right? Because nobody gets out of childhood without some sort of trauma. Something, I don't care how good your childhood was, something happened that overwhelmed you and you didn't have the ability to understand. A lot of times it can actually be from medical care. A kid falls down, gets a big old cut, has to be taken to the ER and held down, lots of pain and blood, and they don't understand what's going on. That can be traumatizing. So even things that in good families, quote unquote, trauma happens. But of course, adverse childhood experiences are incredibly more prevalent in this 10 categories than we ever thought until this original ACE study and subsequent studies came along. So they looked to see about 10 categories of adverse experience: physical, emotional, or sexual abuse, growing up with a substance abusing, mentally ill, or incarcerated family member, ever seeing your mother beaten, and then 2 categories of neglect: physical and emotional neglect. And the ACE score, so to speak, was not the number of experiences, it was the number of categories that you had experienced. So an ACE score of 4 or 6 means 4 or 6 of those categories happened to you. They may have happened many, many, many times, but it's the different categories that was actually studied to create the ACE score. And we know from the original ACE papers and subsequent ones that almost any health or behavior outcome or life outcome that you care to look at, the higher your ACE score, the more likely you are across populations to have issues. So as you can see, this graph on the right, just looking at and showing the stair step of, if you look at the health behaviors, the more likely to smoke, to drink, to use drugs in that stair step way. The higher your ACE score, the more likely you are as an adult to do that. Why would you drink more as an adult if you had difficulties as a child? Well, that continuous turning on of those stress hormones, it feels awful to have adrenaline, epinephrine going through you imagine what that's like, if you have that feeling constantly. You'll do whatever it takes to make that feel better, and alcohol works. People don't do what don't work. It's a matter of what you're trying to accomplish. So when we look at health behaviors, they are coping strategies to deal with what it feels like to be dealing with past and current stressors and trauma. This is a really profound thing because so much of our health education is really kind of a shame and blame kind of thing, when in fact, what we're looking at are people who are trying to deal with the effects, the cumulative effects of stress and trauma and adversity over the lifespan. So, why do people smoke more? Well, nicotine not only calms you down, but it makes you more alert. Sign me up. I love that. Right? How great is that? And when you're dealing with how that feels, you'll do whatever it takes to feel better right now. And the fact that some nice health educator told you that in 20 years, that means you're going to get some bad disease called diabetes or heart disease, that 20 years later may take you out of this painful life a little sooner. Really? That's an incentive to quit? Not so much. We have to understand what we're dealing with. And we'll talk in a minute about how, and as I talked about with food actually a few minutes ago, how it affects stress hormones, how it affects brain serotonin levels. When I feel that bad, I want to feel better right now because it feels terrible right now. And that's a lot of what we're seeing when we look at overeating, in addition to all of the other food availability issues. So, so health issues, if you hold health behaviors constant, you still see the stair-step risk factors for all kinds of things, including diabetes. The higher your ACE score, the more likely you are to have diabetes. And then the big things in life potential, whether you are able to get in school, stay in school, pay attention in school, whether you're able to get a job, hold a job, whether you're able to bond and attach to other human beings. The most fundamental things in life are all related to the amount of trauma we had as children when the brain is developing those capacities. The current issue of the CDC Vital Signs is all about adverse childhood experiences. Melissa Merrick and her colleagues have written the MMWR on that. I encourage you to look at it. And a number of articles are in JAMA and JAMA Pediatrics this month, all related to adverse childhood experiences. And the other thing about ACEs is that they're common. About 2/3 of people in the original ACE study had it, and that and the thing I mentioned in the current Vital Signs, it was similar. About over 61% in that Burfus study said yes to at least one type of ACE, and 1 in 6 said yes to at least 4. So ACEs and diabetes, in the White House study of social servants in Great Britain, for every additional ACE you add on, increase the risk of developing diabetes by 11%. And then looking across countries, different kinds of studies, adults who had at least three childhood adversities, the hazard ratios for diabetes and heart disease are there, more than double the risk for heart disease. And for heart disease, the risk is similar to the association between cholesterol and heart disease, both in terms of the magnitude of it, as well as in the population prevalence. So its effect is huge. A different Bertha study looked at ACE prevalence and how high it was there, and the risk for diabetes, hypertension, and lipid problems increased. Again, in a dose-response relationship, that strong graded relationship. And this was independent of ACE's effect on their health behaviors. It's just directly biologically embedded. So early experience, this is a wonderful National Academy of Sciences report that just came out, has a tremendous amount of literature on this whole issue of what happens early in life affecting us for the rest of our lives. And as they said, early experiences and life circumstances shape prenatal and early childhood development with powerful impacts in the developing brain and body that shape health outcomes across the life's course and generations. This is powerful stuff. So prenatal risk factors, I don't have time to go into the rich literature and all of this, but high levels of racial inequality and socioeconomic inequality increase the risk of being born small for gestational age. Before 36 weeks is preterm, and small for gestational age, of course, is average weights of children born at different gestational ages. And when racial and socioeconomic inequality co-occur, that risk of SGA birth goes up considerably. Similarly, maternal stressful life events in the first trimester, before a lot of women even know they're pregnant, increase the risk of preterm birth almost 2.5 times. Well, why am I mentioning it? It's because being born small and or early are strongly associated with later risk for diabetes. These aren't little things. These mean that something's going wrong in utero that will have health consequences for the rest of that child's life. So what happens in the womb, hugely impacting life course issues, including diabetes. So how does it all get programmed in? And I know we're real short on time here, already behind. With stress and inadequate nutrition in the womb, mom eats about half of the building blocks, nutritional building blocks, that's going to go into that little fetal body before she even conceives. So nutritional quality of young women is hugely important. There's actually evidence from an epigenetic standpoint that may also be true for young fathers. But the other half of nutritional building blocks mom eats during pregnancy. So if you have enough nutritional building blocks to build healthy brains and muscles and organs, that's a good thing. But if you don't, you may or may not have enough calories, but if you don't have enough of the other nutritional elements, then some things can happen. And also, if mom is dealing with a lot of stress, there's an enzyme in the placenta that will buffer the ups and downs of mom's stress hormone levels. But if mom has some of those stressful life events, like we just saw on the last slide, something big, maybe domestic violence, or some other kind of thing, and the stress hormones are huge, or she herself has had adverse childhood experiences and her set points for these things are already through the roof. She's already pre-programmed to hypersecrete stress hormones. That does cross the placenta and affects the developing fetus in some really important ways. We know that epigenetic on-off switches absolutely are affected. The extent to which this is true is still being studied, but we know that this is an element of it. And it alters directly fetal development. If you don't have enough nutritional building blocks, the first thing that gets short shrift is muscle development, skeletal muscle. So you'll actually have less skeletal muscle development. Well, what's the problem with that? Well, that's where about 60% of glucose is burned in the body, is in skeletal muscle. So if you're already starting out with less of that, you're already going to have more trouble with glucose metabolism throughout your life. If you have even less nutritional building blocks, and again, this isn't calories, it's nutritional quality here, you actually will have fewer cells in the pancreas, including beta cells. You will have fewer nephrons in the kidney. So we're already setting up for diabetes and its complications in the womb if there's not enough nutrition. That's pretty profound stuff. I mean, that we think of that as being so distal to this kind of thing, so far removed and unrelated, but it's absolutely related to what happens so early. And if you have overall even less nutritional building blocks, you have a small for gestational age child, and that's where we saw why that would be true for increasing risk for chronic disease later in life. This is big, and we see this a lot. With mom's stress hormones crossing the placenta, it affects the set points for developing hormonal systems, including those that regulate appetite, glucose, and stress response for the rest of that child's life. And because insulin resistance and visceral fat, all that cortisol that's crossing the placenta from mom is actually leading to visceral fat deposition in utero, you can actually have a child with all of these issues going on. They may be normal or even large for gestational age. It's not because their organs are well developed, it's because they already have visceral fat laid down. And that's been shown in studies as well. So in the first few years of life, you can add to that then stressed parents unintentionally transmit trauma to their children through ACEs and similar things. This continues to ramp up those set points in children for stress hormones and others, and it feels bad to do that. So again, the risk for using external substances to help modulate our emotions and our physical feelings goes up. So that goes up, increases the risk for smoking and drugs and alcohol, but also food intake, including the less healthier versions of things, because that helps us to externally modulate those kinds of things when we've been dealing with that kind of adversity. So stress also affects brain development. Cortisol actually reduces the hippocampus and the prefrontal cortex and increases the amygdala over time. That and another hormone called brain-derived neurotrophic factor will both increase the likelihood that amygdala, which is checking out for trauma wherever you look, is going to be hypersensitive to things. So all of this just keeps coming together in the perfect storm to create risk for problems later in life. Dean talked about food insecurity. In addition to what he said, it alters appetite regulation, especially when it happens early in life. Children who go through having food and not having food cycles often have a lot of difficulty. That becomes a traumatic association in the brain. Being hungry means I may starve, so I can never be hungry, so I have to keep eating. That's something now that may or may not be a conscious thought, but it is in the amygdala, which doesn't care if the conscious brain is on track or not with that. So as the American College of Cardiology was saying, psychological distress at any point in life course associated with higher cardiometabolic risk. Even if things seem to get better as we get older, okay, right? You're born into a bad situation, but now you're older and things are better. But what got programmed in early still affects your health risk later. So that that heightened risk of cardiometabolic disease risk remains. Early emotional development is a target for actual prevention of lifelong cardiovascular and metabolic health. Let's say that again. Early emotional development should be a target for what we do to prevent diabetes and heart disease. So what do we do? So here's a few examples, and this just was published online the other day. A nationally representative survey of parents of children in this country, children under the age of 18. 2/3 of them reported that they had at least one social determinant of health-related factor that was a barrier to their children's health, not just their health care, but their health. 1/3 said they didn't have enough money to pay a bill. Another third said that they had to skip a medical or dental appointment because they couldn't afford to pay for it or the copay or whatever they had to do. 1/4 of them said their family was food insecure. I mean, this is profound. These are huge. This is incredibly prevalent. And the Neighbors Health Corporation or health system that sponsored this, the CEO, in an accompanying letter related to this report, pled for, was citing that only 15% of health relates to health care. The other 85% are all these other things. So we have to affect the other things. So he was making the case that we should be switching from fee for service to a per capita value-based system that pays people to keep people healthy, keep kids out of the hospital. And that means you're going to have to deal with all those social determinants. And he's saying, please pay us to do that. Please pay us to make that make sense so that we can afford to do that. And he cited the asthma literature, which has shown that this sort of thing reduces asthma hospitalizations by 40%. That's a lot of money. And he also was pleading that just as we put money toward medical care, we should be putting the same amount of funds toward addressing social determinants and cross populations. So you got healthcare systems people saying, let's do the right thing here. We can't keep treating disease in the context of all the things that are making people sick. In terms of other things in home visiting, it has some evidence. Home visiting has some evidence. Many are familiar with the Nurse Family Partnership, David Old's program that's been studied in 3 randomized controlled trials and shows positive effects decades after children whose moms receive this extra support during pregnancy and early life. The Family Spirit Home Visiting Program is one that has evidence in American Indian communities that actually reduces both substance abuse-related and obesity-related risk factors in children. And another one called Minding the Baby that Yale University developed and studied significantly lowered the rate of obesity in New Haven being New Haven. Yale sits in the middle of this, unfortunately, living laboratory for adversity and poverty. So they looked at this and found that their home visiting program significantly lowered the rate of obesity in low-income 2-year-olds considerably, as you can see there, including in Hispanic kids. So it also affected minority kids in a really positive way. Supporting moms, helping them to have resources and support at this critical time during pregnancy and the early life of their children is just critical. And yet, so often these young women don't have enough food resources or other types of support, and it has consequences for them and for their children throughout their lifespan. This is looking at quality childcare. Some of you may be familiar with this. James Heckman, the Nobel Prize-winning economist, is the first author on this paper about the Carolina Abecedarian Project. This was a study with 4 cohorts of kids born in disadvantaged areas around in Raleigh-Durham, North Carolina in the mid-70s. The intervention was provided from birth to age 5, and the intervention consisted of really high-quality childcare where the teachers did a lot of one-on-one work with kids specifically trained to help them develop language, emotional self-regulation, and cognitive skills. They did some parenting interventions, bringing parents in to help them learn how to interact well with children. If you didn't get good parenting growing up, you're not going to be able to give it. It's just the way it works, unless you're really taught something, not with a brochure, but shown another way. So they bring parents in and help them to learn how to interact better with their children. They took care of food insecurity by providing 2 meals and a snack at the child care center, and they provided primary pediatric care. Flash forward to these kids being in their 30s, and they had lower prevalence of heart disease and metabolic risk factors, including blood pressure, A1C, and obesity, and better HDL cholesterol. So what happens early having profound effects on disease risk factors throughout life. These next 2 are in my population because with Indian tribes being able to go into compacts with their states so they can have gaming enterprises. It provided opportunities for natural experiments to look at what happens when you increase income in these kinds of populations. And in one that actually in North Carolina, studying at the eastern band of Cherokee, the longer children were exposed to income supplements that came about after the casino opened in Cherokee, the lower rate of psychiatric and substance use disorders these kids had as young as adults, following them up 20 years. And then in California, in tribes that opened or expanded a casino during the study period, every slot machine per capita, now there's a unit of measure you don't hear very often, was associated with a $541 increase in per capita annual income, and also decreased the probability of overweight and obesity in the kids. So what happens at that macro level, at the economic level, having health effects. We know that SNAP, Dean talked a little about SNAP. Studies have shown that SNAP participants have improved nutrition, reduced food insecurity, better health, lower healthcare expenses, and children with access to SNAP not only do better in childhood, but they also in adulthood. Adults who were low income as children and had SNAP benefits have less obesity than adults who were low income as children and did not have SNAP. Anytime we make decisions at this macro level that affects any of these things, that increases stress and trauma and poor nutrition across populations, and that affects individuals, that has huge health effects. And we need to be looking at this because this is the foundation of where health comes from. Another study looking at housing, that housing vouchers to move families from high to low poverty areas not only had a lot of other good things, but actually reduced obesity and diabetes. Neighborhood quality matters. Lots of studies have shown that, both in this country and from Scandinavia, in terms of diabetes risk. It's related in terms of how we think about health in a little bit different way. So I want to just finish my section here. Sorry, again, I know we're behind, guys. Sorry. Dean and I just have a lot to say. But this was a study before the DPP big clinical trial. So NIH and CDC had to study the DPP lifestyle intervention, make sure it was all ready to roll for the big national clinical trial. So where did NIH often go when they want to study something related to diabetes? They went to the Pima Indians in the Phoenix area because they have been studying them for years. So this was a pilot study for the DPP clinical trial. So they recruited Pima Indians who had obesity but didn't have prediabetes. They were normal glycemic, and they were randomized to what they call the Pima Action Group, which received the 16-week lifestyle intervention that we now know was very successful in reducing relative risk of diabetes by 58% in the major clinical trial. But they had to have a control group. So they had to figure out, well, we have to get these guys together to talk about something, but they can't talk about diet and exercise because they're the control group. So what are we going to have them talk about? So they really weren't sure, and they said, well, how about PIMA history and culture? Okay, PIMA history and culture. That's what we'll talk about. This wasn't healthy PIMA, this is what we used to eat and be physically active. This is a lot of the hard stuff. This is PIMA history and also the cultural things. This had nothing to do with diet and exercise instruction or intervention. So at the end of the study, it was the PIMA Pride group that had more positive results on every biological measure, bar none, in the study. There's something profound about knowing who you are, being connected to other people. Connection is a very, and sense of identity. These are profound and powerful things that have health outcomes. So looking at these socioeconomic stress, trauma, ACEs issues, these are the causes of the causes. These are the causes of why people don't always come in for healthcare. These are the causes of why we're biologically predisposed to obesity or to diabetes or to depression. And we need to look at them in that way. And macro level policies that affect these for good or for ill in populations, especially ones with lots of challenges, the vulnerable population definition Dean gave, this is important. We have to, when we talk about changes in the SNAP program or changes in the earned income tax credit or in housing policy, these have profound health implications. When we talk about changing pollution standards, we haven't even gotten to that whole literature about how that affects not only risk for asthma and lung problems, but actually increases risk for diabetes and heart disease. These all have profound outcomes. And to make meaningful improvements in diabetes, we need to improve the socio-environmental factors that underlie the health of populations. The magnitude effects across populations, even if an intervention has only a relatively small change for an individual, when you multiply that across thousands of people across populations, that same intervention may have far more impact than something that is more targeted and at a smaller population, smaller individual number level. We need to take a larger and longer view on costs and benefits of all of these macro level decisions. And as the Commission decides what to make recommendations on, in my humble opinion, there is nothing more powerful that we can make recommendations on than how decisions are made at these levels on these things that profoundly affect the health and diabetes risk of populations. Thanks.
That was great. Thank you very much, Anne, and thank you, Dean, for your presentations. I'd like to invite everybody to stand up at their seat to just stretch, but not to go anywhere, while we welcome Leah Lozier, Dr. Leah Lozier, who will be our next speaker. Dr. Lozier is a social science analyst from the Program Evaluation Division of the Office of Policy Development and Research with the Department of Housing and Urban Development. She focuses on the intersection between housing and health and has managed the Integrated Wellness and Supportive Housing, or IWISH, program. And she'll be giving us some perspective on social determinants of health as they relate to housing.
Hi, good morning. Thanks for having me. I'm really excited to be here. I'm Leah Lozier. I'm a social science analyst at HUD. I work in the Program Evaluation Division of the Office of Policy Development and Research, so it's a big mouthful. So briefly today, I'm going to give you an introduction to HUD and PD&R, Policy Development and Research, what I think of as HUD 101. I want to take a focused look at 3 projects which I think are relevant to the Commission to give you a sense of the work that we're doing in health and housing. And then if there's time, I will just highlight some other relevant programs, research, and initiatives, and have some time for questions. I love discussions, so I am happy to take points of clarification or questions throughout my presentation, and we'll just kind of go in whatever direction is useful to those that are here today. I also just want to add, I will be talking quite a bit about work that my colleagues are doing. So there might be some questions that I can't answer, but I'm happy to put people in touch with other points of contact at HUD that can dig deeper into some of this work. So HUD's mission is to create strong, sustainable, inclusive communities and quality, affordable homes for all. The department works to strengthen the housing market to bolster the economy and protect consumers, meet the need for quality, affordable rental homes, utilize housing as a platform for improving quality of life, and this is the big bucket, which the health and housing work falls under, build inclusive and sustainable communities free from discrimination, and transform the way HUD does business. So as you can see, we're a big department. We could be multiple agencies. There's a lot of work going on here, and increasingly, the health and housing work is becoming a bigger part of certainly my portfolio and the work and the research work we're doing at HUD. The Office of Policy Development and Research specifically has a mission to inform policy development and implementation through conducting, supporting, and sharing research, surveys, demonstrations, program evaluations, and best practices. And we really have a commitment to providing objective data analysis to help inform our program and policy decisions. So for us, PD&R really sits at the center of the health and housing work. We are the department's large research arm. We do in-house research, and we also fund grants and cooperative agreements and very large contracted research studies that can go over multiple years. And because of that, we have a lot of opportunity to do different kinds of research and studies. But everything really centers around our HUD housing assistance programs. So HUD is responsible for overseeing the nation's housing and community development policies. It's a medium-sized agency with an annual budget of about $50 billion a year. And it's not really a health agency. That's not central to what we do, but we've really embraced health in all policies approach to the programs and the research we're doing. So I want to take a minute to go through the three big buckets of housing programs. I think it helps build context and explain where there's opportunities for collaboration, where we have some challenges and barriers. Just by a show of hand, how many people are familiar with HUD programs? It kind of helps me gauge the room. So a little bit, okay. So the first one to talk about is public housing. I think this is the one that HUD is most well known for. This is federally funded and regulated, but it's managed by local housing authorities. So there is a Montgomery County Housing Authority, a DC Housing Authority. You can think of these as hard units or bricks and mortar. So these are actual physical buildings that people live in. And households generally pay about 30% of their income in rent, and then it's subsidized. So this gives an affordable place to live for a lot of low-income people. The second program, the second big bucket, is housing choice vouchers. So this is monthly rental assistance payment to assist very low-income families in renting housing in the privately owned rental market. And this is HUD's largest rental assistance. So this is also managed and administered by PHAs, but families are able to take their voucher, spend about 30% of their income in rent, and lease up in the private market. So instead of hard units that are tied to a certain place, it gives families opportunity and choice to move elsewhere. The third bucket, which I think is the least well-known of HUD programs and is actually where I've spent most of my research focus, is in multifamily housing. So this is subsidized, privately owned housing. Again, bricks and mortar hard units, but it's owned by private entities that provide heavily subsidized, affordable homes. And again, people pay about 30% of their income in rent. A couple things to note. In public housing and in multifamily, the subsidy is tied with the unit. So whoever's living in that unit receives the subsidy. But in housing choice vouchers, the subsidy moves with the person. So they lease up in one apartment building, maybe they want to move after a year, they can take their subsidy with them. Are there any quick questions on those big buckets? Okay. So across all of our programs, we serve about 10 million individuals, and 4 million of those are children. Which I think a lot of people don't necessarily know is that elderly and persons with disabilities make up over half of the tenant households. So we are serving a lot of vulnerable people through our programs. Children, elderly, persons with disabilities. But another important point here is that housing assistance is not an entitlement program. So HUD assistance is based on your income, and there are eligibility criteria. But unlike a lot of other programs, if you're eligible for HUD assistance, you generally go on a wait list. So sometimes that wait list might be very short. Sometimes that wait list might be 2 decades long, or a wait list might not be open at all. And so what that amounts to is HUD is only assisting about 25% of the people that are eligible for HUD assistance. So I point this out because this becomes a challenge for interagency work because our programs aren't necessarily always aligned. Although we're generally serving the same individuals and interested in the same population, because of the limitations on HUD assistance, and there is geographic variability in terms of wait lists and housing shortages, it can make it difficult to properly deliver services. But there's also a lot of opportunities here, and we've had a lot of opportunities for health-related research. The big one comes actually from use of HUD administrative data. I know this is probably going to get a little wonky, but I promise it's important and useful to know. So as part of these HUD programs, HUD collects administrative data on its tenants through these two forms. We call them the 5058 and the 5059. I know it's boring and I'm not going to get into all the fields, but we collect deep program data on all the people we are serving. This is collected by the public housing authorities or the multifamily property owners, but it is transmitted to HUD. And these forms contain really detailed program information, but they have data linkage potential, which has been a real place where we've been able to invest in our health and housing work. And I'll explain more on that. So the first big project that I'm talking about, even though it was quite a while ago, has really set the stage for a lot of the work we've done. There's a report, it's on ASPE's website, you can Google it, and there's an updated report called Housing and Health, Medicare and Medicaid Among Older Adults in HUD-Assisted Housing. This was a collaboration between my office, PD&R, and the Office of the Assistant Secretary for Planning and Evaluation at HHS. And the idea here was, can we match our rich HUD administrative data with Medicare and Medicaid claims data for two reasons. One, feasibility of a data linkage. We didn't know if we could do this. And two, can we use that information to understand more about the health status and the health conditions of the people we are serving? So in 2008, the Lewin Group and their subcontractors, they were contracted to do an individual level data match in 12 geographic areas. So this was linking, I believe, on social security number and date of birth in the HUD data with CMS data. And they actually had, it kind of blew everybody away that the systems were interoperable. If any of you ever deal with administrative data, because it's collected for programs, it does not make it easy for researchers. And so this was a huge learning opportunity just in the methods game. But more importantly, we found out about elderly residents, some things that we just didn't know before. The first is that around 68% of HUD-assisted residents age 65 plus are duals. They're dually eligible for Medicare and Medicaid, which made us think about alignments of our programs and how we can tap into benefits that our people are eligible for and receiving. I do want to note that for HUD, we use the old Social Security definition of elderly, so our elderly starts at 62 plus for our programs. So again, there isn't perfect alignment, but we're generally serving the same people that are covered by Medicare and Medicaid. Another thing we learned, compared to other duals, HUD-assisted residents have more chronic conditions and higher healthcare utilization and costs. This probably comes as no surprise to anyone, but we didn't know it. We didn't have the data on it. And this really opened our eyes to thinking about housing as a platform in a different way and how we can leverage our programs to improve the health connection and hopefully improve the health of the residents we're serving. So again, that's housing as a platform and portal, and also programmatically an opportunity maybe to think about identifying hotspots and high utilization because we can geocode our data, and thinking about, again, program alignment and access to services. That data linkage potential underlies a project that I'm managing now called the Integrated Wellness and Supportive Housing, or IWISH. It's also sometimes called the Supportive Services Demonstration. We did some rebranding to make it sound less governmenty and less boring. And this is designed to test a new approach to help low-income seniors in HUD-assisted multifamily developments, so those privately owned developments I mentioned, successfully age in place. What we're doing is we're testing a model of a full-time resident wellness director. There's a typo there, I apologize. Resident wellness director, RWD, and a part-time wellness nurse per about 100 units. And the way this works is the resident wellness director and the wellness nurse are embedded and work at the property level to assist elderly residents age in place. And so traditionally, HUD has had a very robust service coordination program. These are often social workers that are very, very, very good and work on site, but often do more of a refer and link kind of model to help connect residents with services and benefits on the social services side. We know that there's I hate the word, but I'm going to use it, silos, right? There's silos in the social service sector and the health service sector and also the housing sector. And the idea here, building on some other good evidence-based models, was can we do better at connecting our residents on both the health and social services side? And there are 6 main components to this model that are being implemented. So the first is a proactive resident engagement, which I know was mentioned earlier as being really important. So trying to get residents interested in this kind of model in independent housing. And that's something I should mention. This is not assisted living. This is all independent housing, but it's helping elderly residents hopefully avoid the need to go into assisted living or nursing home care. Another part is a standardized assessment. So trying to really understand what the needs are of residents, both on the social and healthcare side, so we can better connect them to what they need. There's the development of individual and community healthy aging plans. So the individual healthy aging plans are person-driven. So the resident wellness director and wellness nurse work with the resident to learn about what they are interested in doing and potentially want to improve on, and building a plan around that. So it's not someone coming in saying, oh, you should really quit smoking. You're 75. Let's go ahead and work on quitting smoking. It's saying, what are you interested in doing? And it might be, I want to be able to stand at my kitchen sink and cook a healthy meal, or I want to be able to go for a walk around the block, and starting there for a health and wellness approach. At the community level, it's about thinking what this building as a community can use to promote healthy aging. So it might be that a lot of people have type 2 diabetes, and they can bring in a chronic disease self-management program to help with that, some education programming, connecting with the local hospital, connecting with the university. It might be a falls prevention program. It really depends on the needs of the community. There is also a centralized data platform that is collecting this information to help the resident wellness directors and the wellness nurses do their job and be able to understand what the residents need, so they can say, all right, 90% of the residents in IWISH are struggling with type 2 diabetes. That is a need I have, and I need to think about how to support them. As I already alluded to, a big part of this is making local partnerships. So this is not a direct delivery model. HUD is not in the healthcare delivery game. We can't do that. And the wellness nurse is, although they are RNs, they're not doing clinical services. So it is about connecting people to services that they already can get or are getting in the community, but trying to also push those local partnerships with the area agencies on aging, or if there's transportation programs, if there's food programs to come in. And then also bringing in evidence-based programming like chronic disease self-management, like some of the Matter of Balance or Tai Chi falls prevention programs. What's exciting about this for me and for the department is we really set out with an agenda of evidence building. So this is actually a cluster randomized control trial that we're running at HUD. It officially launched in October of 2017 and is running for 3 years, so we're in our last year. And what we did is we randomized these multifamily properties that all serve elderly residents, 62 plus, into either a treatment or control group. 40 properties are implementing IWISH, that standard model I just walked through, and another 84 properties serve as controls, and they're doing business as usual. This runs the gamut. Some have a service coordinator that is doing basic refer and link functions. Some have a service coordinator that are doing, frankly, what we're asking our resident wellness directors to do, go above and beyond. And some are relying maybe on property management or other programs in the community to support their residents. So a large variation. We just want to see how this model stacks up to business as usual. Back to what I mentioned about our data. We are doing a process study to look at rollout, but we're also doing an impact evaluation where we are linking our HUD administrative data with Medicare data and state Medicaid data to look at unplanned hospitalizations, use of primary care, length of stay in housing, and transitioning to nursing homes. These are our primary outcomes of interest. We're also going to be doing some exploratory analyses, which we can do from the claims data and get out some of the health status and health conditions, and answer some more exploratory questions that we're not sort of hanging our hat on in terms of impact for iWish. This is currently running in 7 states. This graphic shows the breakdown of the different states and how many properties. So the number refers to properties, not the number of residents. There's roughly, you can think about 100 residents per property. So we're working with about 4,000 residents in our treatment group and 8,500 residents in our control group. So it's a pretty big trial for us. We actually, I'm going to give a plug. We're going to be having our first interim evaluation report coming out in a few months, which is going to look at baseline characteristics, the randomization, and a very early look at implementation. And then the full process study and impact analysis will be following in, I think we will end up publishing the report probably in 2022. I know that sounds so far away, but it has to do with data availability and data lag. But we're really excited about this because it is going to be follow-up on earlier work to really understand what is going on with our elderly residents, but what programs HUD can be rolling out to work with them. And importantly, as I hope I made clear, this model really depends on what is available in the community, what our interagency partners are doing, what is going on in the healthcare sector, the social services sector. So we're really excited about this work. Another area of focus I want to highlight, this is not my own work, so very quickly we're going to get into places where I can't answer technical questions. But my colleagues at HUD have undergone a data linkage with the CDC and the National Center for Health Statistics to link HUD administrative data with their NHIS, National Health Interview Survey, and NHANES, National Health and Nutrition Examination Survey. There was 2 linkages done. The first, linkage 1.0, was done from the survey years 99 to 2012. And the linkage 2.0, I think, just came out, which is from 2013 to 2016. So this is huge, actually, in that, about 17 years of data from NHIS and NHANES linked with HUD administrative data to help us and other researchers better understand what is going on with assisted residents, both children and adults. So the work I mentioned previously was really focused on elderly because we were capitalizing particularly on Medicare claims data. But this is allowing people to really dig in across the lifespan. And if you'll forgive me, I'm going to go to my notes because I want to read some things that I wrote down about this work that I think are worth mentioning and would be of interest to the Commission. So on the adult side, we were actually able to look at the prevalence of a diabetes diagnosis. So I believe this was self-report data on ever having been told that they were diagnosed with diabetes. So among HUD-assisted adults, they had the highest prevalence, with 17.6% reporting ever have been told they had diabetes. Among unassisted but low-income renters, so a somewhat comparable group that were not receiving HUD assistance, 8.8% reported a diabetes diagnosis, and among the general adult population, it was 9.9%. So this, to us, aligns with the previous work, right, about HUD-assisted adults having higher chronic conditions, multiple chronic conditions. But I really wanted to point that out because it's specific to the work of the commission. And I think for us, really highlights that HUD-assisted adults could benefit from some targeted diabetes prevention or management, and there might be a real opportunity there for collaboration. And given the way our programs roll out and our rich administrative data, I think that there's a lot of opportunities there that we would really be interested in exploring because we know it's a place where there's a lot of need and hopefully a lot of opportunity. And finally, those were sort of the big three I wanted to highlight, and they really hinge on our administrative data. But I want to give an opportunity to highlight some other programs and initiatives that really show the breadth of what we're doing at HUD, both past, present, and future. So the first I'll mention is the Envision Centers. This is this is a secretarial initiative under Secretary Ben Carson. It's a place-based initiative to provide communities with centralized hubs for support in economic empowerment, educational advancement, character and leadership, but also health and wellness, and that's why I'm mentioning it here. So really this is partnering with public housing authorities around the country to have a centralized hub to do these things. The next is the Section 811 PRA program, which Section 811 is a program for housing with persons with disabilities, and HUD was testing a new model around enabling people to live in the least restrictive setting possible and also have access to services, primarily home and community-based services. There's an evaluation report coming out probably in the next month or two that looks at how this program worked. And again, they were linking with Medicare and Medicaid data to understand changes in healthcare utilization and health status. There's an ongoing study, and I believe this is also funded by NIH, called the Housing and Children's Healthy Development Study. And this is looking at the associations between receiving a housing choice voucher, so those vouchers I mentioned to help you lease up in the private market, and neighborhood quality, family processes, and health of the primary caregivers and children. So this is, again, a randomized control trial, and they're looking at outcomes along three main dimensions: physical health, emotional development, and cognitive achievement. But this is really interesting because they are actually collecting some biological data to look at biomarkers. So they're looking at interleukin-6 and C-reactive protein, executive functioning through the Hearts and Flowers tests, and a self-regulation protocol, and then using the Woodcock-Johnson letter word and applied problems test to look at cognitive achievement. So this is a really interesting study. I don't believe there is a specific diabetes component, but as the other two presenters, and you all know, it's all interrelated, and I think there's a lot of opportunity here. We have two cooperative agreements. One just started with the University of North Carolina, looking at the role of adolescent housing residents on adverse childhood experiences and outcomes. And then another one where we've got a report coming out in a month or two, looking at children's outcomes on education and emergency department visit for some housing that was undergoing some revitalization in Fresno under what's called our Rental Assistance Demonstration Program, or RAD. Another new thing we have going on is the Choice Neighborhoods evaluation. So Choice Neighborhoods is a place-based program that brings an infusion of cash into the community to transform and revitalize HUD-assisted housing, but also the neighborhood, and leverage private capital and bring in new development. And one of the things, there's a big people component to Choice Neighborhoods, and we're evaluating that program. There is a new multifamily home modification grant program that's really focused on the elderly and modifications to help support aging in place. There was a big study called the Family Options Study, for families experiencing homelessness. This was recently completed. If you'll excuse me, I want to read from this. I want to get it right. This study was launched in 2008. It was a multi-site evaluation designed to measure the relative impacts of different housing and services interventions on homeless families. And there was an 18-month enrollment period and over 2,200 families that had spent at least 7 days in emergency shelter and were randomized to different treatment arms. What's important about this is that both in the short-term 20-month and long-term 37-month follow-up, there were, one, vastly superior outcomes for families who were randomly assigned to receive a voucher when compared with other treatments. But what's important here is there were significant reductions in child separations, psychological distress, economic stress, intimate partner violence, school mobility, behavior problems and sleep problems of children, and food insecurity. So again, going towards those ACEs and those other social determinants of health. And this that program really highlights the power of a voucher and housing assistance and housing security and how that intersects with all the other things that are working to have both good parental and childhood outcomes. I'm not going to spend time on the other two. I can if there's questions. SASH was a program that inspired iWish, and it was evaluated by ASPE, and MTO was a HUD study conducted in the 90s in RCT, which had some interesting health impacts. So hopefully, one, this gives you an idea of what HUD does. Two, let you know we're excited about working with this sector. I think there's a lot of opportunities for collaboration, and we'd be excited to hear about those. But also let you know what we're trying to do in this space in our own capacity and think about where we might be able to link up better. So I will stop there. 10 a.m., happy to take any questions, and we can also follow up separately. Thank you.
Thank you.
Oh, I just want to highlight, we have a ton of cross-agency research initiatives. I want to give a shout out to our partners and say thank you. And that's my contact information.
Great. Thank you very much. You mentioned that only 25% of people who are eligible actually receive benefits, and it sounds like it's a first in line, first come, first serve approach. Is that how the housing benefits are dispensed?
Typically, although this can vary by PHA, so public housing authorities can have certain preferences on their wait list. So not just whatever they want to do. I believe families experiencing homeless can be a preference, and so it can change the way the wait lists are ranked and sort of who becomes up the top and eligible for assistance. There's also certain types of vouchers so there's non-elder vouchers they're called NED vouchers, non-elderly disabled vouchers for non-elderly disabled persons and so forth. So sometimes the wait list can change slightly if there's different vouchers that have certain preferences associated. But yes, generally it is a first come, first serve on the wait list.
And would you have any recommendations as to how to prioritize who gets served? And if you could pick a number, what proportion of eligibles do you think ideally should be served? Should it be 100%?
I think that's a little bit of a broader policy question, right? In terms of how our programs roll out and being an entitlement versus not. I think there's a deep commitment to make these dollars go as far as they can, to make the voucher dollars go as far as they can while adequately providing rental assistance. Right, there's that trade-off because you want enough rental assistance such that housing isn't fully crowding out all the other needs, but you want to make those dollars go as far as possible so you can serve as many families. So it's a tricky policy question for me to answer. I don't know that I have an answer for that on behalf of HUD, but I think certainly a desire to get as many families served as we possibly can with the resources we have.
Thanks, Dr. Lozier. It was a really excellent presentation and very responsive to the questions that we had asked you to prepare for. So thank you. I want to follow up on Dr. Herman's question a little bit. Respect to the 25% number and follow up on Dr. Bullock's slide, one of her last slides, which is, you're appropriately evaluating, in some cases, the health impacts of either different forms of public housing assistance or different co-interventions co-located in the housing units, or whether they private or public. I'm wondering, given the 75% number of people who are not served, and given the fact that there likely are very, very high costs to the healthcare system and other sectors related to the unavailability of housing for them, and given the nature of HUD's practice to put people on a wait list, whether there have been studies that have evaluated the health trajectories of those who have been put on a wait list, not for reasons of different forms of eligibility, just with comparably eligible people who have been provided vouchers or other forms of housing in a longitudinal fashion, so that one could begin to estimate what the hidden costs related to not having housing be a benefit, but having it be not having it be an entitlement, but having it be a voucher-based system are to society at large. Has that natural experiment that happens every day in every city and every county in the United States ever been harnessed to try to estimate the human and economic costs, be it for diabetes or a range of other conditions?
That's a great question. To my knowledge, there has not been a large HUD study or a HUD-sponsored study evaluating this. I do believe in work on families experiencing homelessness, not just the family option study, but there's some other work attempting to look at the costs, I think, primarily to Medicaid with being unhoused, right? That's where we can see the biggest cost differential when you get someone who's homeless and housed in terms of impacts. I don't think that
it wasn't experimental, though. Yeah.
And I also do want to highlight that HUD is not holding the wait list, and we are not doing that kind of ranking. The wait lists are all done by the public housing authorities and by the multifamily providers. So,
and do you know if those PHAs even collect data in an ongoing fashion on those who are on the wait list, or is it just you're on the wait list? We'll call you when we're ready.
Yeah, I believe they basically collect. I don't want to misspeak here, so this might not be 100%.
I'm sure there's a lot of variation. Yeah.
Yeah, but I think that they collect one, basic eligibility information, and then also contact information. And so for some places that have long wait lists, right, they try to keep their wait list contact information up to date so that they are able to contact people. But to my knowledge, they're not collecting any deeper information. Those forms I show, the 5.8 and the 5.9, those are only
for those who are housed. So, but the idea of calling everybody up in a year would not be impossible to collect data.
I don't think so. And certainly there are many PHAs throughout the country that have research wings of their own that are really interested in this kind of work, and always potential for collaboration, particularly between PHAs and universities and so forth.
Mainly want to echo what Dean just said. That was excellent, and I'm delighted to know of the many things HUD's doing, and also to underscore that it appears to be not so much what you guys are doing, but it's the availability of it. That is the crucial issue. I'm delighted to see the partnerships looking at ACEs and other kinds of things, and other child stress situations that being in housing may be helping to reduce. So anyway, just if there's anything that, obviously I realize as a fellow Fed, we can't talk about, what should happen. We're not able to do that, but getting at Dr. Herman's question about it, and Dr. Schillinger's in terms of what are the, where are we penny wise and pound foolish? Mm-hmm. The costs of housing people in good quality housing situations, both through your private and publicly available ones, to look at what would it take to house these people, and what would be the costs we would be avoiding by doing so in all these other sectors. I'm really just restating what's been said, but
really want to underscore it because it sounds like what you guys are doing is really wonderful. We just need more of it.
Yeah, you've highlighted something we've struggled with, right? The wrong pockets problem, in that there's a strong belief and growing evidence out there that the provision of housing can save money on the healthcare side, in some cases at least. But right, HUD is not going to see that return on an investment in our budget in a way that would allow the housing dollars to go further. So again, it's that wrong pockets, and it gets really complicated when we're thinking about federal budgets and also alignment of programs, because Medicare and Medicaid can't directly pay for housing. There is some changes, I think, on both the Medicare and Medicaid side, especially under managed care, giving a lot more flexibility to what they can pay for in terms of social determinants of health. And there are some places where I think healthcare entities are building housing, they see that need, but it has been really tricky to think about what we can do from a HUD perspective that we do think can save money. I will say though, some of our studies are also trying to build that evidence. The SASH evaluation that was led by ASPE, I believe they found slowing in the growth of Medicare dollars. Our iWish study is not sufficiently powered to detect all Medicare costs, which is why it's not one of our primary endpoints, but we are looking at utilization, which can be a proxy for some of the costs, right? We know that emergency department visits are very costly, unplanned hospitalizations are very costly. So we are trying to help build that case and go more from what I think we all feel and think, but putting that research in place to show it and actually quantify some of that. And like I said, I think it's been a lot more effective on the homeless side and getting families housed in terms of cost reduction.
So just to follow up on all that, there's been some in the medical literature, some articles talking about how healthcare systems are starting to address housing insecurity in addition to food insecurity, because they realize that their highest cost patients with multiple chronic conditions, that's the small percent of patients taking up a large amount of healthcare resources, especially many that are under or not reimbursed to them because of the status of those patients. So I wonder if HUD is working with any healthcare systems that are starting on their own to put dollars into helping to house these people, because some of them have started to undertake that and to see if that is actually cost saving to the healthcare system. So just throwing that out as well.
Yeah, to my knowledge, we don't have any formal research studies going on, but I can tell you, I go to a lot of meetings on health and housing, and more we're getting managed care organizations, Kaiser, United, the same players that are coming in that are of interest. Dr. Wong and I were at a recent meeting, so I think we're getting there because we recognize it as well. It's a great point.
I just have maybe one quick follow-up on that. Hi, Ann Albert from CDC. I think a couple things. What has happened in other work in diabetes prevention was that others in the federal agency and commercial health plans and others had to go first, and then we went to CMS. It was just sort of how things unfolded, and seems to be a little bit more happening that way. It would be interesting to look at that, what is going on, and consider either working with CMMI ultimately, or certainly CDC, because many of and the Chronic Center do work and are working with you, by the way, and we're thrilled about that.
Yeah.
To really look at that kind of a model test and see what would happen, because it would then allow coverage or payment. It would be interesting to sort of explore how to do that, because the deal with some of this stuff that we're really eager to understand is the sustainability of it. You can do it for the short term, and even what health plans are doing, how do you sustain something like that? And so it gets to that right pocket, wrong pocket problem. And I think it also gets to how you can do some of this and have it really be cost effective and not pound foolish and penny foolish and pound, but and to make sure that it is sustainable long term. So it would be interesting to talk about that, in addition to talking about evidence-based programs, because I know you all have a partnership with our Office of Smoking and Health,
And we are doing some work in the National DPP in housing units across the country and are proposing an internal project within my division, the diabetes division at CDC, that would involve communicating with you all and HUD. So we're eager to follow up with you on that and see if we can't tie some of these things together and sort of enhance what we're already doing with you.
I would love that. And one thing I do want to mention that has been a challenge for us thinking about working with health plans, and I know we're short on time, is that in housing, there is we have to preserve choice. So we cannot make housing assistance dependent on who your health provider is or what kind of insurance you have. And so, for instance, in IWISH, which is at multifamily buildings, in any given building, half may be on fee for service, half may be on managed care, some may be with Kaiser, with United, they might go on and off. And so trying to figure out, like you were saying, sustainability, right, making that business case to health plans who understandably want to serve their members, it doesn't neatly align with how our programs roll out, which doesn't mean it's impossible. It's just a challenge. We're still trying to figure out the mechanics to make the incentives work for everybody.
Sorry, Don Shell from Department of Defense. I'm excited to hear about a lot of the things that you're doing at HUD. And the thought that comes to mind when looking at your IWISH and your data linkages is thinking about if there's, in your data linkages, is there availability of information or data about partnerships concerning physical activity, participation of your children in parks and recreation activities or competitive sports or in leagues or obesity rates. And so I'm wondering about the opportunities for HUD's housing department associations and your relationships with them. Both, are there any opportunities for children to participate in physical activity, sports, competitive activities? And I know sometimes that can be a challenge for children, but thinking about physical activity, your data linkages, the individual community plans in your IWISH program, the local partnerships, if any of that information is included potentially in any of the reports that you highlighted, because I'd like to look a little further at those activities for movement. The final thought is the partnership you had on your next to last slide with USDA, but thinking about food sources and food selection and food choices with your residents in housing units. I think that what you presented provides a lot of fertile ground for thoughts about system-wide linkages and then bringing those resources or partnerships to HUD that would help just improve some of those baseline environmental issues.
Yeah, thank you for that. In terms of what's in our existing linkages, I don't think any of the information you covered is in our Medicare, Medicaid. I don't know all the variables that are in the NHANES and NHIS. There were two reports. They're probably super small. You can't read it, but it's a health picture of HUD-assisted children and a health picture of HUD-assisted adults. And those reports are really nice because they go over the linkage, all the variables, and then present all the data. And I think generally they did those on HUD assistance, low-income, unassisted renters, and then sort of others in the community to try to get at decent comparison groups. So I would encourage you to look through that. And then also on the NCHS website, they have a nice explanation of the linkage. But as you pointed out, there's potential for other linkages with other data sets. HUD has a data license program where you can come in and link with our HUD administrative data. It's free. You, of course, have to have all the privacy protections in place and IRB approval if it's necessary or appropriate. We take data security very seriously, but we also see the benefit of research using this data. So there's lots of, and this isn't just for feds. This is also for university researchers and others. And then on the ERS side, I think the big program we're working on right now is I have some colleagues that are trying to develop a housing insecurity module. It's kind of analogous to USDA's food insecurity module because we get asked about that a lot. We don't have a stock set of questions that we can kind of plunk into surveys that's been validated on housing insecurity. But I think there's a lot of opportunity for where we could maybe partner with USDA around food insecurity in general.
I just wanted to make one final point and question. I think the most important thing you said today was that HUD is very excited and has a focus in the concept of health in all policies, which is, I think, critical to this trans sector work if we're going to be able to make it harness these systems to help prevent and manage diabetes. Where did that philosophy come from in your agency? And how do you believe it could be best supported and amplified? There are the wrong pockets issue that you've mentioned, which I think is a very important concern. But where did it come from, and how could it be best supported, both within your agency and then to enable cross-sector agency work?
I don't know when or exactly how it started. It's been going on for over a decade for sure. But even before that, with the MTO study, they did collect data around health, and that was back in the 90s. And it's continued under different administrations. This focus on health, and I think is growing more and more. So on areas of how to better support it. When I first started at HUD almost 6 years ago, there was a senior policy advisor. She liked to joke. She was the only one at the agency that knew the difference between Medicare and Medicaid. And she wasn't really wrong. There's a few more of us now. And two of my colleagues in PD&R actually have public health degrees. We have an IPA right now with Dr. Craig Pollack from Johns Hopkins University, who's a physician and also in the School of Public Health that is working with us. So we were trying to build our internal capacity. I think for at least 5 years, at the federal level, there has been what's called cross-training between HUD, HHS, and USDA around these issues. And it really started with just making sure we were speaking the same language, right? Just of whose programs are entitlements and whose are not, and what the heck is HUD assistance, and how does Medicare work, and what can't you pay for? And where does USDA fit in? What are SNAP benefits? And also the rural housing component, which comes under USDA. So
it's a model. I mean, it's a beginning of something.
Yeah, and so I think for us, these types of meetings where HUD is asked to be at the table, we're very appreciative. And thinking through concrete research studies that I know I'm a researcher, so I'm always proposing research, but I think that is a way to start for evidence building and making the cases for different programs and different models with HHS, with CDC, with CMMI. And so we're always interested in talking through that. And I think for us is dealing with our naiveness around the healthcare sector and around public health. We are trying and we are working, and taking us where we are and us taking you where you are, and trying to just figure out program alignment in some places, baby steps. And for us, it's also getting the word out for the work we're doing.
Great. Thank you very much. I think we're going to have to break here.
Thank you.
As we organize our thoughts, I'm sure we'll be reaching back out to you, though, for more information about programs and potential research. We've had a bit of a change in our agenda, but we are going to now be hearing from the U.S. Department of Transportation. Danielle Nelson and Victoria Martinez are here. I guess Danielle is here. Are you going to start, or? Okay, so Victoria Martinez will start. She works with the Federal Highway Administration as an urban transportation planner and environmental protection specialist. And both she and Danielle will be speaking with us this morning. And again, you all, we'd like you to present in half an hour or less, to leave again 15 minutes for discussion. And if folks want to stand up quickly again while the slides are coming up, please feel free. We're not going to take a break.
We'll be quick. We'll kind of sound like that medication ad on the TV where they're talking so fast about all the side effects. So we will help make up some time. And Victoria, can we hear you? Are you on? I'm on the phone. Can you hear me? Excellent. I'll advance your slides.
Can we turn up the volume a bit?
Oh, is that better? Try again. Let's see how loud you can get, Victoria. Is that better? A little bit.
Okay, I will
There we go.
try to speak up.
That's good.
And our apologies.
Okay.
Our colleague Jason couldn't make it. Sick child at home, and Victoria's in our Puerto Rico office, so that's why she's virtual. But go ahead, Victoria, take it away.
Okay, thank you so much. I think you can go to slide 2. This morning I wanted to talk to you a little bit about health and transportation. Is this bad, Danielle?
Yep.
It's bad. So slide 2 should be up, and we're talking about this morning health and transportation. And given this audience, I thought we'd focus on active transportation. Slide 3. So like Dr. Lustier said, we rely on our partners to provide many aspects of our transportation and to support active transportation. Slide 4. So I thought I would discuss a little bit about what this graphic shows in terms of the various ways health and transportation intersect. And as I said before, much of what I'm going to talk about has to do with the active transportation corner, which includes biking, walking. I'm going to talk about safety. I'll touch on equity, connectivity, and clean air, which are all interrelated. Next slide. So safety is really a major component of what we call health and transportation at DOT. And a vast majority of our transportation-related fatalities come on highways and on roadways. And while what we're showing here is a long-term positive trend in the number of roadway fatalities going down over the decades, in the past several years, we have seen an increase. 2018 data shows overall roadway fatalities have declined by about 2.5%, which is great news. However, we have seen a trend in recent years of fatalities, increased fatalities among more vulnerable users that are outside the vehicle, pedestrians, bicyclists, and motorcyclists. And unfortunately, in 2018, we're showing a 3.4% increase in bike fatalities and a 6.3% increase. The bicyclists was 6.3, pedestrians 3.4. Again, both troubling trends. Next slide. So the Department of Transportation has a health and transportation working group. Danielle, Jason, and I are all work on this. It's an interdepartmental group established in 2012 to coordinate on developing resources and expertise. At that time, health within the Department of Transportation was something that was being brought up by outside partners. People were asking, what is transportation doing about health, and how are you considering health outcomes? And we all thought we were. We're working on air quality issues. We're working on safety or noise. But we weren't really coordinating that discussion, and we weren't really showing a lot of leadership and communication. So we formed the group to do that. Since that time, we've also been coordinating with CDC on a number of initiatives. The DOT, for example, National Highway Traffic Safety Administration, NHTSA, has worked with CDC for many years to prevent fatalities and injuries. Again, the HINT work group has an ongoing collaborative with the CDC through their Built Environment work group. We have been sharing information through several workshops, webinars, and joint presentations at meetings like at APHA. the American Public Health Association. And then there's FDA. I know Danielle is there, and she's going to talk more about what they do in terms of coordinating access and mobility. So I'll leave that to her. Next slide. So these next two slides cover a resource related to transportation corridor planning. And I could probably spend our whole time talking just about how Federal Highway and how DOT fund projects, but I don't have time to get into that. But one element of highway planning and program delivery is in the corridor planning sector. Are you on slide 7, Danielle?
I just went forward to Appleton, Wisconsin.
Oh, well, okay. Could you go back one? I'm sorry. It should have the graphic with the corridor planning framework.
I was just trying to rush us along with time, so we'll try and speed
I know. So this is a tool we've provided that helps our practitioners that are interested in incorporating health do so. It gives tools, it gives questions that helps them engage the community to focus on what the community's needs are. A lot of times transportation is worried about how many cars can we get through the intersection, or how fast is the traffic going on that particular roadway. And we decided that in order to improve accessibility, improve active transportation, reduce exposure to air pollution, that if we put the community first, that could perhaps turn things a slightly different focus. We've done a number of case studies. You can go to the next slide. In the interest of time, I won't get into this too much, but the outcomes were, I think, important, and that's at the bottom of the slide. This tool helped Appleton, Wisconsin, convene a new and diverse group of stakeholders that they weren't talking with previously. It helped them make recommendations to support a multimodal corridor that gave benefits to the business community, the people that lived in the corridor, as well as people that used the corridor. And it also worked to build support for implementing these recommendations, not just in this corridor study, but in future studies as well. Next slide. I just here have another tool that the department has developed that brings together health, transportation, and policy issues, and helps communities that want to use the indicators in the tool to improve how they're going to address walking, biking, fatalities, and other health-related indicators. Next slide. So active transportation at the Department of Transportation. I'm going to talk a little bit about this. The Office of the Secretary. Sorry, next slide, Danielle. 11, sorry. So the DOT Office of Secretary, this was Jason's office. He wanted to make sure that he mentioned this pedestrian and bicycle coordinating committee that is bringing together, it's an internal committee, but it focuses on bicycle and pedestrian work. They're also leading a very big data safety initiative focused on improving data integration, as well as visualizing the data so that they can better identify and address emerging safety risks. This allows us to move more quickly. Right now, a lot of the data is a year or two behind. So by the time we get it and we're able to help identify the high-risk areas or whatever, we're already behind. Right now, we're under something called the FAST Act, which has allowed DOT to focus on accommodation of all users. And in 2018, we released a Safety for All Users report, which focused on bicycle and pedestrian, and it gives information about 9 workshops that were throughout the United States. The next slide, please. Again, this is the Safety Data Initiative, and shows you a little bit of how we're taking the data, putting it into some visualizing, visually pleasing graphics. And next slide. Okay, Federal Highway, we have many programs that we think cover health and transportation issues. I talked a little bit about planning, multimodal planning, complete streets, context-sensitive solutions, and things like environmental justice are just some of the examples. Next slide. FHWA has produced a number of bicycle and pedestrian planning guides. A lot of what we do is help states and communities deliver projects and programs. This is information about multimodal transportation networks that will hopefully benefit all users, as well as increase the design flexibility. Sorry, I have a lot of static.
And Victoria, we're on the next slide, highway safety programs.
Okay. I'm sorry, there's a lot of static on my end. Are you hearing the static?
Yes.
I just don't think it's worth talking right now. I only have 2 or 3 more slides. But.
No problem. I'll take over. Thank you, Victoria. And just as an FYI, Victoria works in our Federal Highways Office, which is an operating division. Jason, who couldn't be here today, is in our Office of the Secretary in the Policy Shop. And then I work at the Federal Transit Administration, which is one of the other modes, or as you guys call them at HHS, operating divisions of the department. And this is Jason's contact information and Victoria's, if you would like to contact them. And then Victoria, hopefully you'll stay on for some questions. I'll just fly through this very quickly. So I work on something that's called the Coordinated Council on Access and Mobility, which is chaired by the Secretary of Transportation and has been delegated to the Federal Transit Administration. It was part of our authorizing legislation, the FAST Act. We always have sexy names for our laws. And so it was put in my lap when that legislation came through. A couple things I'm going to touch on today, but I'll go quickly. We held a summit. It was the Access and Mobility for All Summit on October 29th at USDOT. And the Secretary announced some very big initiatives. The one I want to just touch on today is the complete trip deployment. So we're going to have a $40 million notice of funding opportunity coming out of the department. And the whole goal is to help states and communities get individuals from point A to point B seamlessly. So instead of 5 different payment models, if anyone lives locally, if you ride Capital Bike Share, you need a different, or if you're unbanked, you can't access it. So this program is really about helping the user be as seamless as an Amazon package to get through. From when you order it, you click a button and it gets there the next day. Also, I just wanted to give you an overview. So the Federal Transit Administration, we provide about 10 billion trips annually. We have 4,000 different agencies we fund. Our funds majorly go to the state DOT and then are sub-awarded out to private nonprofits, human service agencies, etc., cities, state, and local governments. And then we have about 130,000 vehicles right now currently. So the Coordinated Council, what is this? It was started by executive order in 2004 by George W. Bush. It's been stagnant until our authorizing legislation where Congress said, do more. We need you to coordinate transportation. So it's 11 agencies. A lot of these are surprising. People always wonder, well, why is Department of Justice involved? They actually have several programs that can fund transportation for drug court-involved individuals, including juveniles. They also have a lot of new programs around the opioid epidemic that can fund transportation. The other question I always get is, why is Interior there? Bureau of Indian Affairs, they have 3 programs that can fund transportation on Indian reservations. The others, but the whole goal is to increase transportation coordination for transportation disadvantaged individuals, older adults, people with disabilities, those of limited or low income. That's the goal or the mission. Why is it important? GAO has been beating us up about this since 1999. There are 7 current GAO reports, with 1 being finalized now on rural coordination. So this is something that's been ongoing. We started to look at, when the Affordable Care Act was passed, we started to look at the fact that there's all these preventative appointments that are free, but what if those individuals can't access them? So we decided to do a study. So we funded it through Health Outreach Partners, who already was working with HRSA. I can say that acronym in this group because I know everyone knows it. It's nice and transit, I have to say it out. And we surveyed their community health centers, 15%. And what we found is the missed appointment rates were very high, but they were not tracking why. So we didn't know if it was for transportation or what was the issue. Is there no transportation? Is there not reliable? Do they have a card that doesn't work? So that's when we started this notice of funding opportunity. This was in 2016. We posted it. We tied the goals to the triple aim, so looking at increased access to care, improved health outcomes, and reduced healthcare costs. The goal of this funding was to incentivize public transit to partner with your world, to get those silos, as the last presenter said, to be sort of bridged. And I really wanted to highlight this program that I have a picture of. It's in Flint, Michigan. The Mass Transportation Authority was one of the 19 projects we funded in 2016. They're 18 months. They just finished. We just got a lot of the final reports. This one's my favorite. I know we're not supposed to have favorites. But what they did was they developed an Uber-like same-day public transportation service. They partnered with the local human services agencies, the adult drug court system, the community health center, the behavioral health clinic, the area agency on aging, the Center for Independent Living. Everyone was involved, even the VA, the local VA medical center. They even started partnering with their PACE program, which, as far as I know, is the only public transit provider that provides transportation for the CMS program for all-inclusive for the elderly. And so what they also realized in doing the same-day healthcare service was that there was a huge issue with lack of healthy food. What they found was 2 of the grocery stores in Genesee County had closed, and most people were going to the Dollar General, and they couldn't get access to healthy food same day. So this is what their answer was. They developed their bus routes. They took a look and said, are we going past that one open grocery store still? And then they trained their drivers to be able to help people get on and off, change the times of the service. And they also started their local ride centers. So they offer a low-cost, door-to-door service to get people to the grocery store. They help with your groceries to get you on and off the bus. They even have a special vehicle they developed that carries the groceries this way. And they now have a service in every part of the county, 7 days a week, including Sundays. So our next funding of opportunity, we changed the name, new administration, new name, but the same funding stream. And we just awarded 37 projects. And the majority of them that came in talked about lack of access to healthy food, lack of access to safe recreation paths, and they talked about diabetes, which I do have an MPH, but when I first came to DOT 5 years ago, first person asked me when I got my business cards, does that stand for miles per hour? So it's not necessarily something. So our review teams that reviewed this was gobbledygook to many of them. Why? So we're starting to get into this space. I don't know if it was intentional, but we're in it. And we're finding a lot of our transit grantees are having trouble in the local community partnering with your networks. So we're trying to help them through that. And this funding is incentivizing it. And then now we just, through the Coordinated Council, we asked all of our federal partners this question. How do we get your networks to be at the table for this next 2020 funding? And so we decided that we were going to put out the funding, which was just announced at that summit on October 29th by Secretary Chow. And there's a requirement to have letters of commitment or MOUs with your network. So they have to partner with aging, disability, healthcare, veterans, etc., in order to get this funding. And then for the first time, we are doing an evaluation, which is new for us. You guys work in evidence-based evaluations, in transportation. We report vehicle miles traveled, deadhead hours. So it's new to us. And then one of the reasons we're doing this is because we went out and did 5 states, a focus group, and we met with all of the stakeholders that are not transit. So we met with aging, disability, workforce, etc., across those 11 CCAM agencies. And the number one thing they said is, we have no awareness of what is out there, what funding sources can fund transportation if it doesn't exist in my community. So in answer to this, we developed an inventory of federal programs. And surprisingly, there are, this is just the list for the Administration for Children and Families. All of these programs you see here may fund transportation. It's not their intent to be a transportation program, but it's an eligible expense. And so any program of these 130 that get these funds should and can coordinate transportation. So instead of having a bus going down the road serving each of these separate clients, like just for Head Start, why not coordinate? So this is how you get to the inventory. It's linked here. Just to give you a background, in 2008, we did this exercise and there were 64 programs. And then in 2012, the GAO did it and there were 80 programs. And so now we just finished it in October and we found there's 50 additional programs. For example, we didn't have CDC in the original. Now we know that CDC has 10 programs that may fund transportation and or transportation planning activities. So we're starting a webinar series that starts in January. So each of the CCAM agencies will host a webinar. We're doing the platform. Their experts will be on it, where they're going to talk about their funding opportunities that can fund transportation and encourage their networks to coordinate. So again, rather than having 5 vehicles going down the road, you've got the aging van with just 1 or 2 aging individuals. You've got the van for people with disabilities that only can carry those with disabilities. Same with the veterans. Why not have one van, have all of them on that van, and then allocate the cost of that trip to each separate funding agency? And so we are developing the software right now to do that with our partners. So rather than just get people together virtually on a webinar, we want to get them together in a classroom. So we are funding, it's a free class for all of our grantees. So it's called the Advancing Mobility Management course. It's a 2-day free course that tries to bring together untraditional stakeholders. So public transit with workforce, local Head Start grantees, all of them to come together, talk about promising practices, and then encourage them to develop some that are specific to their community. Whether their challenge is diabetes, lack of healthy access to food, it helps them to come up with solutions. And these are where the courses are being held. So we encourage you all to tell your networks and to invite them. We also have funding for next year to do the other 5 regions. Our regions are the same as your regions, which is nice. And I wanted to give you one last success story. We piloted that program I just told you about in Kansas City. And what they found was a lot of the human services organizations, like the Adult Drug Court, for example, was buying bulk bus passes at a reduced rate from KCATA. And KCTA is it's a 7-county public transit that goes across 2 states. You've got Missouri and Kansas. And so what they were doing is a lot of the human services agencies bought it's a very antiquated system, paper bus passes. Someone would come to community health center, they'd give them a pass to get home that day and another pass to get back to their follow-up appointment. Halfway through the year, they'd be out of bus passes, they'd go back and say, I need to buy more. So the CEO of KCATA said, why don't we do this differently? Why don't you guys give us up front next year the same amount of money you spent last year on bus passes? We'll give you unlimited access to our transit services for all of your members, all of your participants. And so what it did was it allowed KCATA to have money up front at the beginning of the year to pull down more funding from USDOT, more grants to increase service and access for the community. What it gave those human services provider in the community was more transportation for their vulnerable populations. So it was a real win-win for that community. What the politicians locally loved was that the buses were full during non-peak hours, because we have a lot of access during the times you guys go to, your clients go to health appointments or CBSME classes. So again, it was a win-win. The last thing I just want to leave you with is we have a huge rural transportation program. One of the biggest issues is that there's a required 50% match for operating that service, hiring, training drivers, buying gas. It's a 20% local match to buy the vehicles. But for that operating, a lot of the transits go out of business because they can't come up with that match. Congress heard us when we kept telling them this, and they just amended our authorization to allow other federal funds that are non-DOT to be used as local match. This is a really big deal for those rural communities when match is something that's out of their reach and it makes them lapse their funds, which are returned. So HHS just made an announcement. They have the statutory ability in 66 of their programs that are on that inventory I mentioned that can be used as local match. And so this is very exciting. And ACL just had a webinar yesterday to highlight this. And we had more people register for webinar than we've ever had. So it just goes to show you the need. And then transportation research. So national academies, we fund them to do research through the Transportation Cooperative Research Program, or TCRP. And there were 2 reports that came out just this year that I thought you'd be interested in. This one is about dialysis. And there's a huge issue with public transportation, with the number of individuals needing to go 6 trips each week to get dialysis. And so especially in rural communities, it's becoming a burdening issue on those transit providers in that rural community. And so what this report did was it looked at the medical literature, the transportation literature, and then it came up with promising practices. What are communities doing that have been successful? It also talks about the safe harbors, the new change to that allows dialysis clinics and other hospitals to begin funding transportation. So it really looked in that in depth, and it was a great report. The forecasting tool, I think, is most helpful. And then, as I'm sure you all are aware, the HHS 2019 budget has committed to using authority to change the Medicaid required any non-emergency medical transportation benefit, which is now required for states to provide, to become optional. So we've been working closely with CMS as they're preparing this, and the RFI that's going out in January, and then their notice of proposed rulemaking that will be out in 2020, because this will have some pretty big implications for our rural transit providers that are usually the provider for NEMT. And then in preparation, TCRP did a research study on this. So what they did is there's state-by-state profiles that examines what NEMT looks like in each state. And so I just did a screen capture of Virginia there so you can get an idea of what it looks like. Free resources, we fund 3 national technical assistance centers that can help communities to find transportation, get travel training, find a trip, etc. And I have the yellow arrow there because each of them do annual community grants. So planning grants, helping communities plan to get their project up and running to then become a full grantee from us later. And then here's an example of the 2019 grantees out of the National Aging and Disability Transportation Center. 2 of them are looking at healthy food options. One's doing a shopper shuttle in Portland, Maine, because just like Flint, Michigan, grocery stores are closing. They had the same issue. And then also in Tulsa, Oklahoma, they have huge food desert areas. So they're doing, again, some more access to that. This is my last slide, I promise. And if most people I find don't know this, it is a requirement of all of our grantees that they provide half fare for anyone with a Medicare card. And that is all I have. Any questions for me?
That was great. Thank you very much. What's the thinking behind the changing the Medicaid requirement that transportation be provided to making it optional?
So you definitely have to ask CMS about that. They are a partner of ours on the coordinated council, so they've just been letting us know what's coming, which is very helpful. So the HHS budget has a paragraph, and it basically says they're using regulatory authority to be able to make this change. They spend about 1% of their budget on Medicaid and NEMT. So I would imagine it would be savings in that way.
And do you have a specific program, I may have missed it, to help address that need when that takes place?
We do not. And it's going to be, if states decide to opt out of Medicaid, that's going to be very interesting for that state. Luckily, in urban areas, we have pretty decent public transportation, which of course is too expensive for some individuals, even the fare. But in rural areas, it's gonna be a real tough. We're gonna have to look into how we can help fill those gaps. But our rural program has not increased in funding.
Can you I have 2 questions. One is, can you clarify the NEMT change and its implications for states that are expanding Medicaid versus those that aren't? A and B, because that sounds like a really big and important one for people with diabetes, living with diabetes. The second is related to the Wisconsin example that was provided earlier by your colleague, which is very exciting to see those kinds of community makeovers that allow for multimodal transportation in high transit corridors. Could you clarify what the Department of Transportation's either regulatory or funding purview is with respect to these local makeovers, sort of where the levers are at the federal level to instigate, facilitate, fund, mandate, whatever? So they're 2 very disparate questions, but.
So I'll take the first one, and then Victoria, I have the slide up for Appleton, so you can talk to the second question. So the first one is really, I'm happy to put you in contact with our CMS colleagues that handle state Medicaid plans that are managing this change. But this is direction that's coming from OMB. So
But what does it mean? What are the on the ground implications for a recipient of Medicaid in a state where they've decided to do this optional thing, and in the state where they've decided not to do the optional thing? Whose pocket is it coming out of if it's being done and not being done? And
those are very big questions and great ones that our network themselves are asking in their communities. What is this going to mean? So we are only just starting to hear, and so when that RFI is published, I think there's going to be a lot of interest in making comments from the public and stakeholders about what that's going to mean. So I think really I myself am looking forward to seeing when that's open for 60 days, what types of comments and what the communities think about it. So, but I would just say you would have to talk to CMS. I can't answer on their behalf.
that'd be great. Yeah, thank you.
And then Victoria, I have Appleton up.
Okay, well, the health and transportation planning framework and the use of that is totally voluntary. As I mentioned, I could spend your entire meeting talking about, there's even a week-long course on highway planning and funding just for that. This is not a requirement. The state DOTs that get the Highway Trust Fund dollars and the MPOs that get Highway Trust Fund dollars get a certain amount of money that they can use towards planning and programming and doing activities such as using the framework. But it is not mandatory. It is not funded. I don't know if that helps.
I guess, sorry, and follow up that yes. So I understand that there's no regulations. What you're saying around that, but if a municipality is interested in doing this, or a community is interested in doing this, is the process and the funding to do it generally available, or are these a series of small pilot opportunities essentially?
The money to do corridor planning is in place. And what they decide to study in that corridor would be up to the Metropolitan Planning Organization or the state DOT, depending on who was doing it.
So that's the planning you're referring to.
I'm sorry, my connection's so bad.
You're referring to the planning process you're referring to?
Right. In any community over 50,000, the Metropolitan Planning Organization can be put in place to do transportation planning. They will get transportation dollars to administer their program and do the planning. And that's sort of some of the partnerships and encouraging the Metropolitan Planning Organization, or in this case, the Regional Planning Commission, to engage with new stakeholders, right? Like that's why I highlighted that as one of the outcomes. Bringing the county health department or whoever to the table, bringing I don't know who else they brought to the table.
I understand.
I know this is a business, a lot of businesses along the corridor getting engaged in the process.
Right.
What it would mean to them to have safe bicycle lanes on this corridor.
But then the funding for the implementation then is left up to the regional, resources available regionally. Is that right?
Exactly. But if they can, the beauty of bringing new stakeholders to the table, the beauty of encouraging people to think about other outcomes besides just how many cars can get through, is that you start to develop support by new partners. And so when the decision makers who decide ultimately what to fund have the interest of the business community or have the interest of others in the corridor kind of pushing them towards it, it becomes easier for them to say yes. But it's still going to compete with the bridges that are needing updating. It's still going to compete with the road potholes that need to be filled and all that. Yes, but the amount of money won't change.
Thank you.
I have just two quick questions. One is, of all the wonderful programs and grants that you described, how many of them, or is there effort to turn these pilots and demonstrations and short-term grants into long-term policy? How much of that work is going on? So maybe that's one. And then I'm encouraged by the fact that there's the inventory and CDC has been added to the list, because in many of our situations, we provide evidence-based programs and our partners are not implementing them nationwide. And that's a real huge importance to get these evidence-based interventions actually scaled. Almost all of them have transportation issues as a barrier, but the information you provide is right. Is it transportation itself? Is it the fact what transportation to what? Is there any effort in this coordinating effort to maybe think about how do we make sure that funding in a coordinated way is provided to evidence-based programs that other federal agencies are either paying for or their grantees have now implemented and is now built into the system? So it's sort of twofold. What's getting longevity out of those grants, and what can we be doing as sister federal agencies to really try to coordinate and make sure that things are being paid for out of our fellow agencies that are actually getting to things that we know work?
So one way we're doing that is through our notice of funding opportunity. So for the first time, we're requiring partnerships, not just incentivizing them through the evaluation criteria. And then we've asked our other federal partners, CDC's been the most open to this, of including just a sentence in future NOFOs, encouraging coordination with transportation. I mean, it's such a small thing, but, and I just actually saw this morning, the Administration for Community Living, I saw a notice come through that they have 2 notice of funding opportunity around CDSME. And the first thing I thought was, wouldn't it have been great if we could have gotten something in there about the requirement to at least coordinate with local transportation? A lot of times people can't get there, and it's really important because we can provide free travel training, and we can provide free monthly bus passes for travel training. So I just think there's a lot of opportunity. We are talking about it. We only just got back into the groove with the CCAM, so we're the first thing we're going to try and do is get verbiage in NOFOs, competitive ones at least, that go out to encourage those types of partnerships. And this is the sort of first one out the door. And CDC actually was the reason when we published this one that it wasn't just focused on NEMT, because Wendy Heaps kept saying it needs to be human services broadly. And I was always saying that, but hearing another federal partner, we listen more. So it's great to get your input. And so in this one now, it's mobility for all. That was the key. And it's not just healthcare. And so it can be recreation. It can be more broad. And so it's not siloed in what it can fund. It's broad. And then the partnerships are broad. So the other issue is that we don't have that evidence base, so we're now going to start tracking it. So I think this will be the first time that these funds are going to we're going to get more bang for our buck, because we'll be able to say we saved X amount of dollars. So we're going to start collecting that data, and not just this is how many buses we bought. So I think we're finally getting to that point.
I had a thought once, Don Shell with DOD. I really think that the model that you presented, especially in your Flint, Michigan example, definitely in your CCAM conversations and with your question, I think it's a model for the commission to look at addressing the transportation aspect of the environment, the way they're collaborating with other agencies. I think developing the federal programs that fund transportation, the comments you just made about mobility for all. I think if we're looking at making recommendations, as Claudette mentioned earlier, about increasing coordination, decreasing duplication, and addressing gaps in the federal programs, I think this presentation has provided a model specifically for transportation, but I think how we can address this, how we should look at framing our comments to scale across the board. And so I think we should really think very hardly and learn more about how we can adopt and utilize the approach that she's presenting and what we're going to recommend for what our charge is.
And hope that some unfortunate policy doesn't get woven in that ends up limiting. I think that's the one thing that I think there's so much potential there, as long as it doesn't get some ridiculous language in that you end up shortchanging what really the intention is.
And I think as you're saying, the critical thing is, meeting the basic needs. I think, as you've mentioned in Flint, Michigan, the other thought that came to mind was hopefully they were getting clean water in Flint, Michigan too when they're driving around. But I'm sorry to add that in. I think just the innovation that went into place there with looking at the food, the stores that were closed, taking into consideration what was occurring in the local communities, I think it's a great model.
And actually, the bus, they did have cases of water and they would deliver along the route. So they coordinated above and beyond what we expected of them because it was a need in the community.
I think it also suggests that every agency needs to have a master's in public health working there. So thank you for that.
Well, with that, I'll just say if you guys want any of our documents, anything we've worked on to adapt for your need, just let me know and I will provide it. Thank you.
Great. Thank you very much, Danielle. And thank you, Victoria, as well. We appreciate your calling in. We're going to turn now to presentations from the U.S. Department of Agriculture, and we're going to let Pamela Stark-Reed lead with that. She's the Deputy Administrator, Nutrition, Food, Safety, and Quality. And she has, I think, 3 colleagues who may also be presenting. Dr. Stark-Reed, we'd ask you as well to try to take up to 45 minutes in total, so half an hour for your presentations if you can do that. And we're going to move the data call update to after lunch, so we'll plan to break at about 11:45, 11:50.
So good morning, everyone. And normally you would be having Naomi Fukugawa here as your representative from USDA, and she's not available today, and I'm actually her alternate, so I'm stepping in for her. In light of the fact that we have a behind schedule a bit, I have slides, but I'm not going to go over my slides. They're available to you about the Agricultural Research Service. Because Naomi's on your committee and I'm here today, you can talk to us about ARS. Our mission isn't as much focused on social determinants of health. We're a very research-oriented agency. So you can go through my slides and look at some of the things I provided. I'm just going to give a few slides of introduction here for the USDA. And first of all, here's our organizational chart. It's a very large department, and the colleagues that I want to yield my time to this morning are the ones who are over on the very right-hand side for you. And it's for the Undersecretary for Research, Education, and Economics. And under that branch, we have the National Institute of Food and Agriculture and the Economic Research Service. And those 2 colleagues will be talking to you today. In addition, you'll hear from one of our other areas, which you'll have a discussion today from someone who's from the Food and Nutrition Services. And these 3 folks are a lot more focused on the areas that you're interested in today. So you're welcome to go look at my slides and talk to me about them later about the Agricultural Research Service, but I'm going to yield my time over to the other 3 speakers. Thanks. So we're going to move now to Dr. Deirdre Chester from NEFA, and I guess I will advance her slides for her. Sure.
So please start with slide 2.
Can you move to the NEFA slides, Deirdre's slides? Oh, I can. Never mind. Sorry.
So slide 2.
Hang on, Deirdre. I got to get through mine, which I'm not giving.
Okay, thanks.
Here we go.
Okay. So I'm Deirdre Chester, and I'm a national program with the National Institute of Food and Agriculture. And so I want to present some of the research that we have that focuses on social determinants of health. But in NIFA, we fund competitive research through colleges and universities. And some of this research actually supports social determinants of health. Next slide, please. So
Can you turn up, Deirdre, can you turn up your audio a bit, please?
Can you hear me better?
Yes.
Is that better? Okay. So slide 3. What NIFA, our competitive research portfolio, is the food research initiative. And I want to just provide some context for the type of research that we fund here. So there are 2 major portfolios: the challenge area, which are integrated projects, and then the foundational programs, which are basic research. Slide 4. So what I will present today is the ASPRI Childhood Obesity Prevention Program. Since 2011, we funded $222 million in this portfolio. There's been a total of 88 grants at colleges and universities, and we funded a large agricultural project for $25 million at the University of Hawaii. This is the program that I will give you some information on today. So the Childhood Obesity Prevention Program is one that we consider that is fully integrated, and it has been that way for the past 5 years. It means that all of the 3 function areas that we focus on at NIFA, which are research, education, and extension, has to be included in all of the programs. Next, slide 5. One of the things that I want to say is that in 2007, that was the last year that we actually funded the ASPRI Childhood Prevention Program. So most projects are current and will end in FY 2022 or 2023. This slide just shows the program area priority for this priority area. So it was to generate knowledge of behavioral, social, cultural, and/or environmental factors, which includes food environment that influence childhood obesity. This information was used to develop and implement effective family, peer, community, and/or school-based interventions for preventing overweight and obesity and promoting healthy behaviors in children and adolescents. This entire portfolio focused on children 2 to 19 years of age. And there was a strong emphasis on health literacy and health disparity. Slide number 6. So this particular portfolio allowed investigators to, it was really to fund investigators-driven research that focused on the social determinants of health in communities across the U.S., as long as they address obesity prevention in children and adolescents. This work focused on the economic and social conditions that influence individual and group differences in health status. The portfolio focused specifically on health-promoting factors found in communities to address overweight and obesity. And so some of these were nutrition education, early childhood development, food insecurity, food, looking at the quality of food and how children choose food, and also education. Next slide, please. So the program that I want to highlight is that $25 million program that we funded, and it's called CHILL, the Children's Healthy Living Program for Remote Underserved Minority Populations of the Pacific region. This particular program addressed childhood obesity in Alaska, America Samoa, the Commonwealth of the Northern Mariana Islands, Micronesia, Guam, and Hawaii. The focus of it was childhood obesity, and through training, community-based participatory intervention research, dissemination and outreach, policy change, and the use of local advisory communities. One of the things that I would note is that this was a large undertaking. We have actually funded a supplement to this particular project for an additional $5 million for them to continue to support the specific community. The next slide just demonstrates the REACH program. The prevalence study of children in 50 United States. One of the great out of this project is that a total of 102 students have been trained in childhood and dietary assessment skills across the Pacific. Many of these students at the University of Hawaii, but many of them have also gone back to their respective so that they can continue the great work that is happening in the Pacific region. The next slide, please. So the results are controlling for age and sex of children 2 to 10 years old. We saw child overweight and obesity decrease. And we also saw feeding time decrease in these children. Next slide, please. These are some additional results. In the Northern Mariana Islands, they are in the process of incorporating child care wellness policies in child care facilities. In Hawaii, they're continuing the work on establishing nutrition guidelines and child care regulations. And the chill data is being used to support legislation for a 1% per ounce fee on sugar sweetened beverages. And then the last thing is that adolescent health screening legislation was successfully passed in Hawaii. The next slide, please. One of the things that I want of this particular program, but also many of our other programs, the other 87 projects, the current research information system provides documentation and reporting for ongoing agricultural, food science, human nutrition, and sports research that include education and activities for USDA. All of these programs have reports on the FRIS system and can navigate and click on FRIS, RIS, and you can find it's on each of them have been funded through the portfolio. So that concludes my presentation. Are there any questions?
Great. Thank you. Questions? Yes, Anne.
Thanks for that. I'm not quite clear on, and maybe I missed it, in your CHL grant program. It looks like you're doing funding a lot of education. Are you actually, are the funds able to go to actual food programs, or just telling people about food programs? Because obviously a big issue is often there's simply not enough funds to provide healthy foods directly. So just making sure I was clear on that.
Yeah, so this polio was in there. Childhood, and so it did not. However, at this Arch Grant program, to the community, and also the with its security program that polio for food.
Can you?
So Deirdre, you're
your
breaking up a little, so let me just try to answer this. So this is the National Institute for Food and Agriculture. It's basically the extramural research arm for funding for the land grant university as well as competitive funding. So it's a research-based agency. You're going to hear later from the programs and the food programs and the huge number of them under the Food and Nutrition Services Fund. So the projects that Deirdre's talking about mostly are to do research, not to actually fund programs.
Sure, can understand that, but still, how are in the research projects, how are people actually getting the food?
So in this portfolio, there's no food provided. However, we do have other portfolios where food is provided. We are extramural research. So our mission is not to provide food in these research programs.
Sure, I can understand that, but in order to study the effects.
So it'll depend on the research project itself. If it's something that is really dependent on having a very defined feeding study, then some of the researchers may provide food to the participants. And for example, on the ARS side, when we do a feeding study, we bring people to our centers and we give them food for that. So it really will be dependent on how. I mean, these are grants. These are extramural grants. So it depends on how the researchers have defined the project to be done.
It just seems if you're going to study child obesity, you would need to make sure that that you're included in the intervention is the ability to get consistent access to healthy foods, whether you provide it as part of the research project or in some other way. That was my question.
I think we're going to need to move on.
Sure. And so the next presenter will be Dr. Jay Barariam, and he's from the Economic Research Service. Jay, are you there?
Yes. Can you hear me?
Yes, loud and clear.
Okay. All right. Wonderful. So thank you for this opportunity. I am from the Economic Research Service of the USDA, like Pam mentioned, within the Research Education Economics Mission Area. And the economics is, ERS is one of the 13 principal statistical agencies of the federal government. Our overall mission is to inform and enhance public and private decision making on economic and policy issues related to agriculture, food, environment, and rural development. So within that broad portfolio of looking at food and agriculture, the Food Economics Division, next slide please. So the Food Economics Division, we cover the entire domestic sector, looking at consumers, the food markets, and also government regulations with regarding food, and also food safety. So we study consumer and market behavior and factors that influence it, and also how these affect outcomes like diet quality and body weight. Like the HUD speaker mentioned, we focus on food security. That's a major focus, and how food assistance programs affect in reducing food insecurity and promoting nutrition and health. The other part of our work is the major focus is in providing data for looking at all aspects of the food environment, food prices, food access, and all aspects related to food consumption in the U.S. Next slide, please. So I will highlight a few examples in the time that I have of the type of work we do with the portfolio of our research and also the data assets that we have. So I will briefly touch upon a few elements, but it does cover quite a lot, and much of it is very relevant to social determinants of obesity, because we are talking about food consumption and the economic factors and social factors behind them. So one example here is, are you on the Food Environment Atlas slide?
We are now.
Okay, good. All right, so this is an example of a derived data product where we have assembled over 275 statistics on the food environment related to food choices, relationships to health and well-being, and community characteristics. These data, depending on their nature, they could be at the county level or the state level, and so forth. And this map and the associated data are available on our website. And here is an example of a map where we look at change in fast food restaurant density over time, and just the whole growth of the availability of fast food restaurants in finely grained neighborhoods across the country. Next slide. Another product very popular is what we call a Food Access Research Atlas. Please click the bullet, first bullet. So the Food Access Research Atlas presents a spatial overview of the food access indicators at the census tract level. Next bullet, please. So this atlas has 4 measures of low access to supermarkets or other large food stores and other contextual data. Next bullet, please. And these this atlas and the underlying data, they provide food access data for specific populations of interest, and this can be downloaded for community planning or research. So we do get a lot of inquiries from localities about the status of their, in popular language, it's called food deserts, and we get a lot of inquiries from localities and other regions inquiring about the status of food access in their localities. Now, related to the earlier speaker from DOT, one of the key determinants obviously is vehicle availability for the household, and that plays quite a big role, and it is one of those measures included in this food access research atlas. Next slide, please. So here is simply a shot of the this interactive food access research atlas, and it can be zoomed and gone to pretty fine census tract level. Next slide, please. Okay, so now here I'm getting into some of our data assets, which we call the consumer and food markets data. One of the major investments we made over the last several years is in conducting this comprehensive national household food acquisition and purchase survey, which we call Food Apps. And the main contribution of this is it is a comprehensive survey covering both food at home and food away from home, which was not previously available in such detailed fashion. Now, bear in mind that these are foods purchased by the households, and so this is different from, say, a data set like NHANES, which is food consumed by individuals. This is a household survey and gives you detailed data on the quantity, the prices, and all the other factors associated with household food acquisitions. And this data allows assessment of the impact of food choice and all the factors associated with it on quality of the quality of the food and nutrition. Next slide, please. So this slide is simply an illustration of one of the sort of results that can be gleaned from these data, this food app data, which is basically comparing the quality of the foods purchased by SNAP households compared with other groups such as non-SNAP high-income or non-SNAP low-income households. And it kind of illustrates that, as we all know, every household pretty much has, every segment of the population has problem with meeting dietary recommendations, but it does show the differences across the SNAP eligibility with regard to the quality of the foods purchased. So that shows the extent of the challenge. Next slide, please. So here is another illustration. Because we have now the household food expenditure data along with the quantities, we can compare the calories bought by SNAP and non-SNAP households on a weekly basis. These are not calories consumed. Again, these are calories purchased by the households. And the top set of the three charts, the three bars show that SNAP households consume or purchase as much calories as other households roughly, but the bottom panel shows that the weekly expenditure by SNAP households on an adult equivalent basis is much lower, which shows, of course, which implies that They are buying the SNAP households, and other low-income households are buying fairly calorie-dense meals. And it again illustrates some of the challenges that these households face in buying foods of high nutritional quality. Next slide, please. And this is another illustration of some of the results coming out of this Food Apps data, which shows, for example, since the introduction of whole grain requirements in the WIC program food packages, there is clearly a positive effect on the amount of whole grains consumed by these WIC households, but it is entirely coming from the foods or grains purchased from WIC benefits, which are targeted towards whole grains. So again, it confirms some of the positive effects of the WIC program. Next slide, please. And we did explore a little bit about the characteristics of households with an obese child with the data that we have in Food Apps, and it does show some of the differences across households when the household has at least one child who is obese. So next slide, please. So these are some of the earlier slides were some of the examples of a key database that we have. But in addition, I want to talk a little bit briefly about another database that we have. I don't have a slide on that, but it is a pretty large database of scanner data from retail stores across the country, and it records all the weekly purchases of different type of foods at the store level. And each year there are about 6 to 7 billion transaction records, and we have data going more than 10 years. So what we have done in collaboration with Agriculture Research Service and other groups is to link these purchase data to USDA nutrition databases, and we developed a crosswalk so that now you can understand the quality of these the foods purchased or food sold at the retail stores. So we have unique household food purchase data, both through a survey mechanism and also based on scanner data. So these data sets complement each other, and they give a complete picture of the type of foods being bought by U.S. consumers. This slide that you have here is simply showing some additional data that we collected through the NHANES survey as a supplement, especially looking at food labeling and how different types of levels of label use or exposure to labels affect the type of foods people report consuming in NHANES. So in other words, we do have these supplemental surveys with other major federal surveys, and we try to look at issues related to food consumption. Next slide, please. And this is another example of some of the research that we do with the data. In addition to providing the statistics, we do some original evaluation or assessment research. And here is an example of the role of school meals in children's diets, and especially since the implementation of the new food school meals regulations. And this chart clearly shows, using data from NHANES, that since 2011-12, the amount of whole grains that children are consuming has been tremendously influenced by the change in school meal composition. So that is a positive outcome of that particular initiative. Next slide, please. And finally, here is an example of a big portfolio of our research which focuses on food away from home. And here is simply a trend showing using NHANES data showing how food away from home consumption, especially calories, in terms of calories, has gone up over the years, and it dipped a little bit during the Great Recession, but the trend is back up and climbing. So that's another set of original research that we do. So basically, to conclude, we have an entire portfolio of data of which I touched upon only a couple of them, covering the household food purchases and the food environment of the U.S. domestic food sector, and also we have original research looking into these factors that affect purchase behaviors and the nutritional quality of those purchases and so forth. So I will stop at that, and if you have any questions, I'll be happy to answer.
This is John Baltry. One of the interesting things about the last slide is the increase in food consumed away from home from 1977 to 2011. Do you have any way of explaining that trend?
Yes, so that is a very good question, because it is as economists, we like to point out that it is both a result of supply and demand. That's our last resort. And so the food composition and the type of food supplied by the market is changing. And at the same time, viewed another way, that change is being driven by the type of consumer demand that the firms are facing. So, there are certain attributes that food away from home provides, such as convenience, time savings, and so forth, which are valued by consumers. And so that is, so clearly it is a confluence of both supply side factors, improvements in technology, the ability to provide food in different formats that appeal to consumers and so forth. And at the same time, consumers' evaluation of certain attributes like convenience, time saving, and so forth.
I have a question. When you analyze the people getting SNAP, do you have any way of finding out if they had to supplement with like food from the food banks, their local food banks? If they did, how often or how many people was the SNAP sufficient, and or did they have to go to other sources?
Yes, so that is a very good question, and it can be answered by the Food App survey, because one of the things that was unique about that survey is it did collect information about the foods coming from food banks and other quote-unquote free sources. And it showed that it did show that that's a pretty high proportion. And then we have another survey related to the food security research that we do that also has information on the reliance on food banks and other sources by SNAP and other households. I don't have the numbers right with me right now, but I can certainly provide.
Thank you. That would be good if you could do that.
Yeah, I just had a question about whether there's data on things like sugar sweetened beverages or sugar or salt composition of different foods over time, and where that might be collected, if at all.
Yes. So certainly Food App, that was just a one-time survey. So but the innovation there was we did link all the foods again to USDA nutrition database so that we have the nutritional composition. So you have in that sense you have, and also we have the UPC barcodes so that it contains information on the label, whether the type of food and sugar sweetened beverages and so forth. So that is available. And similarly, the scanner data can be similarly broken down, and and the trend in SSB consumption can be examined that way.
Hi, this is Dean Schillinger from University of California, San Francisco. Thank you for your presentation. I'd like to ask if you could move to the slide prior. The very striking slide you showed about the whole wheat grain consumption. And I'm just wondering, was this improvement, I think you mentioned that it was the result of a policy change at the USDA regarding the composition of foods that school-age children are required to be offered. And is this the same legislation and policy that has been changed and revoked under the current administration? Was this the the Hunger-Free Healthy Kids Act that resulted in this improvement? That's my first question. And my second question is not unrelated. Do you guys do at ERS any modeling work when policy changes are being considered, like the reduction in eligibility for SNAP benefits, to project what the implications would be on the nutritional status of the population, or in our case, the risk of acquiring diabetes?
So the result on the chart is based on data from the Enhance, and so the timing, depending on how you look at the timing of the implementation of the changes in school meals, clearly this was a big statistically different change, and so in that sense, if you accept that that Enhanced data provides that kind of a before and after effect, then it can be attributed to that change. And now legislation itself has undergone some changes, but I will kick that down to my FNS colleague who will speak after me as to what the policy side of that is. What was the second question?
The second question is, do you do modeling work to project the health impacts of policy changes, like the SNAP benefit change?
We don't do health effects as such, but we do look at the macroeconomic effects of changes in SNAP program. For example, one of the recent studies that we did is to look at the effect of let's say a $1 billion addition of SNAP money, new money for the program, and so that's called the SNAP multiplier. So if there is $1 additional allocation to SNAP, that results in either because more people claim it or the benefits increased. Either way, when that $1 goes into the economy, it has some ripple effect. So what is the consequence of that? And we do come up with an estimate of the multiplier
for the economics. Okay, for the economics, but not at the household level. It's more at the macro level.
Yes, at the macro level.
Great. Thank you very much for that presentation. That was terrific. I think we need to move on now. Our next speaker will be Lindsay Datlow, who's going to be speaking actually on the programs.
Thank you so much for inviting me to speak. So today I'm going to talk about the programs. There's been some questions, so hopefully this presentation will help answer them. Our mission is to increase food security and reduce hunger by providing the food through our programs. We do have 15 programs. I'm going to touch on each of them at a pretty high level, but we can always facilitate someone coming in from a specific program if people have specific questions on that program. We do have a very large portion of the USDA budget in doing these programs, so they are something that serves 1 in 5 Americans every year. We do have some shared program characteristics. Each program offers some form of food benefit. They're focused on low-income individuals and families and are federally funded and state-operated, which is a very unique aspect of our programs. Every program is state-operated, and we have a lot of local flexibilities and local control because the local communities really do know their participants best. So I'll start with SNAP. It's our largest program. We have a couple different interesting aspects of SNAP. We have the farmers market program. We do have 2 farmers market programs. We also have some farmers market programs in our other program areas that I'll talk about. Our mission is also supporting agriculture at the USDA. So this type of cooperative agreement allows SNAP participants to purchase locally produced food with their SNAP dollars. And many farmers markets also provide incentive programs. So we have the GUSNIP incentive program. Some folks may know it as the FINNY program. It was actually renamed in the most recent Farm Bill. But this program, people may know it as something called Double Up Bucks, where the government provides $1. So if you go into a farmer's market and purchase apples, you can get twice the amount of apples for your money. We also have SNAP Education, which is something that we provide a SNAP Ed toolkit. Again, this is something that the states plan at the state level. They provide us a state plan of what they're going to do and with their grant money, and then they have sub-grants that they provide to those partners at their level. We do have a SNAP Ed toolkit, which provides evidence-based SNAP Ed type programs that they can run. We have a robust website called SNAP Ed Connection for those who want to find out more on our SNAP Ed toolkit or what's going on in each individual state. Next, we can move on to the child nutrition programs. So our programs offer several benefits. In addition to supporting American agriculture, we improve health and nutrition of school kids. We support low-income families, and we support security. So we have 7 programs in the child nutrition division. 4 of them are here. The National School Lunch Program is probably our most well-known program. We serve lunch to 30 million children a year. Our school breakfast program may be slightly less known. It's actually only serving about half of those kids. We're definitely always working to increase that. Something that's helping increase that is the CEP program that we have, so Community Eligibility Provision. If a certain district or SFA, School Food Authority, falls under a certain threshold, or I guess I should say above a certain threshold, for low-income families, they can kind of group together and the whole community can serve free lunch to everyone. A provision of that is if you are doing CEP, you do have to do breakfast as well. So that has really helped increase our breakfast numbers. We have the Fresh Fruit and Vegetable Program, which offers fresh fruits and vegetables as snacks. So this would be outside of the lunch and breakfast program, where it's a grant program for low-income schools to get additional fresh fruits and vegetables. And then we have the Special Milk Program, which is, again, similar to the Fresh Fruit and Vegetable Program, but milk. We also have Smart Snacks. So our meal programs have standards, but some people don't realize that the competitive foods that are sold outside of the reimbursable meal pattern also have nutrition standards. So we have standards for low-fat dairy, fresh fruit and vegetables, whole grains, different protein foods. We have calorie limits, salt, sugar, fat limits, beverage limits, and these are the foods that are sold throughout the school day. We also have 2 community-based programs that fall under the child nutrition program. So that's Child and Adult Care Food Program and the Summer Food Service Program. The Child and Adult Care Food Program is for serving those students who are under the age of kindergarten or adults who are in a daycare center. They again have meal pattern standards in the foods that are sold in CACFP. An interesting aspect of CACFP is that it serves a wide range of daycares. So it could be institutional level where the school is serving a preschool, but it could also be someone in their home, in their local community, serving the children that live in that community. And our summer food service program is serving the gap between when school is out in the summer. So there's congregate feeding sites that will provide meals to the community. There's also EBT programs, so electronic benefit transfer. Some states are using a WIC model where they have specific food packages. Some states are using a SNAP model, but they get about $30 additional per child to their SNAP EBT card for the summer months. And then Farm to School is a grant program, so we offer grants to agricultural producers or schools or nonprofits or other government agencies like state departments of agriculture, for example, to help facilitate farm to school. So gardens being grown by the school children, they learn where this local food is, how this local food is grown. They can grow their own food and then taste test it. There's a lot of different interesting ways that people are implementing this. It is a complete grant program, so lots of local control over what they do. Okay, a couple more. So this is our supplemental nutrition and safety programs. Again, we have a number of programs in this division. So we have the USDA foods programs, which are actually what a lot of our schools use. So the schools can purchase their own foods from producers, but they also have the opportunity to get USDA foods, which are USDA specifications. We work with different agencies on this. So AMS, Ag Marketing Service, helps us with procuring these foods. We also have a partnership with DoD where we do DoD Fresh. So DoD helps us get the fresh fruits and vegetables out to some of the more rural areas where we may not have, they may not have like robust abilities to get local, to get fresh produce. TFAP is the Emergency Food Assistance Program. So this is the food bank program. So we provide foods to food banks so that they can share them with the community. We partner with local organizations on that. We have FDIPR, which is on Indian reservations. So FDIPR is essentially the same thing as SNAP. You can get SNAP or you can get FDIPR. FDIPR is for Indian reservations or Oklahoma. So it's a very flexible program. You can go on and off of it. So you can go SNAP in January, FDIPR in February, SNAP in March if you so choose, but you cannot get both at the same time. FDIPR is interesting because we have a lot of flexibilities for traditional foods. So our Indian reservations are able to pick which types of traditional foods they want to allow in their package, which is really special for FDIPR. And then we have the Commodity Supplemental Food Program, which again is very similar in food distribution, but it's for seniors. And they come and they can either pick their foods or maybe they get a box of food. It depends on, again, how the local wants to run it. And then we have the Supplemental Foods Division, which is probably our most well-known because it's where we house WIC. WIC is our program for women, infant, and children under the age of 5. They need to be nutritionally at risk and low income to receive WIC. WIC has 7 food packages that are nutritionally adequate for the specific level of the mother and the children. So if you are a mother who is pregnant, you get a different package versus if you are postpartum and breastfeeding, or if you are postpartum and not breastfeeding, or if your child is an infant versus if your child is 4. So it's very specifically tailored for the nutritional risk because that is an aspect that qualifies you for WIC. We also have a very robust nutrition education aspect to WIC. We have breastfeeding support and nutrition education is required. They do need to come to the clinic multiple times per year to get some sort of like checkup for their nutritional risk, but also nutrition education and or breastfeeding support. These are the other 2 farmers market programs. I'll kind of skim through them because they're very similar. They are farmers markets. And then we also have an Office of Food Safety, which helps all of our programs with the food safety aspects of food handling, processing, etc. Lastly, we have the Center for Nutrition Policy and Promotion. This actually used to be a separate agency under Food and Nutrition Consumer Services mission area, but we recently merged and now CNPP is part of FNS, which I think is great because CNPP actually provides us all of the information that we base our programs off of. So every program, all of the nutrition standards that I mentioned are part of all of our programs are based off of the Dietary Guidelines for Americans, which are updated every 5 years by CNPP as well as by HHS, Office of Disease Prevention and Health Promotion, which partners with CNPP on this project. CNPP runs all of the nutrition evidence systematic reviews for the Dietary Guidelines Advisory Committee. They also do food pattern modeling, which both feed into the Dietary Guidelines for Americans. And then the Dietary Guidelines for Americans is used for all of our programs as well as for consumer nutrition education, such as the My Plate Icon. They also do the Thrifty Food Plan, which is the basis for how we determine our spending in our programs such as SNAP. They do the Healthy Eating Index, so Americans are currently a 59 out of 100 on a scale of 100 in their eating, and we know that because of CNPP's Healthy Eating Index. and they also have professional education, etc. We do measure our nutrition outcomes as well. We have a research department at USDA that has a number of research analysts that do research on our programs. It's pretty specific research, but we do know that we have some great outcomes. School meal participants have more nutritious food. WIC pregnancy outcomes are really great. We actually saw this week MMWR published an article that one of our staff co-authored that WIC is, we're seeing obesity declines in our WIC participation population. So I think that's something else there. There's a lot of outcomes because we have a lot of programs. So that's all I have. Happy to take questions. And like I said, if there's very specific questions on any of our programs, or if you guys want to hear more about a specific program such as WIC or school lunch or whatever the case may be, we could definitely facilitate that because I know this was very high level. That's it. Questions?
Yeah, thank you for coming. Obviously, what USDA provides to the population is incredibly important, and the work you're doing is incredibly important. So thank you. I had two questions, as I guess is my pattern. You mentioned two very innovative programs that I think, at least preliminary evaluation, are very positive, and I'm wondering your thoughts on scaling them up, which is sort of the Ann Albright model. There's the Double Up Bucks program, where you basically get 2 for 1 if you're buying fresh fruits and vegetables. And then there's the GusSNP incentive program, which provides additional funds and access points for people to increase their fresh fruits and vegetable. I guess it's additional money, actually. Can you say anything about what it would take to scale those programs? Number one, and number two, you mentioned that everything USDA does is based on a foundation of the U.S. dietary guidelines. The most recent of which I think everyone would agree are quite solid and evidence-based. What do you think it would take for one of the most fundamental programs of the USDA, which has to do with incentives to farms in terms of what they grow, to include incentives to grow fresh fruits and vegetables? Earlier on, before you arrived, I showed a slide of the cost of healthy food compared to processed unhealthy food over time relative to inflation, and there's been, from your perspective, a divergence, so that healthier foods that are not incentivized for growers to grow have become relatively more expensive than those foods for which the Farm Bill incentivizes farmers to disproportionately grow. So the first is, how can you scale up good stuff, and how could we incentivize? What would it take to align the U.S. dietary guidelines with what it is we're growing in America?
Yeah, absolutely. So I know I spoke really fast. I think the first thing I just want to clarify that Double Up Bucks is a type of GusSNP grant.
Okay.
So that's an example. But so it's not actually a separate program. But I think from the GusSNP side, that is something that is in the Farm Bill, and we do it. I think it's a great program. We've shown a lot of really great nutrition outcomes, like you said.
Right.
Scaling up, I think, is going to take more appropriations. All of our money is either mandatorily appropriated or discretionary funds. So like our Farm to School program, which I think would kind of get to your second question on, well, how are we incentivized? We're incentivizing these local agriculture producers to produce more fruits and vegetables and show our kids how to do it. And we partner with different, dairy farms to get milk directly to the schools and those types of things. So I think that's an incentive, but that is something that we get funding for. And we wait for the appropriations bills to even get that funding for Farm to School. Same with summer. We have a lot of demo authority in summer food service, and we're trying to come up with ways to get to those more rural areas that may not be able to have a congregate feeding site. When someone has to drive 30 minutes to get there, they're not going to go just for lunch. But we have to wait every year to get that appropriations. We can't even consider scaling it up at this point because the appropriations bills haven't been signed. And something we ran into last year is that when the appropriations bills aren't signed until February, we can't really get people to scale up their summer programs that start in May. So I would say from a very general USDA FNS standpoint, a lot of our scaling up abilities have to do with appropriated funds.
Well, I would say, I guess on behalf of our subcommittee, that if there are particular programs like GusSNP or the School to Farm, or that you believe are likely to be very effective in the prevention or control of type 2 diabetes, type 1 diabetes for that matter, our charge is to make recommendations around how agencies can work better together. You've given some examples of that, but it would be important for us to hear your perspective and to be able to follow up with you on specific programs that you think are worthy of scaling.
Yeah, absolutely. And I think from a nutrition education standpoint, there's been a lot of discussion about nutrition education. A lot of these agencies do it, at least at USDA. We're working right now as part of the 2018 Farm Bill on how to better coordinate those on our own part as well. So I think that that's something else that's really good for prevention is nutrition education. Of course, will help, and we have so many different programs at USDA. So once we can, coordinate those better, I think that will also just lead to better nutrition outcomes.
To sort of follow up on that, are there other programs that you think might be less impactful that maybe don't need to be so fully funded? And in terms of coordination with education, a lot of different agencies do education. Are there opportunities to consolidate education with other federal agencies?
That is a very good question. I would say that all of our programs are very tailored to different types of individuals. So I wouldn't necessarily want to say, take some out of school meals to provide to the elderly. I think that is just opening a big can of worms. But I think because our programs are so tailored to the different individuals that we serve, I think that offers a lot of opportunity to meet different individuals. Also, like I said, all of our programs are run at the state level. So we have oversight at the state level. We oversee the state, but the state then works with their local so for example, for school meals, their local education agencies or their local food banks or their local network partners to make sure that it's a program that's working for their local context. Because obviously, rural Alaska is much different than New York City. And so we want to make sure that our programs are offering what the participants in that area need. So I don't really think I can say which programs to take money out of to put more money into them. Unfortunately, I can't really answer that question, but I do think that if there's ways to coordinate better, I know that's something that we're looking at FNS and USDA holistically in a one USDA approach. So I think ways to coordinate better, always, leverage that money, coordinate it better, and then maybe there's more money for other programs. But I can't answer the first one.
Bill, there is actually increasing coordination going on. I think I'll have to check with our Division of Nutrition, Physical Activity, and Obesity, which we really probably need to hear a lot more from. There is coordinated effort with a number of people through NCORE, and there's another acronym where a number of the federal agencies that work on nutrition have come together, and it also brings in some of the other outside groups. So probably worth looking at that a little bit more. Yeah.
A question about your about the food package issues and SNAP versus WIC. I think everyone agrees that the last set of changes to the WIC food package have overall been great. Not that there aren't some other tweaks some people would make, but that has a profound influence on the quality of the foods that are distributed to the WIC program. Whereas, of course, SNAP doesn't have such a limitation of that nature. So this builds a little on the question that was asked of your colleague just before. But can we tell about the quality of foods that are being purchased with SNAP vouchers? And also, what are the thoughts about ever looking at some sort of food package, maybe all the way up to something like WIC or something in between, so that SNAP dollars are used to best advantage? And related to that is because it costs more for a lot of healthier foods, how does that factor in on use of SNAP vouchers? Do people buy the lesser quality foods because it makes their vouchers go further, just like it makes dollars go further?
Yeah, I think so. To your first question on do we do any We do have some reports that come out. I want to say the one that comes to the top of my head came out maybe 2 or 3 years ago that said SNAP participants are actually eating almost exactly the same as non-SNAP participants. I can get you a reference. I don't have it off the top of my head, but there was a pretty robust report on the eating characteristics. It's not something that we do every year, but I think it came out maybe 2 or 3 years ago. And then on your other question about, the WIC food package versus the SNAP EBT model, there's always lots of discussion on that. I think food manufacturers are constantly innovating, so trying to come up with a huge database of what food can and cannot is just in general something that may be challenging. That's one side of the coin, of course. The other side of the coin is, like you said, maybe it changes the way they eat. So I think there's a lot of discussion around that. I don't have the answer today, but I think it's definitely a good question for you all to discuss and kind of, come up with recommendations.
Our HUD speaker referred to the fact that they're only reaching about 25% of the people that are eligible for benefits. I was wondering if what percentage of people for your national programs you think you're reaching?
That is a good question. I do not have that answer off the top of my head. I do know we reach 1 in 5 Americans. I think there's a lot of initiatives to try to reach more. So like I mentioned, the community eligibility provision, if you have a school district that is directly certified. So if the proportion of those directly certified by SNAP, so that means that their families are in SNAP and there's a literal computer system that does it versus their own application, then if that is over 40%, the school district is in its entirety available to offer free meals to every student at that school level. School district, however they group, doesn't necessarily have to be a district, but so that's an opportunity to really hit those lower income areas and make sure that everyone's getting it. So I don't have a direct percentage. I know some of our program participation has been declining in recent years. We're definitely looking to find out why. That's on our research and evaluation plan for this upcoming year, some of those things. So that's something that we're constantly looking at. We're also constantly trying to figure out how we better access those participants. So I know that there's I saw a study, someone brought it to me maybe a month or two ago, but I don't know how old it was, that if you can get someone in WIC to stay through the 14th month of their baby's life, they'll stay through the whole 5 years more likely than if they don't hit that 14th month. So I think that's something that's very interesting. We hear a lot that participants end up dropping out of WIC once they hit past the infant formula age, because that's the most expensive part of WIC, and there's a lot that goes with WIC. It's not just getting the food. You have to come into the clinic 4 times a year, and you have to get your nutrition education. So once they hit that level, they don't really want to keep staying because of the burden. So how do we fix that? We recently did a grant to Tufts, who they're going to do some sub grants to look at telehealth. So can we do nutrition education with telehealth? We know the WIC participant age is basically millennials now. So how can we reach them better? Yeah, exactly. Yeah.
I had just a quick question. What do you all do, or do you work with Feeding America, some of the community or larger food bank, food pantry organizations, that being the largest, of course?
Yep, absolutely. We do a lot with them. They are, well, first of all food banks would be eligible for a lot of our grant programs. We're also doing the food distribution program right now. I didn't actually talk about it because we're about to start the second year of it, but with all of the trade issues, we are basically offering $1.4 billion of local agriculture, American-grown agriculture, directly to food banks. So we're partnering with AMS, and they're procuring $1.4 billion this year of American-grown products that we will distribute directly to food banks. And Feeding America has been a huge partner in that because they have food banks everywhere. So they've been a really, really great partner on that.
Any additional questions? Great. Well, thank you very much. We appreciate your talk.
Excellent. Thank you.
Thank you all to the Commission for your extension of time, as well as thanks to the presenters who were flexible about their starting times as well. Dr. Herman and I have talked about adjusting the schedule so that we can still accommodate the afternoon and your lunch break. So I will do a data call after the lunch. We do ask that you be promptly in your seats at 12:35 so that we can do a roll call, the update on the data call, and then get started with the CDC presentation at 12:45. We appreciate your willingness to go along with that plan. Bill, anything else?
Nope. See you all back in a bit. So we're going to go ahead and get started. I think Linda is going to start again with a roll call.
Bill Herman. I got you this
Present.
time. Ann Albright.
Here.
Howard Tracer. Barry Marks.
Here.
Pamela Stark-Reed. Donald Schell. William Chong.
Here.
Aaron Lapata. Ann Bullock.
Here.
Barbara Linder. David Wong. Paul Conlon. Ayatunde Doken was on the call. Are you back on the call? Carol Greenlee. Here. David Strogatz.
Here.
Dean Schillinger. Not P. Okay. Ellen Leake. Here. Jasmine Gonzalo. Here. John Boltry. Shannon Idzik.
Here.
Idzik, sorry.
That's all right. I answered all.
Sherry Boland. Sherry
Here.
Boland. And Bill Cook. You're here, Dean. And
Yeah. Dean Schillinger here.
Dean's here.
David Wong here.
David Wong is here. Okay.
Good. Thank you, Linda. We'll have Clydette now give us an update on the status of the data call.
Thank you, Bill, and thanks to the Commission for reconvening after a brief lunch break. All right, so let me just provide a brief update on the data call. The first thing I want to say is thanks to all the members of the National Clinical Care Commission who were diligent over the many months to help design and refine and reduce this data call. And also thanks to Dr. Don Wright, who has been very engaged in the process and who has signed off on the memo that will transmit the data call tool up to the Assistant Secretary for Health, and then it will go on up to the Secretary of Health. The update is also that there is one data call tool. It's been simplified, and it will go to the 11 federal agencies that are specifically mentioned in the National Clinical Care Charter. The memo indicates that the data call tools results will be due back to the National Clinical Care Commission in the first quarter of 2020. The data call tool simplification still preserves three key areas that the Commission was interested in and for which they had designed questions. And those are the policy and program areas that relate to clinical and public health, preventive services, as well as treatment. The programs and activities that, again, look at clinical and preventive health services. And then the research area that, again, looks at prevention, care, treatment, as well as educational and outreach opportunities for persons with diabetes, families, and communities that are affected. The Commission is anticipating the approach to the synthesis and the analysis of the data when it comes back, they come back in the first quarter of 2020, and we are working with our contractor to optimize the ways in which those data will be synthesized and then presented back to the Commission so that they can develop findings, and that will form the basis of many of their recommendations. Just a reminder that the final report is due in October 2021. And that's our update.
Great. Thank you, Clydette. We're going to move on now to our next presentation, which is on education and outreach. Our presenter is Dr. Zani Leroy from CDC. She's in the Division of Population Health and actually is involved in the school health branch there. We have your slides, and if you want to go ahead, that would be great.
Sure, and thank you so much for having me. It's hard to be remote, but down here in Atlanta, here at CDC. So we can start with slide 2, and that has the objectives. So by the end of the presentation, I hope to provide an overview of the CDC School Health Branch. We also call ourselves CDC Healthy Schools, talk about our priorities, our resources, and some of our partnerships, and also to understand the whole school, whole community, whole child framework. So I'll get started by talking about where the majority of school health work resides at CDC. So I'm in the School Health Branch, which is led by Ms. Holly Hunt in the Division of Population Health. And that's actually located at the bottom right of this organizational chart. And we have 2 teams. I'll get into that a little bit further. The next slide. The grouping on the left, kind of lower left side, is our program and professional development team. And the grouping in the middle is our research, application, and evaluation team. And that's the team that I'm on. And I'll get more into the work that we do pretty much for the rest of this talk. But first, I'll talk about one other area in CDC. So the next slide. Most people have heard of DASH, and that's the Division of Adolescent and School Health. They're actually located in the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. Their commitment is to prevent HIV, STDs, and pregnancy among all youth. Taking a school-based health promotion and disease prevention approach, the division works to prepare healthy youth for a successful future. Their flagship cooperative agreement on local education agencies and a few national NGOs to implement programs that reduce HIV and STDs among youth, and primarily focus on implementing quality sexual health education, linking students to important sexual health services, and enhancing safe and supportive school environments for all students. They have 3 branches, one of which is the school-based surveillance branch, and that's located at the bottom right of this slide. And this is where the 2 surveillance school health profiles and YRBS are located. Next slide. So for those who may not be familiar, the school health profiles, which is the icon on the left, is a system of surveys that assess school health policies and practices in states, large urban school districts, and territories. It asks about school health education requirements, physical education and physical activity, practices related to bullying and sexual harassment, school health policies related to tobacco use, prevention and nutrition, school-based health services, family engagement and community involvement, and school health coordination. And of note, actually last week, they just released their most recent data, which was Profile 2018. On the right-hand side, we have the Youth Risk Behavior Surveillance System, YRBS. That was developed in 1990, and it was to monitor self-reported health behaviors that contribute to the leading causes of death, disability, and social problems among youth and adults in the United States. It's used to determine the prevalence and trends of health behaviors, examine the co-occurrence of health behaviors, compare national, state, territorial, tribal, and local data, provides comparable data among subpopulations of youth, and monitor progress towards achieving some of the healthy people objectives. And most of these questions relate to sexual behaviors related to unintended pregnancy and STDs, alcohol and other drug use, tobacco use, as well as unhealthy dietary behaviors such as inadequate physical activity, and nutrition. Next slide. So back to where I work, which is the school health branch. So our shared priorities with education are to increase the quantity and quality of physical education, health education, and physical activity, to improve the nutritional quality of food provided in school, and to improve the capacity of schools to manage chronic health conditions. We do this by providing funding and support to states, tribal governments, large urban school districts, and national organizations to implement programs. We synthesize and translate scientific research on the best strategies, and then we create tools and resources that are for educators and administrators. We also evaluate school-based policy, system, environmental changes, and interventions. And in addition, we provide professional development and training services through a training network on our tools and how to work with them. And when possible, we collaborate with other CD programs and other federal and national organizations. Next slide. So we know that research shows a strong connection between healthy behaviors and academic achievement. However, youth risk behaviors such as physical inactivity, unhealthy dietary behaviors, tobacco use, alcohol use, and other drugs are consistently linked to poor grades and test scores and lower educational attainment. Students who are physically active, eat breakfast and healthy foods daily, and manage their chronic health conditions have been shown to have higher test grades, higher school attendance, and improved classroom behavior. So we support cross-cutting approaches to promote health and to prevent and control chronic diseases and their risk factors. And for school health, there is a focus on childhood obesity. And we know that children who are obese are more likely to have prediabetes and are more likely to become obese adults at higher risk for heart disease and stroke. Next slide. So in 2014, the Whole School, Whole Community, Whole Child framework was developed by CDC and AFCD, which is a leading education organization, and it was built to strengthen a unified and collaborative approach to education and health by addressing non-academic barriers to learning. And so for anyone in the room who's familiar with coordinated school health that was started back in the late 80s, this is basically the next evolution of it. So the model focuses on the student and emphasizes the collaboration between schools, communities, public health, and the healthcare sector to align resources in support of the whole child. The model has 10 components. That's the circle that goes around in blue. That includes physical education, physical activity, the nutrition environment and services, health education, social and emotional climate, physical environment, health services, counseling and psychological services, employee wellness, community involvement, and family engagement. We fund and conduct science within the WISP framework, and we continue to look for opportunities to work and collaborate within, between, and across the individual components. Recently, there was a paper published with our sister division, DASH, in the journal School Health, and that looks at school health practices across the WISP model based on data from the 2016 School Health Practices and Policies Survey. Next slide. We also work with one of our national NGOs, the NACDD, National Association of Chronic Disease Directors, to create an implementation guide for WISP, and that's to help educators and other stakeholders adopt and implement the model. And although it's not all-inclusive, on our website, CDC Healthy Schools, we do have some examples of evidence-based strategies and practices for using the WISP framework in order to promote student health before, during, and after school. And these show how the different components of WISP integrate with each other. We also have downloadable graphics that are available for use in presentations on websites and for handouts. And so a lot of the, and just in general going forward, most of the tools and resources we create are for folks who are not in the healthcare sector, because we know, and we preach to the choir quite a bit, but oftentimes we do a lot of translational materials so that other folks can get on board with some of the science. Next slide. So who do we fund? The next slide. We currently have several notice of funding opportunities in place. And the program and professional development team within our branch, they're the ones who provide the overall management of delivering the program, evaluation, and technical assistance guidance to each of the funded partners. So the first program is our Healthy Schools State program, and nickname 1801. We have to have a nickname for all of our NOFOs. And that is funding state education departments in 16 states that are highlighted here in yellow. and their charge is to address physical activity, physical education, nutrition, and school health services, which would, of course, include managing chronic health conditions. Next slide. Another cooperative agreement is with the national NGOs. Currently, we're in the 4th year of this program, and our partners include Alliance for Healthier Generations. They're funded for nutrition and out-of-school time. Boys and Girls Clubs of America, they're funded for out-of-school time. Shape America, they're funded for PE and PA. The National Network of Public Health Institutes, also funded for PE and PA, as well as the National Association of School Nurses, and they're funded for school health services and managing chronic health conditions. Next slide. Through a different mechanism with CDC's Center for State, Tribal, Local, and Territorial Support, we have 2 additional cooperative agreements that we've had over the past year or 2. And the first here is listed is the American Academy of Pediatrics, or AAP, and that's to facilitate a convening of stakeholders with the goals of identifying gaps in the current landscape of school health services and coming up with an action-oriented plan to address those gaps. So that meeting was held in May, and again, different organizations were there to talk about what the landscape looks like right now for school health services and what plans can be made to address, some that CDC can be involved in some just across the board. Next slide. The Society for Public Health Education is being funded to support the importance of school health councils and health education in schools, and to assist some of our CDC-funded grantees to help develop tools and resources using the WISC framework that we've discussed. Next slide. So to date, some of the progress of our state NOPO, we're currently in year 2 of 5, so we're still pretty early on. But so far, again, they're using these 1801 program funds to build a school health infrastructure, to provide professional development and training, and to offer technical assistance in the local education agencies. The progress is monitored by annual performance measures, state evaluations, and quarterly reporting. And some of the results show that within the first year, grantees have developed coalitions or expanded the types of representatives in their statewide school health councils or school health coalitions, making them more diverse and broadening their representation. In the last quarter of the first year, there were 105 professional development events conducted by grantees, 84% of which were in person. And 58% of all those events addressed supportive PE and PA environment, suggesting that that's a significant need or interest among the LEAs in the schools. Also, all the states have worked with schools in completing the School Health Index, and I'll talk a little bit about that in a few more slides. Next slide. Next slide again. In terms of our relationships that we either have or we're cultivating across different agencies, with the U.S. Department of Education, we work collaboratively on some school health and wellness initiatives, as well as federal school health work groups that our branch leadership is on. With USDA, we work on research and evaluation projects, review guidance documents to districts and schools, and deliver presentations together. With HRSA, we've collaborated, again, at the leadership level to lead the National Coordinating Committee on School Health. With SAMHSA, we've actually recently connected with our project officers on their Project WARE cooperative agreement, and that's having to do with mental health and substance abuse. We've co-led webinars for our grantees, and there was also a recent paper that was co-authored that looked at the association between physical activity and dietary behaviors and indicators of mental health. Also, with the National Cancer Institute, we've collaborated on the CLASS online policy analysis tool, which is a database that categorizes the strength of state-level policies for school-based healthy eating and physical activity. Next slide. Within CDC, where we can, we try to ensure that we have communication across some of the different divisions and in some different centers with the way we're organized. With the diabetes translation group, we make sure that we have up-to-date information on the evidence and prevalence of diabetes among youth to share with our stakeholders, and make sure that the information on our website up-to-date, co-developed, and also points to their website as well. With the Division of Nutrition, Physical Activity, and Obesity, also some involvement with work groups and co-authorship on papers. With the National Center for Environmental Health, that's actually where the asthma group resides, and again, working with each other's NGOs. For example, we fund NAFN, the school health nurses, or school nurses. They fund NEAF, which is the, I can't remember the exact name, but for environmental, National Environmental something Foundation. I don't remember the exact acronym, but they actually work together, both NGOs working on some work looking at just evaluating students for asthma, especially when it comes to environmental triggers. With DASH, we probably have the closest relationship because that's sort of where the school health branch came from. Again, just working as co-authors and on work groups, and also putting in quite a bit of input into the surveillance system. So depending on the topic areas, they'll submit either new questions on the questionnaires, evaluate and review old questions to see if they still need to be on there, if we're looking for new things that we need to capture. Also, with the Office of Smoking and Health, we try to stay current to what the issues are in the communities. And so obviously now we've got a ton of issues around vaping. And so we've been working with them closely to get messages and resources out to the field on vaping and tobacco. We've added some of that content to some of our resources that are geared towards parents and families. Next slide. So I'll move on to some of the work done in the specific content areas of our branch. Next slide. So our portfolio of work includes school health services and managing chronic conditions. In general, we try to focus on the whole school environment, so creating a healthy school environment where all students can thrive regardless of which chronic condition they might have. Otherwise, we start getting chronic disease competition. I've had people come up to me and ask me about everything under the sun. So again, we're just trying to look at the full school environment and just having great school health services in general. In terms of research, in 2017, we published a systematic review that looked at the role of school health services in addressing chronic health conditions among students in grades K through 12. It was based on 15 years of research, almost 2,500 abstracts, and although we searched across multiple conditions, almost all of the published research was on asthma. The conclusion from that study really stated that direct access to school nursing and other health services, as well as disease-specific education, is what really improves health and academic outcomes among students with chronic health conditions. Since then, we've published several translation materials, including research briefs and fact sheets, and those are pictured on the right-hand side of the screen. So from left to right, in the orange, that's our chronic health conditions and academic achievement brief. And it summarizes peer-reviewed studies published over a 24-year period from 1990 to 2014. In general, there's really not a large body of research in school health that has student-level health and academic outcomes. Almost 4,000 abstracts were screened, and after detailed review, only 54 really met the criteria. Actually, again, most of them still were on asthma. Any associations that came up are reported from that subset of articles. In green are strategies to address the needs of students with chronic conditions. And so this summarizes information from the systematic review on the relationship between school health services and health and academic outcomes. But it also, in addition, reflects position statements and guidelines from other national organizations with expertise in school health, such as the National Association of School Nurses, as well as AAP, and also using the whole school, whole community, whole child approach for comprehensive school health. In blue, navy blue, or at least that's what I hope it looks like to you all, is a fact sheet that talks about the many benefits of school nursing. Because what I've learned over the time that I've been in school health was that people really don't understand the benefits of school nurses and what all they see every day. I think people still have a perception of nurses just kind of putting Band-Aids on and what have you. But I've learned a lot from going to these nursing conferences and speaking with them directly. I mean, they're pretty much running small urgent cares oftentimes by themselves, if they even have, support. But anyway, this particular brief goes into some of the reasons that school nursing is very important, including direct care, case management, advocacy for students and their families. It also reinforces the improvements in academic achievement and decrease in absenteeism, and that for every dollar invested in a school nursing program, society gains $2.20. And that was from a paper published by Dash in 2014. And lastly is in purple, the health insurance for children. Hospitals can help brief, and that basically describes the importance of having health insurance and some of the ways that assistance can be provided at school. And these include just identifying students who don't have insurance, particularly those who actually may have a chronic condition, identifying students that are at risk or vulnerable populations, as we talked about earlier, especially homeless and other, and also helping students and families obtain coverage. Also talking about referring families to either school-based or community-based medical care providers and other resources. Next slide. So we also have some resources, not many, that are condition-specific. So a few years ago now, CDC published the food allergy guidelines, and subsequently a toolkit was created that includes tip sheets, customizable and scripted PowerPoint presentations, and podcasts, all geared towards specific and relevant target school audiences. That would include administrators, superintendents, nutrition professionals, teachers, transportation staff, and we've literally made all these resources for them to use and educate within the education sector. Because again, we know within the healthcare or the healthcare sector, well, all these things are, why these are important. Having them translated and digestible for each particular audience that may use this further the knowledge on food allergies. The other document is Strategies for Addressing Asthma in Schools. That was released in 2017. I'm sorry, that's on the left-hand side. That provides a compilation of information and resources on implementing programs in schools, again, designed for staff in schools, but really also for staff in state health departments as they manage their state asthma programs, and anyone with an interest in asthma-friendly schools. And also really just showing the alignment of WISP in many different areas. So this would, for example, address asthma education, indoor air quality, and the direct provision of care to students. In terms of other conditions, for example, diabetes or seizure disorders, we also have some general information on our website and links directly to those content experts at CDC for additional detail and resources. Next slide. And next slide. So in the areas of physical education and nutrition environment, so I will give the caveat that we have separate SMEs in our branch for each of these areas, as well as a separate SME for obesity. So I'm talking about work that my colleagues have done, but just trying to give you the brief overview, and of course there can be follow-up if we need to. So in the areas of PE, PA, and nutrition, we have a robust information and resources on our website. We have the multi-component comprehensive framework for addressing school nutrition environment, and we also have a comprehensive school physical activity program framework. Each of these is very detailed with corresponding tools and resources to put them in place. On this slide, I showed you some recent releases. So for within the components of physical activity, there's the classroom physical activity suite of materials, and that's been most recent. Last year, I believe we put out the recess materials in 2018, or yes, 2018. So 2019 classroom physical activity, and that describes 10 evidence-based strategies for promoting and planning for classroom physical activity. There's a data brief that provides a snapshot of current classroom PA practices in the U.S. and highlights ways to improve classroom PA through national guidance and practical strategies and resources. Also within the package, there's an online platform that provides a comprehensive look at all the strategies, as well as a guide. In the middle is a cover of the SHIP vending machine studies. Again, the School Health Policies and Practices Survey. And the 2014 data was actually school level data. So what CDC did was they analyzed photographs of a national representative sample of school vending machines available to students prior to the Smart Snacks implementation. And the report highlights key findings, including the descriptions of the machines, prevalence of specific foods and beverages, and marketing on those machines. And for that level of detail, I probably would have to refer you to our nutrition SME, but I do recall when she would talk about it, we actually saw, they literally had pictures that they sorted through and coded, the types of foods in there. So very interesting research. And on the right-hand side is a research brief that is called Wellness Teams Work, and that was released and summarizes evidence supporting the importance of active school wellness teams and promoting wellness policy implementation in schools. Next slide. So we do have some cross-cutting resources that apply to all of our topic areas. And the next slide is our school health guidelines. And so this was originally published in 2011, and CDC integrated research and best practices related to promoting healthy eating and physical activity in schools, and that culminated in the school health guidelines. There are 9 guidelines that serve as the foundation for developing, implementing, and evaluating school-based healthy eating and physical activity policies and practices for students. So obviously, this was published in 2011. There's been a lot that has happened since, so we're currently in the process of updating these guidelines with an anticipated release of 2021. So that would be a 10-year span. And as I think most of the room knows, that guidelines take a really long time to develop, and we're going through that process now. So we're giving it about 3 years. And also, the WISC model was released in the interim, so we're making sure that it aligns with that WISC model, because some of the components in the previous guidelines, we just want to make sure everything's covered now with the new WISC model. So there may be a couple of additions in there. Next slide. I mentioned the School Health Index. It was originally published in 2000, has had many different renditions since then. It's one of our most widely used translation tools. It's a cross-cutting, and it's actually a self-assessment for school health policies and practices, either at the school or district level. And it encourages a multidisciplinary approach. There's a scoring mechanism, and it's basically for schools and districts to see where they are within all the different modules that really do represent the WISC model. So originally published in 2000, it's probably had about 5 different versions. We recently updated it again in 2017 in order to align with the WISC model framework. And so some of those expansions would include social and emotional climate, more extensive questions on the physical environment, separate community and family model, as well as many either new or revised questions that reflect the latest evidence across all the different components. There are 2 different versions. One is for elementary and one is for middle and high school. It's available in print and also online as an interactive format. Next slide. We know that parents have a powerful role in supporting their children's health and learning. Engaged parents do help guide their children successfully through school, advocate for their children, and can help shape a healthy school environment. So CDC developed a set of resources called Parents for Healthy Schools, and that's to help schools, school groups, school wellness committees with encouraging parent involvement in school health. It uses evidence-based strategies for parent engagement, and that's based on our parent engagement framework that was released probably at this point about 5 years ago. And the framework describes how to connect with parents, how to engage them in school health activities, and how to sustain that engagement in school health. Again, everything is on our website as well. So many resources. Next slide. And this is our flagship, I guess, digital tool. It's called the Virtual Healthy School. And it's an interactive tool that demonstrates through familiar themes how schools can help support evidence-based practices again, within the WISC framework, and that's to help support the health and academic achievement of students. It's intended for educational professionals who have an interest in meeting the needs of the whole child. It emphasizes nutrition, physical activity, obesity prevention, management of chronic conditions, and again, just geared towards educational professionals, K through 12 teachers, school administrators, and staff. And also folks in state health departments or departments of education also find this to be very useful. Next slide. We also have some trainings on our online platform on CDC Healthy Schools. And so for many of our resources, we're trying to get, again, not necessarily help people to really understand how to use some of these resources. So we do have some training. We have them on the CSAP, which is the Comprehensive School Physical Activity Program. We have one on PCAP. We have all these acronyms. So I don't have a slide for this, but I'll tell you quickly, because we did talk about health literacy earlier in the day. So in terms of health education, we do support state grantees to help improve health education among their priority districts. And one of those things includes it's called a health education curriculum analysis tool. And so having them train on that to use, and again, these are self-assessment tools that can be used at the school and district level. And also, I talked about earlier, funding Sophie to enhance school health education, and also to integrate that in teacher prep programs at the pre-professional level. We also have trainings on Parents for Healthy Schools, the School Health Guidelines, and the School Health Index. And the last slide are just some screenshots from my website, and I think I made it in my 30 minutes. So thank you. Like I said, some questions I may not be able to answer, but I'm happy to take all and any and refer them to whoever I need to if I can.
Great. Thank you very much, Dr. Leroy. This is Bill Herman. Are there any federal policies in terms of school physical education or physical activity? I know there are a lot of nutritional policies, feeding policies, but are there any policies or guidelines related to physical education in schools?
Not that I'm aware of. It seems that I know we have the framework that we provide, and that's just to make it as comprehensive as possible. But unlike USDA having some of those policies, I'm not aware of any, to be honest. But I can definitely help with our.
And I guess were there policies in the past that went away? Do you know?
I'd have to ask.
Okay. And in any of your pilot programs, is there an optimal physical activity or physical education program you've identified for schools?
Well, I think the framework is what helps provide what would be ideal, and also provide ideas, because it's become a competition of academics versus everything else. And so I think the main thing is showing folks that you can still get in that physical activity, even if it's in smaller sessions. Why it's important to have recess from not only obviously the physical perspective, but also from the academic perspective. So we do have resources that talk about the links between physical education, physical activity, and their academic outcomes.
This is a follow-up to Bill's question, so which I had very similar questions, but this is just my ignorance. How do school guidelines translate to policies? So maybe that's just a broader question, and maybe you've been successful with other guidelines that you've done with schools and translating to policies. I think that would be really useful to hear, and where you think some of the opportunities for greatest improvement around policies using some of the guidelines you have.
I think part of what we hear a lot is the fact that most of this ends up being local control. I don't recall which of the presenters earlier, I think it may have been USDA, but most of what we hear about, we can provide the guidance, but a lot of times it becomes local control because we're not regulatory. We can't really, we don't have that arm any mandates in place. But I would say just as much as we can pump out that evidence and translate it to the folks in the education sector so that they can see the benefits of it and to see where those links are between health and education.
Does the Department of Education have the regulatory power to influence local control? I understand that the CDC may not in this case, but is the Department of Education also beholden to local school districts' decision making?
I believe they are. I think that's one of the issues.
How much is, it'd be interesting to know how much is state level versus federal, and maybe that's something we can follow up with.
Well, it's just interesting that in terms of nutrition, the USDA does have decision-making authority, but in the realm of physical activity, it wouldn't. I don't quite understand why that would be.
Do you have any way of tracking or knowing how many schools or school districts utilize these resources that you just shared with us?
So we do have, it's hard to say. So as much as we try to disseminate the information, and we do have some web metrics about who's downloading, but again, that can't necessarily translate to who's using it. And so in terms of tracking some of our surveillance data, again, like I told you about school health profile and YRBS, we could in some ways see if there are improvements over time. We can't always say that we did it, but we can see if there's some improvements over time in either self-reported physical activity and nutrition behaviors through YRBS, or looking at the school health profile data to see what types of policies and practices are in place and if that's changing over time.
Yeah, this is Anne. I'm at CDC. I would just add to that, Carol, that part of our issue for not being able to monitor or track some of these tools that are developed is we'd have to get OMB clearance. You'd then have to set up the ability to survey these organizations, and then there'd have to be some incentive for them to answer. You'd really have to set up a surveillance system. Otherwise, you get, like one can get, it's the people who are willing to share and the people who are already doing it that would be the likely responders. So that's why it can be challenging. We often get data from our awardees, and we can obviously understand more in depth what they have done and who they have accessed and who is using the tools through them. But to have a national picture of those tools, we're limited by OMB.
Do you have any idea at all if the majority of schools or school systems tap into these, or just a minority? I mean, I'm just thinking about the schools in my area. They don't seem to have read it very well. But
I guess it's hard to say. It really is hard to say, like at the school or district level, like who's using our stuff. So in other words, we can say over time we might see improvement in some of the data surveillance systems, but there's not necessarily a link that it's because they use our resources. And we fund a certain number of states that we're really pushing, a lot more of this TA and professional development through, but we don't fund all 50 states at this point. So as much as we can, we're trying to get this out. And through our NGOs, we try to disseminate the information and have them target their constituents. But it's hard to say, we don't really get that feedback to know how far it's getting, to be honest, with the reach is.
Can I follow up on, first I want to applaud your branch, if it's a branch, on the deep dive work you've done around vending machine content, and I look forward to reading the report that you mentioned. With respect to the fact that schools in the United States still have vending machines that have sugar-sweetened beverages and junk food, I mean, it's kind of a national embarrassment when you look at other countries and what they provide in their schools for young people. Is the same restriction that you described with physical activity also does that also exist in the context of the food environment, specifically around vending machines and the sale of junk food on campus, or does the Department of Education or USDA or some other agency have more regulatory control to really change the structural issues in these schools?
I think the USDA might be able to answer a little bit more on that. I know that what we promote is, when we talk about the school nutrition environment, it's really educating folks about it's not just school lunch. It's also the food and beverages marketing, it's snacks, it's about celebrations and rewards. It's about even having the appropriate time for school lunch. And so a lot of it is actually, we talk about behavioral economics a lot, and just being able to promote how they can make healthy choices, promoting those healthy food and beverages, and providing low-cost strategies that they can use to kind of counter, if possible, coming at them in terms of the money that may be coming from some other incentives, to have those vending machines and to have some of those less nutritious.
Pamela, did you have any follow-up from USDA about regulating machines?
So the schools have to provide the required foods for the lunch programs or the breakfast programs. But what they do in addition to that, in terms of vending machines or whatever, is really left up to the local school and jurisdictions. A lot of them don't want to remove those because it brings in a tremendous amount of income to the schools. So they fight you on trying to.
So is that because we continue to allow them to do that? Because we as a federal government don't have the reach to the regulatory reach in this regard, or is it just because that's the way it is?
So in terms of the required nutrition programs, the required nutrition that you offer to the students, and again, it's what you offer to the students, not necessarily what they take and they consume. Sure. They have to comply with the programs that the USDA sets up for the school programs, and part of that is just establishing the vendors who are allowed to sell, and they have to be approved and they have to be on a list, and those are the ones that can sell to the schools, and then those products get used in the particular schools. But in terms of whatever else they have in there for theirs, that's not regulated by the USDA.
So, but the vendor list is approved by USDA?
Yeah.
That's the vendor list, including the vending machines?
No. I'm sorry. The vendors of the
school lunch.
They're called institutional foods. They come in large cases and whatever. You have to be approved to be able to sell your foods to the school for the school lunch, school breakfast program.
But for the vending machines, though, the districts may sign contracts with Coca-Cola to put machines in the schools. Yeah. I think David has
I can also confirm what Pamela was saying, that in our experience, sport drinks are very popular as a a la carte item in school cafeterias, and were a major contributor to the food services budget. And so when we tried to get sports drinks out, we had to address the economic implications. In one district, because the chairman of the Board of Education was a dentist, we have sort of a powerful ally, and we're able to make the case. But otherwise, it really is a struggle in terms of the economics. We asked the school budget to fill that gap, to say that for the health of kids, it was worth it to make that investment and to find the money to support food services without the income from selling sports drinks.
If they have contracts, it's not just that they're making money from the contracts that they have with Coke. If they break the contracts, then they have to pay a significant amount back to Coke or to whatever the company is.
I was going to ask a separate question, not on the. So if there's more on that, I'll stop. But I had a question just about sort of. Ad campaigns. I think CDC has done ad campaigns at the local level through different grants, but I'm just and they can be very effective. I know New York City had done one around smoking that was very effective, and part of their larger, part of their larger legislation on trying to reduce smoking. It was one piece of that, or one aspect. And I think ad campaigns can be very effective, both for public and providers in other areas. And so I was curious, one, about how effective CDC has found some of the ad campaigns, and could those some of that information be shared with the committee in terms of thinking about our report and education for public and others. And two, maybe there were some high profile or good ones that could be used around diabetes prevention and management. So I just sort of throw that out there. And I don't know if CDC is really the only one that does that. There may be, I'm sure there are other agencies that get involved in that kind of thing. I'd be curious to know sort of, is anybody sort of collaborating across any of those activities with the different agencies? So sorry, 3 questions.
You mean specifically about school-related issues, or
Just
overall,
broader.
all our?
Yeah.
Well, Zany may have certainly comments. I can speak to what OSH has done and what we have done in diabetes.
Sure.
OSH has the TIPS campaign, which actually garners a lot of resources. In fact, all of us in Chronic Center, if we have any fallout dollars, they get swept up into the TIPS campaign. And they have a fairly well-funded, although they would always, of course, appreciate more.
What's Ocean Tips?
Office of Smoking and Health. And TIPS is, what is it, tobacco? I'm trying to remember what TIPS stands for. It's the ads you see where you've got people who may have a trach, who may have, had a heart attack. There is a diabetes one, a person with diabetes who has had serious complications of diabetes. They're the ones that are considered very scary ads. They are very much about using that very serious image for what the impact of smoking is. And so those have aired in numerous places, and we can certainly get you more information. Office of Smoking and Health has a whole communications arm that deals with that, and they're probably the most largest effort of that kind. We have done one in partnership with the Ad Council, our division, and the American Medical Association. Initially, it also included the American Diabetes Association. I mentioned it in our first meeting. It is the first pre-diabetes campaign ever in the country, and we're in the 3rd round now. We have used humor-based, which can be very challenging in health, but it's worked very well for us. It was the bacon guy and the busy mom, and then it was the really cute animals, and then it's now been 1 in 3. So it could be you, your favorite brother, your other brother, your plumber, your plumber's masseuse. So it's been very, very effective. And in fact, it's considered one of Ad Council's most successful campaigns. And that's up against Smokey the Bear, I might add. And it's been so successful that Ad Council has now asked us to continue. Most people go to Ad Council. They've asked us to continue, and they are, for the first time in Ad Council's history, willing to work with us in a concrete location, because Ad Council has very particular parameters. The reason we chose Ad Council was because we do not have budgets to do they are incredibly expensive to do advertising campaigns, to get any reach and not be shown at 2 a.m. And so you've really got to be strategic about your partners, and you've also got to bring people in. And so we can give you the numbers for the leveraging of dollars. It's been millions of advertising dollars that we have been able to leverage in kind because of the reach of this campaign. And there are certainly some others outside of chronic and CDC that would have to do with flu and those kinds of things. So we could certainly tell you more about those. But CDC probably is one. HHS has done some of their own. The VERB campaign many years ago came out of HHS, was run through CDC though, and that lost its budget after a period of time. So there are other examples, but they are really costly. And there's also sometimes a bit of a concern over buying ad space, using taxpayer dollars to buy ad space. And so OSH has been able to do it. We have done it through Ad Council. So you have to find creative ways to do it.
What's the Ad Council?
The Ad Council is a organization that gets major advertising companies to work pro bono, essentially. You will pay for certain aspects of the Ad Council campaign, research that's done, and that's why having other partners that we work with, like AMA or others who can fund research without going through OMB, and can do things of that sort. But Ad Council is known for Smokey the Bear campaign, Brain on Drugs. Those are all Ad Council campaigns. They are really the premier organization that does gets you access to major advertising agencies like Ogilvy and others who are preeminent in advertising, and gets them to work with organizations. But they will take on issues when they feel there is a really high public health need for it, and that they feel there is an opportunity. There are also parameters around the fact that you cannot pay for their ad time. The stations and the entities that you work with to air these, whether it's a national station like CBS or NBC, or it's more local, you cannot pay them to run those ads. It's part of Ad Council's requirements, and they have another set of requirements that we can certainly tell you more about. We have a very lots of knowledge about working with them if that's of interest to the commission.
So it might be useful as we continue further in our councils and subcommittee, just to be thinking about what would be high priority areas, or how do we think of a strategy that uses that ongoing for areas of high priority. And maybe there's other ways too that people are doing ad campaigns. It'd be useful to see some of the data on what's been useful too, I think, if we were going to put that in any kind of report.
Yeah, and we have good data. I'll just quickly say, I know we're short on time, but we're also using other ways by which to get in front of people on television and through whatever it is you want to say, Hulu, any of the places where people are watching shows. Is also, we have done work with major stations like ABC and CBS. We've done work with Joan London, and we did the first time mini-series aired with national news, never been done before. Because the more you get in front of people with this good information, and also we have had the opportunity to work through an organization that a lot of television programs go to. It's Hollywood Health and Society at UCLA, I believe. We haven't worked with them for a while, to be advisors on shows where diabetes is being featured, so their information is accurately portrayed, because that's often not the case. Oftentimes it's not portrayed well at all. So I think those are certainly avenues, but you have to be pretty creative to get to those, and there are always some parameters around them.
Were there any final comments or questions for Dr. Leroy? Good. Well, we want to thank you very much for your presentation then.
Thank you. And hi to David Strogat.
Great. Good. Great. All right. Thank you. So we're going to move on now to a discussion of the presentations and the model. And I just want to start by referring back to the model that we started the day with. And I think we've really covered a tremendous amount of material so far today, particularly related to the social determinants of health. We've certainly touched a lot on education, housing, transportation, and food. I think we've also pretty much hit all of the behavioral settings, perhaps except the work site. The areas that I think perhaps we've not touched as much as we should are labor, industry, and the work site, and also potentially the environment, parks and green spaces, and maybe also some more issues related to physical activity. I think Anne did a nice job in touching on some of the psychosocial factors, stress and trauma-related issues. Is there consensus that at a future meeting we would want to hear more about labor, industry, and the work site? And if so, who do folks think we might want to solicit input from? we'll take it one at a time.
Bill, I would say, I mean, I don't know if folks have reached out yet to Department of Labor. There are a number of things, but it's a question of, again, like Department of Ed and other federal agencies, but certainly that would be the one I would certainly think of first as it pertains to labor. As far as work site, I mean, that's a broad category, and probably a lot of entities are using work site like one looks at other settings, schools and others. So I can tell you that also in the same division that you heard from today, population health, there is a pretty solid workplace program that goes on, and they've developed they've got some pretty good evidence, and they've actually developed some sustainable work that's getting many more employers to talk about what they are offering as far as benefits and services for people. So probably hearing from them. I'm not sure who else in the federal government may be able to offer that, because it may be sort of mattered around other places in the federal government. But those are the two that I can certainly think of. The other quick thing I would mention is there's also some work going on in addition to when we talk about environments, there's increasing evidence around air quality or other substances in our environment that are maybe contributing to type 2 diabetes. We have a trial going on right now, the LEAD study, which is just beginning to look at some of those. And those are things that include stuff like fracking and other kinds of things that may also be newer and maybe just sort of on the horizon of understanding.
Yeah, certainly particulate air pollution has been associated with diabetes risk in big studies. So going back, so we have a recommendation perhaps to hear from the Department of Labor. I also wonder then if it would be, whether there would be large employer groups who might talk about the types of worksite wellness programs or things like that. Is anyone aware of anyone who could speak to successful worksite programs?
I would offer thinking about maybe going to the organizations in the country that are collectives of employers. I'm blanking on their name, and we work with them. There's the Eastern, there's the Pacific Business Group on Health, the business groups on health. So there's Pacific Business Group on Health, and they're actually a pretty good speaker from the East Coast. So I think there are some business groups on health that would probably be a good source for that.
Good. So maybe we can ask Linda Clydett to begin looking into inviting people from the Department of Labor and maybe contacting the business groups on health. Are there other groups in that?
I was just going to say, we
domain?
probably still want to make sure we have Department of Education come. I just want to make sure we don't lose sight of that.
Okay, good point. So we still would like to have a formal presentation from the Department of Education. Clydett?
Yeah, we certainly made efforts to have them engaged in this presentation today. And we weren't successful, at least in that particular time frame. I would welcome if people know where within DOE we might make those inquiries again. That would be helpful. Certainly glad to arrange that for you.
I think, again, if we started now, we should potentially be able to have something by February. And if anyone has any contacts, please let Linda and Clydett know. So, and then going back to the environment and parks and green spaces, it sounds like we're thinking more environment. Would that be EPA, or who would people recommend that we hear from there?
I'll just say, I think for something like particulates and that kind of stuff, and when Claudette first asked us to name groups, there is actually a list I found online that lists all these federal agencies. And so I started going through those, and then I realized, I was just supposed to pick from the list that Claudette provided. But I mean, I was going through and ticking off a number of these groups. But yeah, EPA certainly I think would be fallen into that category. But I think if you're talking about parks and green spaces, then it's probably also Parks and Recreation departments, the Department of Park and Rec. And they also do a lot of work with locals, though, which is most of us do in the federal government. So Department of Parks and Rec.
Dean.
Bill, yeah, I just wanted to echo Ann's suggestion about EPA. for me, less around the particulate matter and more around fresh water access. I think something like 25% of the average American do not have access to reliably fresh water, whether it's uranium or lead or others, or whether it's even just the misperception that the water is not potable. I think is a vitally important issue, particularly in light of what we've seen around consumption patterns among SNAP and non-SNAP beneficiaries.
Would you not want to hear about air pollution?
No, I'm
certainly
I'm a neophyte around it. I don't know the field enough to know.
Okay, but to certainly focus.
Yeah, I mean, I've heard more around
water
plastics and diabetes, but
okay, good. Are there other? Yeah, Don.
This might be related to what the issue is now. I hope it is somewhat related. The model that we're using, because the paper that was given had two models. One was the one you're showing on the screen, and the other model had a different base on it. And so I think that one of the themes from the presentations we've heard today is from the federal perspective, there's some things that the federal government can tell states and communities to do. If you fund them, then you can tell them what to do. But there are many times that the federal government facilitates what the state and what the local jurisdiction wants to do. And we don't dictate what the jurisdiction does. So I think using the other model that informed, activated populations and communities is more consistent with the models that you've seen today, that you empower, you work with the state and or the local government to help them to decide how they want to utilize resources and documents and advice that's available. The second thing, three things I want to say, that was the first thing. The second thing is I think we're missing in the conversation and in the diagram, we're missing the public health component, because many of your health departments across the country, state health departments and local health departments have diabetes programs they focus on. And so those are the individuals that are utilizing the resources that are coming out of CDC and coordinating with education and housing. And they're the individuals that are working with the hospitals and the community-based
another
groups.
circle next to healthcare.
Yeah, but the public health departments are the chronic disease directors, the diabetes programs. They're in the schools, they're in the community, they're working with the hospital. I mean, they're the people. Some people don't like boots on the ground term, but they're the individuals that are really aware of what's occurring from a diabetes perspective and for many other things in the community. And then I think it would behoove us then to hear from the third comment was, if we think the communities are important, if we think that it'd be worthy to talk to all of the diabetes programs that are in the state health departments across the country, then to maybe have SACHO, the secretaries across the SACHO to come present, or NACHO to come and present and to talk about their diabetes initiatives, because they'll touch on many of the things that we're trying to kind of get at tangentially, because this is federal government's an umbrella, but we have to get under the umbrella to see what the actual issues are that are going to make a specific difference and try to make the recommendations that will bubble up, because some states may say, this worked really, really well, but the funding went away. If we could tweak what we were doing in this way, we can reach, because then you have the FQHCs, which the local health departments are working very closely with also. So we're kind of missing a big part of the actual delivery system in the process for deciding how individuals access and receive care with diabetes and preventing diabetes. But I think we're missing an entire segment.
Great. So we have a vote for the 3 oval figure. As I had indicated, this is a work in progress, but I think there is some consensus that the other figure would be better. Where would you put public health into this figure?
You can fit public health. Public health I would probably almost say that public health, it's a part of the community, but it's also part of a bigger bubble.
So
there. So
it's with the community or in the other. Yeah.
Well, public health, some health departments deliver care, some don't deliver care. Some coordinate with their local hospital system. Some access funds from federal funds. And so it
could be up here too.
They could be up. There they're in they're a sector of influence. They have behavioral health departments. I was a health officer for 8 years, so I worked at the state health department for 5 years. So I'm
And a darn good one.
And what
Thank
were
you.
you used two acronyms that I missed? What
State
was
Association of
health?
There's chronic disease directors. Then there's the National Association of
Officers.
health officers, and then
NACHO.
there's the Association of Secretaries of Health.
So you would like input from one of those or more than one? Of
We
those?
included the national organization in our work yesterday when we did
For
the brainstorm
as
list.
For chronic disease,
Right, for chronic diseases.
but not for the health officers.
Correct.
So the health officers are the ones that are telling who works for who. In Maryland, well, let me not get into that kind of detail, but at a public health level, at the state level, it's the Secretary of Health for the state that decides the direction. But the Secretary of Health may not have that kind of granular awareness of what is occurring. So but the Secretary of Health for the state would understand what their diabetes initiatives are for the state. Then there are the health officers that are responsible for their particular jurisdiction. And then there are the chronic disease directors that work under either the state health, because I was a chronic disease director for Maryland, but I was also the health officer for a county in Maryland. And so I intersected with Ann and other programs at both ways in different ways. And so I think hearing from both of them, or maybe having a session where you have a representative from the Association of Secretaries of Health and a representative from the health officers from a public health perspective, and someone from chronic disease. And I think you would get a broad-based awareness of what the state initiatives are, health departments are, and the chronic disease directors have for diabetes.
Okay, Claudette.
Yeah, thank you, Don. As a public health specialist, I really resonate with your comments. And I think it might be fairly easy to get them on an agenda. I think both NACHO and ASTO are based here in the Washington area. And I don't know about the National Association of Chronic Disease Directors.
They're based in Atlanta.
Okay, so two of the three then should be workable. And we'll follow up with that.
They will no doubt come in ACDD with.
Yeah, I agree with Donald around this flip side version being better, because I like the fact that well, I'll leave it at that. With respect to where we put public health and where we put healthcare, I think I'd like to just raise, which is that right now healthcare is sitting in the individual factor ellipse, whereas in many of these models, it's actually a sector of influence. So it actually crosses many. And the problem I have with healthcare being situated where it is, it's sort of like the outflow obstruction in the urinary tract. It's like you got to get through healthcare to get to health. And so it feels like if we could reposition it, so that's not the only pathway, and it might be through public health. I mean, there might be other pathways by which health is achieved. At least visually, to me, it feels like everything flows through healthcare, which is true for some things and not true for others.
Good point. Send a revised diagram in if you would.
I'd be happy to.
And I think the other thing, I don't know if we talked about it yesterday or not in the subcommittee, but the hospital association. I mean, if there's because I think bringing it full circle with the other things I've mentioned, having whether or not there's a national hospital association or whether or not there are more distinct ones, but there is, right? But having them talk about what they're experiencing, and then maybe they've had some likely experience with the federal government and programs and what they've been able to successfully implement and coordinate with federal programs. What's the benefit of federal dollars? Where federal dollars that's helped them to provide care to communities and individuals and groups, and to get the hospital associations to respect.
So on the note of both the model and people to invite, I think I commented over the break that, payers are not well representative. We have sort of coverage benefits under healthcare, but I think the payers would argue they do more than that. And so, there would be sort of prepared, proactive community partners and payers, and maybe that's also where health departments, I think we need to just think a little more broadly about that as well in the model. And I'm happy to add some comments and revisions. But on that note, I also wonder if there would be some benefit in talking with the state medical directors of the Medicaid, partners in particular, and getting some of their feedback. I know we'll have CMS at the federal level, but there's been a lot of work at the local state level with the state Medicaid programs, and there may be some really great sort of feedback and things we can learn from them about their work. In particular, we're doing things combined with the Medicaid managed care plans to try and improve health, and that's very innovative at our state level, and how they're trying to combine the required federal performance improvement projects that the Medicaid managed care plans have to do with other ways of tying all of the health systems across the state to try and really maximize things that they're required to do with actually benefiting patients across the state. So I think that's just an Ohio example, but I know there are many examples across the U.S. around what people are doing at the state level that aren't sort of out there in the public for us to know about yet. So I think that could be very useful. And I don't know if I could certainly ask our Medicaid health directors if there's a national meeting. I believe there is some kind of group that meets, but I'd have to ask them.
Barry, did you want to comment on that?
I can certainly.
Okay.
There are a couple of them. We brought them to the table for our Medicaid demonstration project for the National DPP, and we had representatives. There are a few different groups.
Good. So I've tried to focus on things.
One more thing.
Yeah, please.
We're thinking maybe the QuinnQIOs, the Quality Improvement Network, Quality Improvement Organizations. When we talk about different healthcare models, they do a lot to help educate on those models, and they provide diabetes education in often remote communities, and a number of other things. So it might not be bad to have someone from there.
Yeah. So I was really trying to focus now on sort of the outer rings here. I think at the next meeting, we're going to be focusing more on healthcare, and I think that would be a good informant for that meeting. Are there any other suggestions in terms of areas that we've not covered in terms of the sectors of influence or the social determinants of health that we'll want to follow up on? And if not, I will call on Dean to help lead the discussion in terms of what we've heard in terms of social determinants of health, and trying to summarize some of those and maybe come up with some preliminary thoughts in terms of things that resonated with him.
Sure. So this is very, very much improvisatory. First of all, I think we heard from a diversity of individuals and diversity of agencies that, at least for me, was just incredibly informative and exciting to hear. So much information that for many of us is new and feels really relevant. I think also what we heard from these agencies is a demonstration of the fact that these sectors of influence, these social systems, can profoundly influence not only incident diabetes, but also the management of the disease in myriad ways. And many of the examples were quite germane to those who are living with diabetes and its complications. So I think it was very illuminating in that way for all of us in the commission to hear from these agencies. I also heard a lot of personal commitment on the fact of those that were selected to come here, and a real openness to collaboration across agencies, a commitment to evaluation, a desire to carry out important research together with other agencies that are relevant to the epidemic, and a real, I think, a common sort of awareness of the severity of the problem of diabetes in this country. It didn't seem to be an open question as to why we're even talking about this. So I think that was also very compelling. I think we also saw that, at least in this cross-sectional representation of agencies, that different agencies, I think, are in different stages of evolution with respect to how they are thinking of their role as it relates to health in general and diabetes more specifically. Obviously, the CDC, I mean, they're deep in it. This is what they do. They do it very well. To agencies that are just kind of dipping their toe into, how should we be thinking about transportation as it relates to the prevention of diabetes, not just the management, to the presentation from Housing and Urban Development, in which it was clear that health in all policies is some magical way a guiding principle. And so I think there's a lot that could be built on there in terms of the degree to which these various agencies do seem to recognize the nature, the transsectoral nature of health. So that was very, very reassuring. I think some of the things we didn't see, just kind of cutting across all of the agencies, was the fact that while there is a commitment to evaluation, in hindsight, there seems to be relatively little focus on modeling the potential health impacts of changes in very important policies that can affect very large and even more smaller targeted populations, and very little specifically health economic evaluations that I think are absolutely critical to informing the work that the federal government engages in. And I think it's another specific opportunity for collaboration with those who do health research and have expertise in other agencies to think about, okay, if we change policy A, what is this going to look like for childhood obesity in 10 years or diabetes incidence? And I think the science has progressed significantly over the last decade to enable that to happen more. I think that kind of work can lend itself to policies being subject to health impact assessments, just like we do environmental health impact assessments now before we build a railroad track somewhere or build a new building. We assess what the effects are going to be on the 7 flocks of birds that live in that area. Could that open up the opportunity for us to consider health impact assessments for not for every policy, but for major policies that affect large populations? With respect to the individual agencies, I think the thing that was most compelling to all of us about housing and urban development was the sort of the paradox between the commitment and the service that they are providing to those who are fortunate enough to be, not only eligible, but to actually take advantage of that eligibility and receive the housing benefits. And so that's just a striking paradox. And, I don't know what we're going to do with that in terms of recommendations, but it is quite striking. I think the idea of better understanding the implications of withholding housing with respect to health outcomes and costs is something that we should probably talk about pursuing. And certainly the researcher who presented seemed quite open to that idea, and the data sets that they have and the linkages that they have with CMS, particularly with Medicaid, would I think be quite interesting to pursue. And I think the pilot work they're doing around place-based holistic health and wellness, I think, is very exciting, particularly with seniors. And I think, riffing off of what Anne was saying, that the more that work could also be focused on maternal child and doing demonstration projects there, that would be even better. And I think this is true for HUD and will probably be true for all the agencies, riffing off of Ann Albright's comments, which is, how can we more systematically go from demonstration projects that show promise to scale? And there are probably a number of strategies to do that, that many of you are more familiar with than I am, but that should be something that we think about focusing more on. the transportation agency, I thought was again maybe a bit earlier on the spectrum in terms of their evolution, but to see that they have a very robust health and transportation working group really suggests an important entree that they've obviously are focused on issues primarily of safety, and certainly those of us who promote biking to work are not happy to see that 6.3% increase in fatalities. So you prevent someone's diabetes 20 years from now, but they had a fatal accident. That's a problem that needs serious attention and infrastructure. I think that I felt a little bit less clear on where to go with after the transportation presentation. It seems that there is a tremendous interest on their part to assist local municipalities in coming up with creative plans for urban redesign and transportation redesign. But then what happens with those plans, I think, is unclear to me, and probably is where a lot of the rubber meets the road. And so I think what our Department of Transportation was unable to demonstrate was any work on the relationship between the built environment and transportation policy and health, apart from the safety issues that they're appropriately concerned about. So I think that is really an important area as we develop the infrastructure of our country and try to redesign particular areas that need redesigning. In terms of USDA, I mean, it's a massive agency. I mean, I think that they, like HUD, do terrific work. They're collaborating with anybody and everybody, including the CDC. I think that the main issues we struggled with USDA again come down to, are the people who are eligible getting it? And she didn't directly address that answer. And I certainly know there's tremendous state to state variation, with some states having high rates of the eligible receiving the benefit and others having extremely low rates. And I think there are models that she alluded to that related to how people who are eligible can get the benefit. Are there ways to automate that? Are there ways to use area level information so that everybody's covered in that area? That I think could be an area for us to pursue because of the obvious health benefits that SNAP beneficiaries enjoy. I think there also was some discussion of, are there ways that we can better manage what the SNAP benefit enables you to purchase, that it's healthy, while at the same time finding innovative ways to get more bang from your buck through these innovative pilots that they're doing around the doubling the bucks and the Gus SNP or whatever it was called incentive program for getting more fresh fruits and vegetables in people's hands. And I think I raised, and I don't know how generalizable this is, that the question of could we be thinking about the supply side as well, of increasing the supply of fresh fruits and vegetables to drive the price down, because I think the consumer demand would follow. But I found that they are really thinking about these things. I think they are coping with some realpolitik in terms of some of the policies that are coming down, and I would imagine that our commission will probably have something to say about food assistance because it is so critical. I'm sorry, did I talk about transportation? The one thing I forgot to say about transportation, if I could go back to that, was I think we learned, at least many of us learned for the first time, about a policy at CMS that we're going to ask Barry to please do some research on, that may undermine the ability of Medicaid beneficiaries who are disproportionately experiencing disabilities and disproportionately have diabetes, to be unable to consistently and reliably access transportation resources to enable them to receive primary and specialty medical care, and that would represent a savings of about 1% of the CMS budget, which is a gigantic amount. I don't deny that. But of course, for those of us who are clinicians in the room, the first thing is like, oh my God, that means that, as Bill, you were saying, that means they're taking the ambulance to the emergency room, and that the hospitalization rates for many of these folks who are, whether it's going a long distance or whether it's even going 7 blocks, can be tremendously challenging. And so I think there needs the CMS Department of Transportation conversation really needs to happen, and that's one area of collaboration that I think we need to follow up on, because I think as she laid out very clearly that the Department of Transportation's job is in many ways becoming apparent to enable access to health and health resources, whether that's getting to a farmer's market or a grocery store or a childcare center, or whether it's going to a doctor's or nurse's appointment. That is de facto what the Department of Transportation services are offering people. And then lastly, I think we, let me just see if I missed anything on USDA. The only thing I would say is that we saw some very compelling evidence presented by the second presenter on how a policy decision, obviously it was an ecological study, but how a policy decision around, in this case, school lunch composition could dramatically, I'm talking about a 4-fold difference in the nutritional value of foods that young people are consuming. How quickly and how impactfully such policies can draw benefit. And I think it's very empowering to see. Nobody suffers if young people eat more whole wheat grains than refined grains. And it just seems like a win-win that are the kinds of things that this commission should be applauding and trying to sustain. Lastly, was the last one the CDC presentation? What was tremendous to me about the CDC presentation, well, again, it was a bit of a paradox. The degree to which the CDC in general and this branch in particular are collaborating with multiple federal and non-federal agencies to get the job done. That's kind of like public health, right? That's what you were talking about, Donald. Like, it's just, we're on the ground, we're going to get the job done. And so the creativity and willingness to extend themselves, the attention to detail and the research. They're taking photographs of vending machines in schools in a nationally representative sample of schools. Like, that is a treasure trove of information. And then the paradox, and I felt this when I was chief of diabetes prevention control in the state of California, is you see that, and then yet the inability to with a firm hand, change policy and practice, and the need to use the model of influence that we all are familiar with in public health to try to move the battleship, is something that constrains many of these agencies, and is something that we're also going to have to address as a commission as well, because there are some things just seem like no-brainers, right? And it's because of a variety of reasons they are extremely challenging to tackle. So that's a off-the-cuff summary, but I'd love to hear from others.
Fantastic. Comments from anyone? Other points that Dean missed?
I thought Dean, thank you for that summary. I think that was a really outstanding summary of all the presentations and the issues that came up. And I would just bring up I think it came up a little bit, but I think just bringing up the idea of thinking about how do we address or not address as a commission some of the policies around salt and sugar in foods. The New York City Department of Health, I think, presented last year at SGIM, Society of General Internal Medicine, about the work that they had done, maybe it was 2 years ago, work they had done to reduce, I believe, sodium, trying to influence blood pressure control for, and I think it was over 20 retail food companies and some of that work. And I don't know how that happens at the federal level. Is that all going to be, city to city? But thinking at a commission level, clearly the kinds of things that are in our food have large influence, and how can we think about that? And it didn't really come up at that large scale level here today, but I think is just worth us thinking a little bit about as a commission.
I think the whole trans fat story has been a fascinating lesson, and I wonder if we can, obviously there are other fats that can be used, but whether there are lessons to be learned in terms of...
Well, you told a
policy.
story about the UK yesterday at dinner around what's going on with the sugar content of their foods, right? You want to share that? I think it was quite compelling.
The legislation in the UK, as I understand it, and correct me if I'm wrong, is that the manufacturers are taxed on the sugar content of their products. So there's been a lot of reformulation of sugar-sweetened beverages to have less sugar so that they pay a lower tax and they can reduce the product. And it has shifted the market to some degree. So it's an alternative approach to basically food reformulation that's had beneficial health impacts based on an economic incentive.
I think just to respond to your comment, Sherry, it also raises the question of, do we want to invite the FDA? There is a lot of discussion now around labeling and a lot of pushback. There had been an accepted new standard that has been held up, and there's tremendous urgency around that, and there's a variety of opinions on what those labels should look like in ways that the general public could understand. So I just wanted to add that to the list in response to your comment.
Pamela, did you have a follow-up?
I've also served on the DRI committee, Dietary Reference Intake, which is not a funded mandate. We, as federal agencies, have to come up with the money to pay the Academy to do these reviews of the DRI, so it's not been done.
DRI stands for?
Dietary Reference Intakes. They used to be RDAs. They're now called DRIs.
DRIs.
And so sodium was one that was just done. And they, there's not enough new information, research, to move the needle much on that particular one. So we need more research because we need more evidence base to be able to do it. When companies
around what should the label should look like, or around the science
the label,
of the
about the actual amount that should be prescribed, or, suggested. So, and when companies have voluntarily done it, Campbell's, for example, did it in their soups. People just stopped buying their soups. Companies will not make these non-mandatory changes unless they're going to make money. Their bottom line is to make money. And yes, they do want to be beneficial and helpful, but they need to make money. And when they lowered the salt content on many of their soups, people just stopped buying their soups. So they're not going to do it unless something is enforced. It's not going to be enforced till we have the data and the evidence base to show that it has to be done.
Around sodium, if to the degree that it certainly relates to management of diabetes, although the evidence is a bit mixed, exactly what the recommendation should be, but is Million Hearts. Million Hearts and the Division of Heart Disease and Stroke at CDC is responsible for a major sodium initiative. So if people want to learn more about what the partners are doing in that, it is the Division of Heart Disease and Stroke, because they're the primary managers of Million Hearts, although there are innumerable partners that have joined Million Hearts. Bill, I just wanted to quickly also add, because I just thought of them as we were talking about the summary and other things. In the sector of influence, the one that we did not talk about, and while it's communication, but I wouldn't put it into marketing, is the FCC. And if we're talking about telemedicine and rural health, I just read the top line heading of a report that just came out from them that said the major issue for accessibility to telehealth was not broadband, although I think that still is an issue. And we have spoken to the FCC. There's some awesome context there. But it really is around more individual factors, getting payment for telehealth, getting individuals who feel more comfortable with telehealth. But I think that as we're talking about access and we're talking about scalability of things, I think they may be a group to also hear from. And the leader of the FCC group right now, the commission, he is the son of physicians and is very interested in supporting health.
And who is that name again?
I'd have to go back and look in my records. It's a little unusual name, but we can certainly ask my team to hunt that down. And he certainly asked us to come visit FCC and to interested in doing what he can. He's the head commissioner.
Paul, I have to acknowledge how impressed I was this morning in hearing those presentations from agencies that I had no idea touched healthcare the way they did. The presentation by HUD was truly impressive. In fact, after that presentation, I felt like saying HUD is a healthcare agency by the fact that they provide housing, and we know that homelessness is as much of a chronic disease, probably more so in terms of its impact on longevity than any other chronic disease that we currently treat. So I have to say that I was truly impressed. The other part that actually left me with a little bit of a sinking feeling, though, and that is that each one of these agencies, only by, I think by the force of will and or imaginativeness of a few people within that agency, is doing the work that they're doing, and including somebody whose degree was interpreted as miles per hour as opposed to master's. I like that one. But I did not have the sense that any of this is coordinated to any extent. And as a result, this is it has the risk of having siloing effects where one agency, and I think in particular, for example, USDA, which, as we heard in the latter presentation from CDC, has significant overlap in the school systems, by nature of the lunch and breakfast programs and the programs in healthy eating and physical activity. That's an example where there's direct overlap, but these are separate programs. And I didn't quite grasp whether or not there actually is already some dialogue ongoing. But I did have the sense that HUD is basically functioning as in a vacuum. DOT is actually doing this all on their own, and they're not part of some larger federal program, and I use that loosely, that has health and or specifically diabetes as its focus. So that was just a kind of a collective observation.
Can I comment? I mean, I think that's I wish I had included that in my summary because I think it's exactly right. And to me, that may be kind of the nugget of our recommendations is that we have this trans-sector work beginning to happen in various stages, and are there ways that more coordination and amplification can be accomplished, so that we don't have that sinking feeling, but we have actually an inspired feeling of we're kind of moving forward together in each agency, and then in aggregate.
I'll just mention for the Office of Minority Health, we have a Interdepartmental Health Equity Collaborative. It stands for IHEC. And the goal is really to cut across the departments and find all the folks that are interested in health disparity work, including social determinants of health. We have a monthly meeting. One of them happened today. Our focus was on education. And we're focusing now for the next year moving forward on a specific project, embedding community health workers in public housing projects in Los Angeles and Baltimore. And so HUD is a big player in that. And so they're not in a vacuum. And I will say, though, that since I started with this work, I was truly impressed, too, with all the programs that HUD has. And they all touch on health. And the project that we're working on with them is a program called Jobs Plus, which the speaker today didn't even mention, because there's just so many programs HUD is working on. And so I think our IHEC could be a way that we could expand. We're not focusing on diabetes. We're focusing more kind of in general. But maybe that's something that we could add. And I would also mention too that because we are so impressed with HUD, and one of the areas that we're exploring on a very low level is having more public health service officers working at HUD. Because right now there is no interagency agreement that allows public health service officers to serve at HUD. And we think that's a huge oversight, because especially knowing about the programs that they have. So we're starting to have conversations with our leadership at Public Health Service and with leadership at HUD to see if we can make that happen.
Just wanted to also comment, I really appreciate that observation. I think that's part of the challenge that we're facing, and it'll be the part of the challenge with the data call, because there's no way we can describe for you in these 45-minute presentations all that's going on. There are innumerable collaborations going on. And I think that the challenge is, and I've done this at the state level and the federal level, you're trying to sort of bring all these folks together, and that somehow that's going to magically allow some collaboration that's going to turn a key, and then things will now sort of miraculously happen. And that may not be to quite an extreme what you're all thinking and hoping for, but sometimes I think that is sort of what people are hoping for, because people do have to realize that each agency has a particular mission. They have a particular charge. It's why there are these agencies. And one could argue that maybe they may think there are too many agencies and too many sub-agencies within an agency. We could debate that, certainly. But I think that's part of the issue, is it's sort of like it is often when you sort of consolidate or you sort of spread and divide and conquer. We are always looking for means by which to collaborate, but you can't just get together and talk about your things. You've got to work on something together, because none of us have as many hours in the day to do that. So there's no conceivable way that every federal agency is going to know about every single thing that every other federal agency is doing. There is a Diabetes Mellitus Interagency Coordinating Committee, the DMICC. And that is one place in which people are supposed to be coming and are supposed to be sharing information with each other. And so I think it's a question, and that is managed by the NIH, so all the NIH institutes come, but it can be challenging for other organizations, and they usually pick a topic to talk about. That's where our Search for Diabetes in Youth project sort of emanated. That was sort of the germination for it. But that sort of ebbs and flows. So I just will say, not to be long-winded and hog up any more time, but I think we just have to think carefully about recommendations and what we mean by sort of wanting the agencies to somehow coordinate more together. It's like be more efficient. What does that actually mean? And what are we going to get out of it? Because otherwise you'll end up with some sort of directive to coordinate, and then people will hold more meetings and will have less time to get important work done.
I wanted to circle back to Bill Chung as well to see if from the FDA perspective you wanted to say anything about food labeling, and certainly to be sure that it gets into the data call.
So I'm by no means an expert on food and drug law. I'm on food law. But if you have a specific food-related question, I can definitely help facilitate identifying someone within the agency who might be able to address that question.
Were there specific questions we had then for FDA about labeling? Who was it? Who? Yeah. 2 minutes.
Sure. I think it's the status of the. I have the name of the actual initiative. You know it better than I do. What the status is of implementation of the new food labeling system, and any evaluation that can be done into its efficacy of comparative, comparing different ways of labeling products, with consumers being the end user, and the degree to which the labeling system could maximize its ability to enable people to prevent diabetes.
So I think there are a couple of things in terms of the labeling. I don't mean to jump.
Yeah, thanks for. I'm not an expert on it, so.
Been here for 32 years, so I've had some activities in this. So there's the nutrition label that is new, that has just come out and been released and is now going to be on products at the FDA.
Is this the nutrition facts?
That's the nutrition facts label, which now includes added sugars, and so there's some other things in there. That took probably 10 to 15 years to get finally out there and done. It doesn't happen that easily. But I think what you're talking about is front of label.
Front of label packaging, right.
Where there's claims made, and there's some countries, I believe England has the stoplight where it's red, green, and yellow in terms of that, and we haven't fully established one here for the FDA, for the USD. But I think it would be of value to hear from the FDA on that, because they can tell you it's not as simple a process as one would think to come up with these various things. There's the rack, which has to be considered, which is the routinely consumed, the amount consumed in which makes up a portion size that then goes into the label. I mean, there's so many things that are involved with it that I think it would be of value to hear from FDA folks in terms of the foods and have them talk to you about these various different things, because it's a very long process to get a lot of this stuff done. So I think it would be of value.
Mm-hmm.
And I know Anne's not here, and this is a little bit in response to her Ann Albright's comment, but I think that I think it will be valuable to hear both from the Office of Minority Health and then also anyone sitting on that diabetes interagency committee, I think, to just hear how that could be made more fruitful. And it sounds like you've thought of some things like having PHS within HUD, that there may be some other really interesting and great approaches that have worked well, and as opposed to just setting up different meetings. So I think we as a commission could certainly make recommendations, not just on having an agency that coordinates, but how best to do that. And are there some best practices that have worked well in the past, or are there innovative, future forward-thinking kinds of things that could be proposed? So I don't know that we want to just specify something very vague in general, but something that could be useful, or at least comment on. So, and I'm assuming folks in the room here will have some thoughts about that.
I'd like to propose that we take a 15-minute break now. We have public comments scheduled for 2:45, so if you can be back in 12 minutes. Good. I'd like to call us back to order in a minute or two. We do have public comment, so if you all can take your seats again. Good. Today we're fortunate to have Hannah Martin from the Academy of Nutrition and Dietetics to speak to the National Clinical Care Commission. And Hannah, welcome. Thank you for being here.
Didn't realize I was going to be at the dais. Good afternoon. I'm Hannah Martin. I'm a director of Legislative and Government Affairs at the Academy of Nutrition and Dietetics, and my organization is a member of the Diabetes Advocacy Alliance. And today I'm speaking on behalf of the DAA specifically. Members of the DAA, led by the American Association of Clinical Endocrinologists, actually worked for many years to rally support among members of Congress for the establishment of this commission. And we believe really strongly in the value and the mission of the work that you're doing. And we are really looking forward to your recommendations at the end of your 3 years. As an alliance, we have focused on promoting and supporting federal policy and legislation in areas where we have common interests, and our work aligns well with your subcommittee 2 and subcommittee 3, prevention and targeted populations and treatment and complications. DAA member organizations, some of which I'm going to mention specifically by name later in my remarks, are very willing to share their expertise. You all have brought in a lot of government speakers, and I'm here just to give you a sample of some of the outside of government speakers that could be brought in. It seems like you've already started some of those conversations, which is really great to see. So under Subcommittee 2, Prevention and Targeted Populations, we would welcome an opportunity to provide perspectives on how current policies are impacting diabetes screening and prevention of type 2 diabetes among people with prediabetes. So for example, one of our members, the YMCA of the USA, could address how it's innovating to improve recruitment, retention, and referral of patients to its CDC-recognized diabetes prevention program. They participate both in the Medicare Diabetes Prevention Program and in private sector DPP. Amada Health, also a member, could demonstrate its innovative evidence-based virtual diabetes prevention program and explain why it's imperative for CMS to increase beneficiary access by expanding coverage to include virtual CDC-recognized programs, whereas right now Medicare will only reimburse for in-person CDC-recognized programs. My organization, the Academy of Nutrition and Dietetics, would be happy to talk to you about the fact that Medicare covers medical nutrition therapy for people who have already received a diagnosis of diabetes, but does not cover the service for individuals who have been diagnosed with prediabetes. We'd be happy to present to the subcommittee or the full committee on the body of literature on the effectiveness of medical nutrition therapy for treating diabetes to prevent or delay the onset of type 2 diabetes. Related to Subcommittee 3, Treatment and Complications, we'd welcome an opportunity to brief you on how policies are impacting diabetes treatment and the prevention of complications and innovations that can improve healthcare delivery. For example, diabetes self-management training, or DSMT, is severely underutilized as a Medicare benefit, and the American Association of Diabetes Educators would be happy to provide you with a deep dive on how they think we could improve DSMT utilization, which is very important for people with diabetes and is already a covered Medicare benefit, importantly. The DAA is also concerned that CMS currently lacks some flexibility to cover innovative diabetes technologies, as well as approaches to diabetes prevention and self-management through reimbursed healthcare services. And the DAA feels the subcommittee members would benefit from a presentation on these topics as well. So in closing, thank you for considering the DA's comments and recommendations as the Commission continues its work. We stand ready to serve you as a resource for the Commission and to assist in providing policy, clinical, or practice expertise, as well as to help facilitate critically important recommendations for new strategies to the prevention, treatment, and care of people with or at risk of diabetes. Thank you.
Great. Thank you very much, Hannah. And actually, one of our next agenda items is going to be to address reaching out to a number of the stakeholders that you mentioned, but thanks for reminding us. At this point, Linda, that's all the public comment that we had for today, is that correct? So I wanted to go on to, let me see, do I have a minute? The subcommittees met yesterday, and there were some consensus items that I wanted to just summarize for everyone here today. This is the item for stakeholder engagement. We agreed that the subcommittees would begin to identify key stakeholder organizations and informants and develop core questions to ask them. The subcommittees will coordinate their lists to invite stakeholder informants to present to members of their subcommittees, and they should involve both a federal and at least a federal and a non-federal commission member. And we need to develop a Federal Register notice to request responses to the core questions from the public and to provide information about our virtual meeting on February 19th that's coming up. And as a homework item, we do need from everyone their input on the core questions that will be listed in the Federal Register as quickly as we can do that. We're going to circulate 4 items that we briefly discussed yesterday, but we'd like everyone to provide feedback on them so we can get that out in the next week or so. I also wanted to ask the subcommittee co-chairs to just give a brief update on where they are now. And we'll start, Anne is gone, but we'll ask Dean Schillinger to say something about prevention, general population.
Thank you. And just before I start, I just wanted to clear the record on an issue that came up before around federal standards for snack food at schools. I learned from the public presenter that there are federal standards that, if not adhered to, do jeopardize a school's ability to receive federal funding. It's the Smart Snacks standards that were presented earlier. And so I think our job is the devil is in the details. What do those standards actually say? And are they being implemented and upheld? With respect to our subcommittee, I can say that we concur with the plan to identify and invite key stakeholders to present to our subcommittee. I think it's an excellent process that was proposed. We also will work with the other subcommittee members to try to create the set of common core questions. And we will begin a targeted literature search to address the needs of the general population subcommittee and the questions that we have prioritized. And we will be meeting in mid-December as a group by teleconference to move forward.
Any comments from other members of the Prevention General Population Subcommittee? Great, thanks, Dean.
Thank you.
And Prevention Targeted Population, Anne or John?
The Prevention Targeted Population Subcommittee of the National Clinical Care Commission is focused on identification of people that are at high risk for developing type 2 diabetes and on implementing measures to delay and prevent the development of type 2 diabetes. We know that lifestyle intervention programs to delay or prevent diabetes are dose dependent. That is to say that the more sessions individuals participate in, the better the outcomes in terms of delaying or preventing diabetes. We also know there are still many people who are unaware of their risk for developing type 2 diabetes, and there are many people who know about their risk but have not entered a lifestyle intervention program proven to prevent or delay type 2 diabetes. There are also people who started but never completed the program, and those who completed a program but are unable to sustain the changes learned in the program. We need to understand how to better identify and inform people at risk for type 2 diabetes, how to better engage and retain individuals in proven lifestyle intervention programs, and how to maintain positive changes achieved in these programs. We hope to identify through literature searches, the data call, and stakeholder presentations the gaps in lifestyle interventions aimed at preventing type 2 diabetes. We also hope to identify the most successful type 2 diabetes prevention programs as well as alternate proven programs that might help those who are not ready for a full lifestyle prevention program. Other prevention tools that need to be considered in our deliberation are medications and bariatric surgery. We need to determine the best diabetes prevention medications, along with alternatives for those who can't tolerate the best medications. And we need to determine the current impact of bariatric surgery on type 2 diabetes and for whom it may be most effective.
Thanks, John. Any comments from other members of the subcommittee?
I would just add, and John had mentioned it earlier, we are definitely eager to have additional research and ways to prevent or delay type 1 diabetes. We really have no evidence to go on there, although things are being worked on. And also to be sure that we are better understanding maybe other means by which we could prevent diabetes that we don't even know about yet. So I think that form of research would be beneficial, and we would look to support that in both our interviews and our literature search, and hopefully comments we're getting from people.
I've recently become aware of the literature on rotavirus vaccination and risk of type 1 diabetes. I think that's very exciting and something we maybe should look into as well. Other comments from
Are
the...
we, is the subcommittee is this more in general population or is it in this subcommittee? But I just bring up sort of prevention or delay of gestational diabetes as well. I don't know where that sits.
When we originally started our group, we were talking about all different I mean, there was diabetes that relates from other drugs, diabetes that can relate from pancreatitis, all sorts of celiac disease, all sorts of things came in. I think it's a really important point. I think one could look at that may be part of the general population. So you're trying to get certainly women who don't even have prediabetes yet, if they would benefit from what the general population, as they move into the risk category, or they maybe have had gestational before and they're pregnant again, they probably come into our category. Or certainly after pregnancy, we want them, since they're at such high risk for preventing type 2. But I'd say that group does touch in both categories as a high risk population, but also part of the general population before they get into high risk.
Other comments there? And then a report on treatment and complications from Paul and or Carol.
Okay, thank you. So treatment and complications is a very vast area. We've done a lot of work over the past few months, starting with our framing statement and then working with the grid to go very wide and broad and deep, and then continuously working from that to call out 3 main priority areas. We want to move the needle as much as we can in improving the care and reducing the harm for people with diabetes. And we think these 3 main areas, which overlap and are interrelated, will help us do that in the best way. The first is focusing on diabetes self-management, education, and support, that it's timely, adequate, and hopefully optimal. And this includes not just the access to and delivery, but the coverage of, and hopefully the content, meaning dealing with language literacy, numeracy, and framing of how that education, meaning providing strategies for prevention of complications. In addition, we want to look at models for delivering diabetes care more effectively and ensure that there's payment support for those models that are effective. And this is also overlaps with the first and the third priority areas, which is reducing health disparities and ensuring appropriate individualized care for people with diabetes. And this includes what Sherry was talking about, making sure the type of diabetes is appropriately diagnosed, access to critical medications and technologies, plus all the other disparities that we've been talking about today, and that also come into play by different comorbidities, different complications, matching the right care to what those patients need. So these are very broad areas, narrowed down from even broader. We've already started to formulate questions on how to address the 12 or 11 charter agencies that impact this, but we've started our literature search by coming up with search terms, and we'll do a search related to this and the evidence related to what is in the literature on this, and then we've started to pick outside stakeholders to talk to, many of which were mentioned today by our public comment. So I think that's okay.
Paul or anyone else comments on that? And I think that the treatment and complications subcommittee is furthest along in terms of their literature search. And I think they're going to be proceeding fairly expeditiously with that. I think for the other subcommittees, it would be worthwhile for them to touch base with the treatment and complications subcommittee to see exactly how they've put that together and get a report back in terms of how it's worked in terms of the yield. Carol? Paul, do you want to say anything more about the search or not?
I think we're just used to working together as a subcommittee, so it was just a group effort of coming up with terms and then refining the terms a little bit more. And we want to work with Clydette and Linda to kind of test how these terms are working and what we're getting back and whether we need to refine them even further. I hope that helps. But we pulled out terms from our priority areas that we thought would get us information on those priority areas.
Great, thank you. I think the next issue is really just to review the next steps, and I think our top priority now is to develop the questions for the Federal Register, and I'd ask Linda or Clydette to send out those draft questions as soon as they can, with about a 1-week turnaround for your comments. We'll try to finalize that and then get them to the Federal Register. We've also asked everyone to begin to identify key stakeholders and informants that they would like to reach out to inform their subcommittees. We'd ask you to come up with a tentative draft of those individuals and organizations, though, and send them to Linda or Clydette so that they can put them together and so that we can disambiguate or at least see who wants to speak to the same organization, so we can coordinate perhaps single calls of one or more subcommittees to deal with the key stakeholders. It sounds like each of the subcommittees is planning a meeting for December. Is that true? Is everyone planning that, or you guys as well? Okay. So again, I think I would ask you to send some target dates to Clydette and Linda to do a doodle poll or whatever to identify times for those calls to occur. The next meeting is going to be a virtual meeting, and it's scheduled, I believe, for February 19th. What I would propose, and I welcome any feedback or input, is that we try to finish up to the extent that we can our discussion of social determinants of health. And it sounds like we wanted some information from the Department of Labor, from communications, perhaps from the FCC, and with respect to the environment with a focus on clean water from the EPA. And then at the same time, I think at that meeting, we want to launch into the 3 topic areas that Carol outlined within the healthcare arena: self-management, education and support, care delivery models and payment, and reducing disparities in individualized care. It's a pretty ambitious agenda. We'll see what we can do on the social determinants of health, and I guess I would ask the Treatment and Complications Subcommittee then to begin drafting how they would like to approach the second half of the second 2/3 of the meeting, or whatever we have in terms of beginning to address those topics. Any
How long
comments?
is the meeting?
What's that?
How long is that meeting?
So what do we do for a virtual meeting? Is it only 3 hours?
Well, we may not have much time.
Yeah. We, whatever people think they can sit through, I think half a day would be fair game. Earlier on, I don't think we had as meaty an agenda. I think we have a lot of important topics to cover. So if people are willing to spend 4 hours, I think we could do 2 hours with a 15-minute break and another 2 hours. An afternoon meeting for our West Coast colleagues.
So maybe one of the things we can think about as a commission, I'd be curious to hear others' thoughts, is how we move along, and we may want to think about some of the one-on-one calls with other organizations, not just the external stakeholders, but the ones that we're doing some of the data call pieces with, because I think if we wait, however long to have these larger meetings to do these kinds of initial sort of presentations, it'll just take too long. So I'm just gonna. I know we've talked about external as opposed to the folks we're doing the data calls with, and I do recognize that there's some benefit in waiting for the data call results, but I think because of the way the data call is set up, I think it wouldn't hurt us to start potentially meeting with some of the folks that would have data calls as well. So I just throw that out there, and maybe that could be further discussed in our subcommittees too about the benefits of that approach, because it's also very hard to sit through and there's a lot of information that was covered today. And it for someone who just sat through that, it's hard. I feel like it's hard to synthesize all of that in your head and think about all the follow-up. So having some of these calls, I think, could be helpful also for just us, our brain power in shorter intervals as opposed to the long sprints.
So, I think the data call has now become sort of a little bit of detail about a lot of different programs. So I think its main utility is going to be to make us aware of programs that we know nothing about. I think if within federal agencies there are programs that we know are going to be germane to the work of the commission, I think it would be fair game to go out and reach out to them before the data call even comes back to get more information about those specific programs. But I'd like to hear from our federal agency partners to see if that would make sense to them. Any objections to that approach?
Question I have is it wouldn't be the full commission. So like some that we heard today would not be the full commission. So it is maybe more unparalleled, sure, as you were trying to describe what we're doing with the external stakeholders. So I think to the degree that there are only certain subcommittees who want to hear about, or all of them would have to be on, and at least some portion of the subcommittees would be on. I think that's the only question I would have is not everybody would necessarily be hearing from these other folks.
And there is a need to keep minutes of any of these meetings with key informants and to feed them back to the entire commission. But Anne, I think that's an excellent point, that if it would be of general interest to the entire membership, I think we maybe would want to do it as part of a larger group meeting. Barry, did you?
Yeah, I think the other aspect of this to maybe give some further thought to is what's the most efficient way to reach out to federal agencies, specifically around information about particular programs, or to respond to specific questions. And it may be that those are not most efficiently executed through a presentation, but through submission of a specific question or set of questions, and then a return of responses.
I have a comment. We're doing so much data collection and learning, and which is fantastic, and I think provides a lot of insight. I think one thing we might want to have on our radar or just be mindful of is our eventual objective is to provide recommendations. And as we are meeting in our subcommittees, I wonder if we shouldn't just start putting together a framework of what our recommendations might look like as we're learning, so that we don't come up on our third year and have to come up with recommendations. So perhaps we just need to be mindful of also making putting the framework for those recommendations kind of in this year too, as we're learning and getting the information.
Yeah, I think that's a great point, Jasmine. I think we should actually be keeping now within the subcommittees lists of draft or tentative or potential recommendations.
I had the same thought that I think thinking of sort of what our draft outline might be, and then obviously that can change and evolve as we hear from other folks, but I think having an initial one also will help us frame who we need to speak with first and what kinds of questions we want to ask to prioritize. So,
and Jasmine, it sounds like you've thought about this. Maybe you'd be happy to draft a template.
I do have thoughts, and I would be happy to draft a template.
Thank you.
One quick clarification question. In Bill reaching out to Carol and the treatment group, we've heard it was said today, primarily, if not exclusively today, from federal agencies that were not won't be part of the data call, et cetera. So in our next virtual meeting, what time we do have allotted for focusing on the healthcare part of our model, is it again primarily federal agencies that are doing work in the key areas that treatment and complications has identified, and or is it more other groups? Who might we be reaching out to for the humongous body of work that falls into, even just if you pick the three primary areas around self-management?
Well, one thought was that we do go ahead and have our presentation and questions with CMS as part of that, because that is a big part of what impacts all three areas. And a lot of the public comment from the last meeting revolve around CMS related issues. We've done enough investigation around diabetes self-management, education, and support to recognize that CMS payment policies around that impact federally qualified health centers, Indian Health Service, and the VA. So I think, if right at this moment, without us having another subcommittee meeting to discuss this, if I was going to pull up something just to say where we should start with the February, I would think it would be with CMS, as Clydette had recommended to me, possibly for this meeting. But, and I think we've already started to generate questions for the internal agencies, if we're going to call them that. So the federal agencies, we already have started our question list. And I think we could get that to CMS pretty quickly after our December subcommittee call, if that helps.
And it would seem to me the other groups that are part of the charter organizations that provide clinical care, so specifically IHS and VA and perhaps DOD, I don't remember if they're...
And we have started an internal list of stakeholders within certain areas, like people who are very knowledgeable around the payment for education within the VA, for the payment of education with Indian Health Service. It's not Anne. She's going to get me the right person. She's given me some names. So those may be calls that don't need to be shared with the full commission, is what I was thinking. But just to get a little bit more clarity around everything before we have our bigger call. Does that make sense?
Yeah. Thank you, Carol, and thank you, Bill. I had some preliminary discussions with Barry Marks, who's our CMS representative on the commission, about using either all or part of the February virtual meeting to discuss the payment issues. And maybe, Barry, you could just talk a little bit about sort of the two categories within CMS that might be of interest, policies and coverage.
I'm sorry, the two categories, meaning what?
I think you said there are two groups within CMS. One is...
I'm sorry.
Yes.
I think what we were talking about was that in determining who would be the appropriate subject matter experts to present to the commission, it would be extremely important to have a sense of what the issues are, what the questions are that the commission is seeking responses to. Because, for example, if the questions really are around how a particular benefit is provided, that would conceivably be one subject matter expert. If the question relates more to how decisions are made around issues of covered benefits, that might very well be a different subject matter expert. And what I want to be certain of is that we are being responsive to the needs of the commission. And the best way for us to be able to do that is to understand the question that the commission is putting to the agency.
So I hope you'll be available to help us sort that out. I mean, okay, thank you.
Just a thought in terms of planning that meeting, maybe a core group of people who are interested in this and who can help formulate the questions that Barry could take up, and then identify the appropriate people at CMS to speak to those might be one way of doing that.
We
Yeah.
started developing our questions already, and if we can meet in December, we can wrap those up. So
Excellent. I would
Okay.
welcome that. And if we
Okay.
need further discussion with Barry or CMS, we
And
can
we would
further
welcome
refine.
that. Thank you.
So just want to make another point, sort of a segue from what Sherry Boland was saying and also what Jasmine was talking about. It is not too early to be thinking about the final report. We're working internally right now to define major landmarks or deliverables within the remaining 2 years. We had developed a report outline when we were young and restless, so to speak, but didn't really know what this charge was fully about. Perhaps that could be circulated and people can start saying, all right, these are the key topic areas. These are the key areas that we want. It's a work in progress, but it's worth thinking how you might populate that outline. I think that will provide a structure and a sense of where we're going. Just something to think about.
Good. Any other thoughts about the next steps? Does that seem to cover everything? Good. Well, we'll have to figure out something to do for the next 40 minutes or so because we obviously can't adjourn until 4 o'clock. But
I'm here available to adjourn at any moment.
Any other parting comments before I pass it to Linda to adjourn us? Thank you, everybody. I think this has been a really productive meeting. I think the presenters were outstanding, and I think we've got a lot accomplished and have some new energy, which is great. I'll echo what Clydette said. We are 1/3 of the way through this process. And so the next year is going to be a lot of heavy lifting, but I think we can do it. So
We're adjourned.